before recurrence, this ctDNA can be measured in liquid biopsies. And in the future, we might be in a position that we can detect metastases before it becomes clinically or radiologically work. And that technology is really very impressive. When you look at, for example, the high sensitivity multi-mutation sequencing, what you can see is here on the red side, in the red line, when the circulating tumor DNA shows in the plasma, then these patients, very rapidly develop metastases. In the absence of such traces of tumor circulating DNA, you almost see no recurrence. So that's a promising technology. Let's see how it develops. We need to study this further, but maybe in a few years, we will use this in routine practice. Let's discuss a little bit about what defines increased risk. Clearly, and still, even in the era of molecular diagnosis and everything, nodal involvement defines risk. So 4+, that's always high risk. 1 to 3 nodes, that's one thing, but nodes is not the only thing. Let's not overlook the tumor size, tumors of 5 centimeters or more. And I'm afraid you might see more than I do in my practice in your region, or high-grade tumors are actually conveying increased risk, and particularly also long-term risk. In hormone receptor positive breast cancer, it's not only about the short-term risk of recurrence, it's about the long-term risk of recurrence, as we have discussed in the previous session. And let's look at this, like the risk of recurrence and tumor size. And when you look at T1 versus T2, you already see that all these curves, all these frequency curves of recurrence are increased in larger tumors. And the same is true for high-grade disease. I know that histology grade is considered to be variable, and there is some inter-observer variability among our pathologists. I'm in the very lucky situation that I have high-quality pathology in my center, but you can see that patients with a high-grade tumor almost look at twice the 20-year risk of relapse as compared to low-grade tumors. So that's also something that is important in our staging, in our assessment of risk, because particularly when you observe these patients long enough, you see that the proportion of presumably cured patients who eventually will not be cured but develop metastases, sometimes late in their patient journey, is substantial. And stage 2 is sometimes considered, intermediate, but there is, when you look at the figures here in the second line of this table, you see that yes, at 2 years, that's less than 10%. So you can say that's not significant. But when you look at 3 and 5 and 10 years, you see that depending on other risk factors, as we discussed, large tumor size, high grade, high proliferation measured by Ki-67, the substantial number of stage 2 patients in the adjuvant setting develop metastases over time. And that has been proven multiple times by real world data and in clinical trials. So the risk of distant recurrence, and that's what eventually kills our patients. I mean, I'm a surgeon by training, as you know, nobody loves a local relapse, but that's still curable disease. But if the patient shows up with lung or bone metastases, then obviously we cannot discuss cure any longer. Real world data indicate that even node-negative high-risk patients look at such a substantial risk. And you see this in these curves, that this is very comparable. It's the green dotted line, very comparable to the blue line of patients with 1 to 3 nodes. So nodes only is not the only indicator for escalation of treatment. And this is when the CDK4/6 inhibitors come into play. You know that these agents can counteract the activation of cyclin D1 and cyclin D2 and thus block the cell cycle. So I sometimes, when I talk to students, call them the stop signs in the cell traffic, in the proliferation traffic of the cells. And they have been defined as standard of care for metastatic breast cancer. You know, we have palbociclib, ribociclib, abemaciclib. It's not everything is available in every part of the world, but we have these large adjuvant trials, Pallas and Penelope B for Palbo, Monarch E for Abema, and Natalie for ribociclib. And you might know that I have been one of the global chairs of the Pallas trial. This turned out to be a negative trial, so palbociclib is not indicated in the adjuvant situation. And when we compare this data, it's important to remind ourselves that the absolute differences depend on the risk level of patients. When you look at the left side here and you look at the patient subgroup, let's say with a 50% theoretical patient subgroup, a 50% relapse risk, and we cut away half of that risk with the addition of a new treatment, then these patients will go up to 75%, resulting in a 25% absolute benefit. When we have the same benefit in a low risk group on the right side, 90% baseline risk, this means that we will cut away again half of the remaining risk, and these patients will look at the 95% prognosis, and the absolute benefit will be smaller. So comparing absolute benefits between trials, you need to be mindful that everything depends on the underlying risk, and these adjuvant CDK4/6 inhibitor trials have quite differing underlying risk, as you can see in this slide. As a matter of fact, Penelope B has the worst risk patients included, then Monarch E, then Natalie, by the inclusion of higher risk node negative patients, and Pallas the lowest situation. As said, the two palbociclib trials were negative, so palbociclib is not indicated in the adjuvant treatment. However, we have Monarch E and Natalie. Both trials have been positive. Monarch E for high-risk patients only, not positive patients, and Natalie including stage 2 patients, which I think is important because it broadens the potential target population. I know that Abema is not available for the majority of your patients, but still also for balance, I'm reviewing these slides. So that's Abema versus endocrine backbone treatment only. And this is the most recent result. You see there is about 7.4% difference at 5 years here in the Kaplan-Meier curves. So that's an effective treatment, and abemaciclib has, based on that, also been licensed by the FDA and in Europe and in many parts of the world. Now, Natalie is slightly different in a number of respects. Number one, and most importantly, it also involves node negative patients, patients with anatomical stage 2. And the second difference is that it was 3 years of treatment rather than 2 years, trying to address this long-term risk, increasing the treatment duration. Another important difference to Monarch E is that all patients in Natalie were treated with aromatase inhibitors. And that makes sense because if you say these patients are high risk or at least intermediate risk, then you should treat them with the optimal endocrine treatment. And as I have shown in the first part of my lecture, the aromatase inhibitor is superior to tamoxifen. And another important observation is that ribociclib in Natalie was used at a lower dose, 400 instead of 600 milligrams, compared to the advanced setting, which, as you will see, had a very beneficial effect on toxicity, particularly the rare but relevant cardiac toxicity. These are the results of Natalie in terms of IDFS, and you can see that, yes, this is a moderate benefit, but remember my hypothetical depiction here is cutting away 25% of the risk, so 1 out of 4 patients, will be without metastases when you add it to the backbone endocrine treatment, which eventually is quite significant. There have been all these updates from the first presentation. They are just confirming this. And this is now a 5% benefit at 4 years, roughly, for the addition of ribociclib as compared to aromatase inhibitors alone. And the good thing, what you can see here, is the treatment duration is 3 years, but the benefit persists. And when we discuss the long-term risk, as I did, then we need to see this type of, we call it a carryover effect, because it is reassuring to see that it's not the case that we stop the treatment and the benefit goes away, but the benefit persists. And the risk, as we know, in hormone receptor positive breast cancer also persists. Now, when we look at the subgroups, you see that essentially there is no difference. It's all subgroups benefiting in a similar manner, or let's say comparable manner. There is no specific subgroup that would not benefit from the addition of ribociclib to the endocrine treatment, which I think is reassuring. And what is also very important is because Natalie is unique in including also stage 2 patients, that the magnitude of the benefit apparently is the same in the subgroup of stage 2 patients in this trial. It's 2,000 stage 2 patients in here. And when you break this down to node negative patients, you see that, as a matter of fact, the Natalie investigators did a good job in selecting those node negative patients, because 87% 4-year risk of metastasis is something that is particularly significant. And it may not be the average node negative patients, but it is a wise selection of node negative patients with other increased risk factors, such as high proliferation, such as large tumor size, such as high-grade tumors. And this also translates into metastasis-free survival, as indicated by the distant disease-free survival on the left side. Still, there is no overall survival benefit. I mean, there's a trend here, but that's way too early. We need further updates and further follow-up of the Natalie trial in order to see this. There has been a recent update at the San Antonio Breast Cancer Conference a couple of months ago. And again, as you can see, there is a confirmation that the relative benefit in the node negative subgroup is, with a hazard ratio of 0.7, very similar to the node positive patients, 0.73 on your right side. And whether you look at any individual stages, there's no difference in the overall picture that this is a beneficial combination. Now let's address the safety issue. And I think what is very reassuring is that overall, yes, we know obviously with all CDK4/6 inhibitors, we face neutropenia. With ribociclib, we sometimes face transaminitis, and we face some liver-related adverse events, which in most cases by dose reduction can be managed very well, but we need to be aware of that. And when you look at the QTC prolongation, you see that it happens in around 5% of patients, but larger than grade 3 is 0.2%, which is significantly less than when you use 600 milligrams of ribo in the metastatic setting. So that is again summarized here. You see the pooled Mona Lisa data of all the metastatic Mona Lisa trials, and you see that the severe cardiac toxicity QTC prolongation here was 1.2%, and that is reduced to 0.2%, which is really almost negligible. We still have to be watchful, particularly also for co-medication of our patients, but in daily practice, with the dose reduction, this is not really an issue any longer when you use adjuvant ribociclib. It's also depicted here in the quality of life analysis. As you can see, over a prolonged period of time, there's no difference whether you have the AI only. We know AIs have side effects. AIs have tolerability issues. Patients sometimes stop using them based on joint pain, on hot flushes, on all the endocrine side effects you're well aware of. But just by the addition of ribociclib, we are not massively deteriorating the quality of life. As a matter of fact, these curves are more or less superimposable. And I think that's very reassuring. And again, just reiterating that the node negative patient population benefits if they are wisely selected with increased risk factors as much as the node positive patients in here. What is also important, because yes, we might see some patients where we are forced to do dose reduction for neutropenia, or maybe for liver enzyme elevation. And I think it's very reassuring for us as clinicians to see that the dose reduction, if necessary, and as per the approval of the drug, does not take anything away from the efficacy, and the benefit for patients is maintained even when you are forced to do some dose reduction. I think this is very reassuring and was presented by Erica Hamilton at the last San Antonio meeting. Now, when you look in to the most updated guidelines, you see that this is NCCN that many colleagues around the world monitor. And you see that in their most recent update, consider ribociclib in eligible patients is a new addition to these guidelines. And obviously, if you have the in the other category of risk category, then there is also again abema or ribociclib for node positive patients in there. Now, when we look into the future, I think it's important that we also briefly discuss, what is next in these two pivotal trials. The vast majority of patients also received chemotherapy based on the risk assumption of risk that we had. And I think it's important to understand that we are trying to find out, maybe for those intermediate patients, it's good enough to add a CDK4/6 inhibitor, use ribociclib instead of chemotherapy, which obviously from a tolerability and quality of life aspect would be very beneficial. We have to wait for the data. ADAPT cycle by the West German Study Group is running. We'll probably report in a couple of years. But there is other projects starting now, trying to identify whether we can spare even more patients with hormone receptor positive breast cancer, the addition of adjuvant chemotherapy. We are discussing this around the world, and I'm grateful to many colleagues in many parts of the world from whom I learn a lot and from whom I'm always stimulated in my thinking. And together we have to keep learning, as we will also have to with additional endocrine interventions. I mean, I'm doing this since a number of decades, and like 10 years ago, people were saying that's it with the endocrine approach. We have tamoxifen, we have AIs, we have fulvestrant, but there is no further development. And now we have the CDK4/6 inhibitors. Now we see the SERDs coming. We see Protex, we see Serans, Sercas approaching clinical use and being already in clinical trials in large numbers. So I think we can be very optimistic that the endocrine treatment of hormone receptor positive breast cancer, which after all is the most prevalent subtype of breast cancer, will further develop and innovations will be there. I'm just showing you in closing what we are doing in terms of clinical trials. That's a neoadjuvant trial we are actually starting right now. It's using a SERD, elacestrant, together with ribociclib in an attempt to optimize the endocrine treatment for patients who previously would have received neoadjuvant chemotherapy because of large tumor size or other factors. So in summary, I would like to conclude the majority of all breast cancer patients is hormone receptor positive, and a sizable proportion of these patients remains at risk of relapse, particularly also of long-term relapse, indicated by tumor size, by nodal status, by high grade, by proliferation markers. For patients with increased risk, we should optimize the endocrine treatment. That means using an AI, using ovarian function suppression in the premenopausal setting. And with respect to CDK4/6 inhibitors, both Monarchy and Natalie have shown that the advances that we observe for these agents in the metastatic setting can be transferred to the early curative setting in the adjuvant use. And I think that's very reassuring. I hope this also will be acknowledged at the St. Gallen conference starting in 3 weeks in Vienna, where many people from around the world come together, and hopefully one or the other colleague from Jordan can also make the trip to Vienna. Thank you very much for your attention, and I'm happy to take questions if you have some.
Thank you, Dr. Gannon, for this excellent and informative talk. We have time for a couple of questions. Dr. Ahmed, please.
Thank you very much. Thank you, Professor Michael, for this comprehensive talk. My question regarding hormone positive, HER2 negative patient with oligometastasis who achieved complete response after neoadjuvant in the primary and the metastatic site. Do you recommend to maintain them on CDK plus aromatase or to keep CDK4 until disease progression?
Yeah, that's an excellent question. Because we have a tendency to treat oligometastatic disease as curable disease. So if we have a complete remission, I would probably continue following the principle of never change a winning team, and the de-escalation might be something for the future. So maybe if this patient is stable for 3 or 4 years, then obviously you might have to reconsider the situation.
Dr. Ayman. Can I add?
Dr. Abadir, please. Yes.
Thank you, doctor, for this excellent presentation. If you have a patient with node-negative disease and you did the oncotype test or the gene expression assay, and it turns to be negative or low risk, low risk, but you still have a high Ki-67 or grade 3, do you consider giving ribociclib for these patients? And a second question regarding
I'm sorry, the microphone is muted, so I could not hear the second question.
Okay. Any long-term toxicity if you give for the CDK4/6 inhibitors in your practice for the use
Yes.
of 3 years?
These are both excellent questions. To be honest, I'm not using oncotype a lot. I think that's not it's not necessary. We make our judgment based on traditional factors and on Ki-67. And if a patient is high grade and has a high Ki-67, I will definitely consider her for ribociclib, because in such a situation, I will probably not order a multigenomic test. To be honest, I save the money for more important things. For example, for treatment, try to stay away from spending thousands of euros or dollars for diagnosis when I need the resources for treating the patient. Second question, in my practice, I have obviously quite a number of patients on, who are on CDK4/6 inhibitors in a metastatic setting, sometimes for years. I have palbociclib patients 5 years out there, no dose-limiting toxicity, except obviously the neutropenia. With Abema, it's the diarrhea that is mainly the dose-limiting toxicity. However, most patients on Abema can be well treated with loperamide and other drugs, and once you manage that in the beginning of the adjuvant treatment, that's fine. Ribociclib usually is very well tolerated. I have seen a couple of patients where the liver enzyme elevation were actually a problem, one with pre-existing hepatitis and the other one spontaneously, and we had to dose reduce. And actually, in one patient, we even stopped the treatment because of this. Since the drug is just available in the early breast cancer setting, I cannot tell you like a 3 or 5 year information, to be honest, but that's my experience also from the metastatic setting.
Dr. Marwan, please.
Is there a role in the journey of giving CDK4/6 inhibitors of following minimal residual disease in the blood, like doing circulating tumor DNA, quantitative, and follow them up? Have you ever had this experience?
We are using circulating tumor DNA only in research projects at the moment. We are not routinely using that because nobody knows what to do and what it really means. Because first, we have to establish the technology. Second, we will have to prove that, for example, an early intervention is actually helpful. If we know like a year before metastasis breaks out, if we intervene, is that helpful? That's something that needs to be tested in clinical trials. We are using the technology in clinical trials. I'm currently not using it in clinical practice.
Any further questions from the audience? I would like to ask Dr. Ganant, do you foresee any role for the CDK4/6 inhibitors in adjuvant setting for those with low-risk breast cancer in the future, as we're talking about targeted therapy, tolerable treatment? So do you think in the future may we use the CDK4/6 inhibitors in the adjuvant setting for low-risk patient?
I think for low-risk patients, no. To be honest, low-risk patients are well treated with the standard endocrine treatment. We know the toxicity. This might change. We might develop SERDs in that setting because we know that they are better tolerated than, for example, aromatase inhibitors. They don't have the joint pain. They don't have hot flushes. They have other issues. But the backbone of endocrine treatment might change in coming years. But that's 3-4 years from now. We will see the results from trials such as EMBER-4, such as the Cambria 1 and Cambria 2 trial with camizestrant, the elacestrant trial with all. So that's going to be the backbone for low risk, if anything. I don't foresee the addition of CDK4/6 inhibitors for low risk patients, except maybe in the neoadjuvant setting. That's something that for a short course, let's say a large tumor, low proliferation, adding a CDK4/6 inhibitor to neoadjuvant endocrine treatment, that is also something we are exploring in the research setting. But in the adjuvant setting, I think it will be the high risk and the intermediate risk patients.
Okay. Dr. Mohsen from Egypt, he want to ask. Dr. Mohsen, please. Please unmute Mohsen. Dr. Mohsen, you are muted already. It seems from your side, we are unmuted you. From our side, you have access to. Could you please do refresh to your screen or?
دكتور محسن، اذا في مجال تطلع وترجع تدخل كمان مره كانه عندك مشكله، لانه احنا معطينا كل البريفليجز كلها على الاطلاق يعني. المفروض طبعا هو عنده مشكله ما بنقدر نتحكم فيها احنا دكتوره، يعني احنا معطينا كل البريفليج، كل شيء ماخذه هو.
Okay, finally, I have to thank you again, Dr. Ganant, and we hope to see you next time in person. And now it's time to move to the second session. Thank you. Thank you.
Thank you very much. I hope to be able to join you in person, inshallah. Thank you.
Inshallah. Yes.
قولي متى نبلش. نبلش. يا الله. Good evening, everybody. The next talk will be presented by Professor Mohsen Mukhtar. Professor Mohsen is a clinical oncology. He is a professor of clinical oncology at the Cairo University, Qasr Al Aini Medical School in Egypt. Was the managing director of Qasr Al Aini Oncology Unit from 2018 to 2023, with collaboration in several regional and international trials, with interest in lung, breast, and gynecological malignancies, having published more than 70 publications on these topics in regional and international medical journals, with a passion in education to improve oncology care in the Middle East and Africa, dedicating himself to this cause. The founding president of Cancer Vive, an NGO for cancer patient support, which aims to improve the knowledge and treatment options of patients throughout Egypt and Middle East. He is a member of ASCO, ISMO, and EMAC. Professor Mohsen will talk about redefining survival expectations in early triple-negative breast cancer. Welcome, Professor Mohsen.
Thank you very much. It's a pleasure to be with you. Can you see my screen and hear me well?
Yes.
Okay. So it's always a pleasure to be amongst our Jordanian colleagues. Allah ya'tikum al-afia, and it's always a pleasure, and I'd like to thank you for inviting me and allowing me to speak in your conference. As said, Mr. Chairman, my topic is on redefining survival expectations in early triple-negative breast cancer patients. To start off with, as always, we always try off things in the metastatic setting, and checkpoint inhibitors were no different. And the first data that we had, and probably the strongest data we have in the metastatic setting, comes from the KEYNOTE-355. This was a trial of first-line pembrolizumab added onto chemotherapy in triple-negative metastatic breast cancer patients who were either de novo metastatic or had a recurrence more than 6 months after the completion of curative intent, or had local recurrence that was inoperable. And they were allowed to receive pembro plus several options of chemotherapy, whether it was nab-paclitaxel, or gem plus carbo, versus that without that combination without the pembrolizumab. And what we found from this data is that if you look at the overall survival in these patients, there was a benefit for overall survival in patients that had a combined positive score more than 10, that meaning that their PD-L1 combined positive score was more than 10. Obviously, the higher the combined positive score, the more benefit you're going to see. But in the end, what we can see is that patients with that combined positive score more than 10 had a benefit. And that's why when we look at the guidelines today in something like the NCCN, we'll see that for patients with a PD-L1 combined positive score more than 10, regardless of their BRCA mutation, and this is going to come in importantly when we talk about on the early setting, pembro plus chemo is your preferred category. Now, if the patient didn't have a positive score more than 10 and was BRCA mutated, then you could shift to the PARP inhibitors. But we are focusing on the early setting. So when I get a patient in front of me, and I think when any MDT gets a patient in front of them that has a tumor that is more than 2 centimeters and is triple-negative breast cancer, the questions that we ask and we sort of interact with the patient is, do we need to start neoadjuvant or should I go on for surgery? Do I need to do genomic profiling for this patient, such as a BRCA or maybe a CPS score? This patient, if she's going to receive immunotherapy, will she require precautions in surgery? If this patient is BRCA positive, would I add on a PARP inhibitor for this patient? And ultimately, what is the cost impact of adding that checkpoint inhibitor, whether in terms of toxicity or financial burden? So coming to the first question, how would you start off this patient with a tumor that is more than T2, surgery versus neoadjuvant? And I think all the guidelines, and for quite some time now, have recommended neoadjuvant therapy for these high-risk patients that are anything more than a T2, whether they are HER2 positive or triple-negative breast cancer patients specifically. And we'll see that this is all guidelines, NCCN, AGO, the ESMO, as well as in the St. Gallen consensus, and have been there for many years. So to improve the outcome in those patients with the neoadjuvant therapy, several things are being tested. Namely, ADCs are being tested, androgen receptors, PI3, AKT, mTOR, PARP inhibitors are being tested, all of these in the triple negative. But till date, the only ones that have been approved in that neoadjuvant setting are the checkpoint inhibitors. Now, Why are checkpoint inhibitors really specific for this? Because we know there's more tumor infiltrating lymphocytes in triple-negative breast cancer patients. We know that there's more higher tumor mutational burden. And we've seen from phase 2 data coming out from two very key trials, the I-SPY trial and the Keynote 173 data on patients in the combination of chemo plus pembrolizumab to the standard neoadjuvant therapy, we see PCR rates exceeding 60%. And if you compare that in the I-SPY trial with patients receiving only chemotherapy as compared to pembro plus chemotherapy, we see that this PCR rate has actually nearly tripled, going up from around 24% up to 60% in a combination when we add on the pembrolizumab for that. So what's the importance of PCR? We know that PCR is a surrogate marker. Now, the achievement of PCR in general has shown to improve event-free survival and overall survival, specifically in triple-negative breast cancer, where it improved survival outcome, and that lack of PCR is always associated with a higher risk of relapse, as well as a reduced disease-free survival, especially in the basal-like triple-negative breast cancer patients. Now, in order to increase the PCR, chemotherapy, what chemotherapy combination do you need to use? Now, we've had questions on the addition of platinum-based therapy for these patients that are triple-negative. We had conflicting sort of data coming out of the JEPA-6-2 as well as the CALGB trials, where one showed there was a significance, the other showed there was no significance in terms of event-free survival. However, if we look at the PCR rate from these two trials, they obviously added on in terms of PCR with the carboplatin. Finally, Brightness trial came on in with the use of carbopaclitaxel, followed by an AC for these patients. And what we can see is that the PCR rate increased from 31% to 58%. And the 4.5-year event-free survival hazard ratio was 0.57, with an absolute increase of around 11% in terms of event-free survival. And this is the essence that we could argue on today, that probably all oncologists treating breast cancer with triple-negative breast cancer would add on platinum in the neoadjuvant setting for their patients. Now, that's really important because if we look at the data from the Keynote 522, this trial was exactly that. Patients newly diagnosed triple-negative breast cancer with a T1N positive node or a T2 tumor with any lymph nodes and above. And what they had in here in terms of chemotherapy was the carboplatin paclitaxel, followed by the doxorubicin or the EC regimen for 4 cycles. Carboplatin paclitaxel was allowed either weekly or every 3 weeks, with the addition of pembro to this population, with over 1,174 patients randomized 2-to-1 in this regimen. And then following surgery, pembro was added on for an adjuvant 27 weeks. So completing in essence 1 full year of pembrolizumab plus the neoadjuvant therapy. The stratification was according to the nodal status, the tumor size, as well as the carboplatin schedule. If we look at the baseline characteristics of this intent to treat population, what we see is that the majority of patients were T1, T2, 74% of the patients. However, we do have lymph node positivity in around 50+% of the patients. As I said, the primary endpoint was the PCR rate. And if we look at the PCR rate, we see an increase in total of a delta of around 14%, going up from 51% for the carbopaclitaxel AC arm to up to 65% just with the addition of pembrolizumab, a single agent for those neoadjuvant setting. Whether the patient was PD-L1 positive or PD-L1 negative, they seem to have a benefit. Now, you could argue that there was less PCR in PD-L1 negative, but look at the delta, you can see that the delta is actually higher even in PD-L1 negative. And that's why for today, we do not test patients for PD-L1 positivity prior to giving on neoadjuvant therapy for these patients. What about lymph node involvement? Again, lymph node negative and lymph node positive patients seem to benefit from the addition of pembrolizumab. They both had a PCR rate of around 65%, though you could argue that was higher in lymph node positive patients. I think somebody needs to mute their mic because it's interfering. I can hear you.
Okay.
The other important thing is exposure to chemotherapy, because we know that the more that we expose our patients to chemotherapy, the more likely they are to achieve a PCR. And I again want you to focus on the red bars here. When you look at the placebo arms with the chemotherapy, if your patient completed the full dose of chemotherapy, they have a PCR of 55%, compared to only 35% if your patient does not complete the chemotherapy. So it is very essential that your patient completes the full dose of chemotherapy. Now, does the addition of pembro hinder or jeopardize the full dose of chemotherapy? And the answer to that is no, because here the full dose of chemotherapy was given in 75% of the patients that were receiving pembro versus 79% of the patients that were not receiving pembro. But in essence, PCR rate in those patients who received the full dose of chemo plus pembro is approaching 70% for these patients. The important things that have come out from this, other than the PCR, because PCR is important, yes, but event-free survival is really important for the patients. Now we can see that we had several interim analyses, the latest of which is the interim analysis 4 and 6, and we can see that the hazard ratio still holds out at 60 months. You can see at 36 months, the hazard ratio 0.63, an absolute benefit of around 8%. And at 60 months, so that 5 years down the line, that hazard ratio is still 0.63, with an absolute benefit of around 9% for these patients, with 81% of the patients on the pembro arm having an event-free survival at 5 years. Remember, these are triple-negative breast cancer patients. That is, again, regardless of the initial stage, stage 2 or stage 3, hazard ratios 0.59 and 0.71 respectively. Regardless of the nodal status, node negative and node positive patients, hazard ratio 0.56 and 0.67 respectively. So it doesn't matter whether your patient is node positive or node negative, any patient beyond a T2 tumor seems to benefit in terms of event-free survival for the addition of pembrolizumab. Looking at that updated event-free survival, as I said here, 60 months, 9% absolute benefit with a hazard ratio, so an absolute risk reduction of around 35% in terms of event-free survival for the addition of pembro. And more recently, in the last ESMO, Peter Schmidt presented the overall survival data at 5 years. And what we can see that the hazard ratio 0.66 and with a benefit of 34%, that was statistically significant. And in terms of absolute benefit, 5% for these patients in terms of overall survival benefit. Is there a subgroup of patients that doesn't benefit? We can see that in terms of overall survival, all the subgroups of patients do benefit. You could argue more than age of 65, which is the lowest column here. But remember, these were a very small number of patients amounting for only less than 5% of the total population. There is a huge argument on whether or not to complete pembro after pathological complete response. And I want to take you directly to the hazard ratio for patients completing the PCR or achieving a PCR. The hazard ratio is 0.69, while the PCR for no, the hazard ratio for no PCR is 0.76. So again, like Professor Nan was saying, it always depends on where you started off with. But if you look at the PCR rate or the patients that achieve a PCR, the hazard ratio 0.69 means that completing and continuing with the pembro for that adjuvant 1 year has a risk reduction of around 31% for those patients, even for the patients that do achieve a PCR. Now, could we define more which patients do benefit? And this was data presented by Professor O'Shaughnessy in the last San Antonio. There was extensive biomarker analysis looking at tumor T cell infiltration or T cell inflammation, as well as tumor mutational burden, and looking as well as molecular subtypes and looking at the HRD subgroups. Now, if we look at this, all these subgroups, including the molecular subgroups, whether basal-like with immune activated or immune suppressed, the luminal androgen receptor or the mesenchymal, all the molecular subgroups benefited. The patients with the HRD subgroups, whether HRD negative or positive, all again had a benefit from the addition of pembro. Tumor mutational burden, again, the higher the tumor mutational burden, the better. But again, tumor mutational burden, high or low, did benefit from the addition of pembro. And the conclusion from this pre-specified exploratory analysis, which was trying to define which patients might not benefit from the addition of pembro, several of these biomarkers were prognostic for PCR and event-free survival, but did not predict the benefit from pembrolizumab. In terms of efficacy, subgroup analysis, tumor mutational burden, HRD status, as well as the patients with non-T cell inflamed signature, all these patients do benefit from the addition of pembrolizumab. And unfortunately, none of these biomarkers could define for you which patient to omit from that combination. There were other checkpoint inhibitors that were being tested. We have seen the JEPADUZ trial. This was with atezolizumab, same combination carbo, but here paclitaxel plus carboplatin followed by the EC, the 4-year event-free survival and overall survival with that addition of atezolizumab did not prove of any benefit. The CAM relief trial, again, that was presented in the last San Antonio, but this was just with nab-paclitaxel carboplatin plus pembrolizumab, showed a benefit in terms of PCR rates that were actually similar to those of the pembrolizumab. But if you look at the event-free survival, the hazard ratio is 0.80. So definitely less benefit than that of the pembrolizumab or the Keynote 522 trial. The JEPANEVO trial, this was sort of a unique trial in which they had, it was a phase 2 trial, 174 patients. They gave 1 dose of durvalumab, then they followed on by durva plus nab-paclitaxel, then durva plus EC, followed by surgery. There was no adjuvant setting for these patients. What they showed was that there is a benefit in terms of PCR as well as disease-free survival for the addition of that new adjuvant portion. Again, emphasizing that the need for giving a checkpoint inhibitor as early as possible, and especially in that new adjuvant setting in combination with chemotherapy. The ABRAVE trial sort of was on the other side, giving adjuvant avelumab for patients with a high-risk triple-negative breast cancer who did not achieve a PCR after new adjuvant or were going on straight for the adjuvant setting. Avelumab was given. However, if you look at the 3-year disease-free survival and overall survival, the hazard ratios are 0.8 and 0.6. Nothing was statistically significant in this trial. And again, this was a phase 3 trial, again, emphasizing the need for that new adjuvant setting of the checkpoint inhibitor with the chemotherapy. The second question, as I said, is when should I do a genomic testing for this patient? Especially specifically if you're talking about BRCA, it's definitely before surgery, because any surgeon will tell you that if this patient is BRCA positive, it will probably impact the extent of surgery for this patient, whether it is a total mastectomy or a bilateral simple mastectomy for these patients rather than doing a conservative surgery for these patients. The third question is, this patient, if she receives the combination with the keynote checkpoint inhibitor pembrolizumab plus the neoadjuvant setting, does she require precautions and surgery? And I'll take you directly to the immune-related adverse events of this. We know that there are higher rates of immune-related adverse events for patients receiving checkpoint inhibitors plus chemotherapy. This is specifically in the neoadjuvant setting rather than in the adjuvant phase. Remember to tell your surgeon and especially your anesthetist that this patient might have hypothyroidism, might have some sort of adrenocortical insufficiency. So please check these out before putting the patient to sleep under the anesthesia, because it could be worrisome for your anesthetist. Again, these are things that you need to be clear about with, especially in an MDT. The fourth question is, this patient is BRCA positive. Do you need to add on a PARP inhibitor? Now, as I said, several molecules are being tested out in triple-negative breast cancer. One of these molecules is the PARP inhibitor. The Olympia trial was a phase 3 trial for patients with high-risk breast cancer, whether hormone receptor positive or triple-negative breast cancer patients, after receiving adjuvant or neoadjuvant therapy, 6 cycles containing anthracyclines and taxanes. They were stratified according to prior chemotherapy, neoadjuvant versus adjuvant. In the triple-negative subgroup patients, they had patients who were prior neoadjuvant, no PCR, or received adjuvant that were node positive, or more than a T2. And they randomized these patients to receive olaparib for 1 year versus a placebo. And what they showed that there was a benefit for overall survival as well as disease-free survival in these patients. This is the latest data from the San Antonio. This was both ways in the hormone receptor positive and the triple-negative breast cancer patients. But if you've given neoadjuvant checkpoint inhibitor like the Keynote 522, and as I showed you, that is really important to achieve a PCR, because PCR is probably the highest surrogate marker for the overall survival data. Your patient would not fit into the Olympia data because this patient had received that checkpoint inhibitor before. So if you're looking for an algorithm for your patient with a triple-negative breast cancer patient that is more than a T2, this patient should receive neoadjuvant therapy. The neoadjuvant therapy standard today is with the incorporation of pembrolizumab, and whether or not your patient achieves a PCR, she should continue the pembrolizumab for 1 year. Now, if your patient had not been subjected to neoadjuvant therapy for any reason, or had just been subjected to chemo, she achieves a PCR, then observation. If it is a non-PCR, then capecitabine, or if she is not BRCA mutated. For a BRCA mutated patient, you've got the choice for the addition of a PARP inhibitor. Now, in the US, and several sites have been trying to incorporate that adjuvant setting, even if your patient has received pembrolizumab. If she does not achieve a PCR and she is non-BRCA mutated, you may think of adding capecitabine to the pembro, but this is outside of clinical data, and we do not have full clinical phase 3 data to support that. And if she's BRCA mutated, you could add olaparib to the pembrolizumab. We do have good data for the adverse events and how to manage the adverse events of either combination with capecitabine and pembro, or olaparib plus pembrolizumab. They seem to be quite safe, but again, this is outside of data that we have from phase 3 clinical data. So if my patient achieves a PCR, do I need to continue the adjuvant therapy? And the clear answer here is yes, because one of the things we know is that the addition of the pembro has increased that PCR. and we do not have a definition to which patient would really benefit from that PCR. We also know that if you look at the PCR, patients in the PCR data, still there is a hazard ratio that is even better than patients not achieving a PCR and have continued on their adjuvant setting with a hazard ratio of 0.69. So the full data supports continuing today that adjuvant part of the treatment. There are several ongoing trials that are addressing whether or not to stop the adjuvant checkpoint in portion of the Keynote 522 if your patient achieves a PCR. But till today, you need to continue that adjuvant portion of the Keynote 522. And if you look at the question of where has all this played, you'll see that the Keynote 522 is actually in the top 5 game changers in the neoadjuvant or adjuvant strategy, coming only second to tamoxifen, polychemotherapy, trastuzumab, and then you find pembrolizumab. Now, nobody would say I would not change my patient that did not achieve a PCR after receiving the combination pertuzumab, trastuzumab to TDM1. Yet here we have an absolute gain that is even higher than the Catherine trial. And again, we are still questioning whether or not this is a game changer. And I think if you're in the top 5, you probably are a definite game changer for these patients. Now, this comes at a cost. And is it cost effective? As I've shown you, in terms of toxicity profiling, obviously you do get slightly higher toxicity, but today I think we all know how to manage those immune-related adverse events. And the toxicity definitely goes down in terms of that adjuvant portion. The other question is cost in terms of financial toxicity. And I'll take you to this data that has come out of Egypt actually beginning of this year, and is cost effectiveness treatment for high risk early stage breast cancer patients, the analysis of neoadjuvant pembro plus chemotherapy followed by adjuvant single agent pembrolizumab. What they showed was that there was an expected gain of 2.9 life years, and in terms of QALYs or quality adjusted life years, a gain of 2.25, which showed a lower cost than the 2022 Egyptian cost-effective threshold. And in conclusion, in Egypt, pembro plus chemo followed by pembro is cost-effective treatment for high-risk early-stage triple-negative breast cancer when considering health-related quality of life and life years gained. So in essence, if it is cost-effective in Egypt, then it's probably cost-effective in a lot of other countries worldwide. So my closing remarks is that following the Keynote 522 overall survival data, and as I've shown you, this is probably in the top 5 game changers in breast cancer. In the new adjuvant and adjuvant setting, Keynote 522 is the standard of care for triple-negative breast cancer patients. And as I've shown you, it is a cost-benefit analysis conducted in Egypt has shown it to be cost-effective. And as I said, if it is cost-effective in Egypt, then it's probably cost-effective in the majority of countries worldwide. And with that, I'd like to thank you and wait for any of your questions.
And the floor is... Yes. Thank you, Professor Mukhtar, for this comprehensive and excellent talk. And the floor is now open for questions.
Thank you, Dr. Mukhtar, for this excellent presentation. I have a question. In the era of new nomination, HER2 low versus HER2 negative, do we have trial, or do you think that pembro will be more effective when we have HER2 negative or versus HER2 low? Or there is any studies addressing these issues? Because the Keynote trial was done before the era of the new classification.
Yes, you're absolutely right. but we do have data from the Keynote 355 on HER2 low and HER2 negative, and it doesn't seem to show a difference in terms of benefit from the addition of Pembro. That analysis was done on data coming out of 355, not from the Keynote 522. We still do not have data on that, but till date, I think again we need to take HER2 low with caution. There is no data on neoadjuvant and adjuvant ADCs like TDXD in these patients yet. We do have it in the metastatic setting, but even in the metastatic setting, you'll find that a patient with a CPS score more than 10, you would probably add immuno. Then in second line, even if she's HER2 low or HER2 low, then you'd add on the TDXD.
Dr. Marwan, please.
Thank you, Dr. In case of, in this scenario, PDL was 0, and you opted to do genomics, let's say NGS, and there was BRCA negative, and the NGS came back with, let's say, PIK3CA or AKT or all these mutations. Would you dare to give medications? Because, you know, your patient is not having anything to protect her. So would you dare to give PIK3 like alpelisib on its own, or capivasertib on its own, or?
Is this in the metastatic or the adjuvant?
No, adjuvant.
No, till today.
You just do NGS for BRCA only.
No, again, not yet. I would not add on something like that. There is some trials that are ongoing, but till today, no. I'd say, but
she's asking you for protection. She knows that her disease is really risky. Yeah. So yeah.
Yes, you're absolutely right. But till date, we don't have something that.
I know there are no data, but
no.
Okay, thank you.
Yes, please.
Yes, I would like to thank you. It's a comment really, rather than a real question. I would really like to thank you for showing us the cost effectiveness of using pembrolizumab in the adjuvant setting in Egypt. And I hope that would be inspiring to us here in Jordan to do such a study. I am aware that there might be a slight difference in the pricing here compared to Egypt. And I would like really to see how does it work here. Because for us, I would see it like if I want to give adjuvant pembrolizumab for a patient who has achieved a PCR, that would really literally means that I would not be able to use it for a patient in the new adjuvant setting. Maybe I cannot use it for 2 patients. If I save adjuvant for 1 patient, maybe I can use it for 2 patients in the new adjuvant setting. In that particular scenario, do you think it's reasonable to use capecitabine? Even you said that the data is immature.
So if a patient does not achieve a PCR.
Yeah, it does. If she achieves a PCR.
You want to omit the pembro and give capecitabine.
Would this be a reasonable or an alternative?
No, I don't think we don't have data for capecitabine at all for patients who achieve the PCR.
Achieve PCR, no need.
CREATE-X was for patients not achieving a PCR. Now, I fully agree with you that the pricing in Egypt might be different from the pricing in Jordan, but the GDP in Egypt compared to that of Jordan is much less. And when you're assessing cost effectiveness, you always take into consideration the GDP. So it's probably, as I said, it would probably be cost effective when you analyze it. Remember that these patients are only 15% of the patients in breast cancer. Now, if you're talking about something like the Natalie or the Monarch E, where you have 70% of the patients are hormone receptor positive, you could argue that giving this CDK4/6s for 3 years and 2 years is actually going to be more in terms of expense than something like Pembro. And remember, if you've given it for the neoadjuvant cycle, you're only going to give 7 or 8 cycles after after the surgery. So it's not 1 year, yani it's 1 year from the start.
Okay. Okay. Thank you, Professor Mohsen. Hope to see you next conference face to face in Jordan.
inshallah.
Thank you very much.
خير ورمضان كريم علينا
كل
جميعا.
عام وانتم بخير.
الله يخليك.
أشكرك.
Thank you very much.
Thank you.
Dr. Maria, are you online with us?
Yes, I am here.
Okay. So it's my great pleasure to present Dr. Maria Matthews. She is the head of myeloma and clinical trials unit at the hematology department and the professor of medicine at the University of Salamanca, Spain. She serves as a coordinator of a Spanish myeloma group with the direct involvement in the design and development of clinical trials. She has coordinated many clinical trials, especially in the setting of transplant ineligible and smoldering myeloma. And these trials have profoundly influenced current options for the treatment of these patients' population. She has published over 400 papers in international journals. She is also a member of International Myeloma Working Group, International Myeloma Society, IHA, and ASH. She has served on the ASH Scientific Committee on Plasma Cell Disease between 2015 and 2019. And on the EHA Scientific Program Committee and Advisory Board since 2013 until 2020, being chair of the Scientific Program Committee in 2019. She has been a counselor in the EHA board since 2015 for a 4-year mandate, and she is now a member of International Myeloma Society Executive Board, member of European School of Hematology Scientific Committee, and a member of the ASCO Scientific Program Committee. She received the Brian Dury Award in 2019, the Bart Balguri Award in 2022, recognizing excellence in myeloma research, and the Kyle Lifetime Achievement Award in 2023. She is the president of National Society of Hematology since October 2022 for a 4-year mandate. So, Dr. Maria, the talk is yours.
Okay, so first of all, thank you very much for the kind invitation, and I would like to acknowledge to Johnson & Johnson for organizing this satellite symposium in the setting of the Jordan Medical Society. And it is a great pleasure for me to share with you today this presentation, basically based on the management of the newly diagnosed patients with multiple myeloma. And today I would say that in 2025, if we talk about the new strategies for newly diagnosed myeloma patients, I think that we have to consider the immunotherapy as part of the first line of therapy. Here you can see my disclosures, and this slide maybe is quite common in all cancer presentations, because you know that avoiding the immune destruction is one of the hallmarks of cancer, and this concept is of course also applicable to patients with multiple myeloma. And indeed, in this slide, you can see different strategies that we are using right now as immunotherapeutic strategies to be used in multiple myeloma. And you can see how we can include the monoclonal antibodies, of course, the T-cell immunotherapy, but why not the hematopoietic cell transplantation? In terms of this immunotherapy, daratumumab, anti-CD38 naked monoclonal antibody, is one of the immunotherapeutic strategies that it is being used right now in the treatment of patients with multiple myeloma, and it is an important piece as part of the first line. Daratumumab, as you know, targets CD38, expressed on the surface of the plasma cells. And this means that we are going to see direct anti-tumor activity. But also, you know probably that CD38 is expressed in other cells like Brex, Tregs, myeloid-derived suppressor cells. And this means that we are going to see a depletion of these CD38 positive immunosuppressive cells, and at the end, what we are going to see is an increase in the CD8 positive cytotoxic T cells, as well as CD4 helper T cells that are going to contribute to killing myeloma cells. And this immunomodulatory effect is going to be responsible for deepened responses as well as durable responses. When we evaluate the guidelines for the management of newly diagnosed myeloma patients, here you can see the European guidelines. On the left-hand side of the slide are the guidelines published in 2017, and on the right-hand side, the guidelines published at the end of January 2021, and the main change implied the incorporation of the monoclonal antibody daratumumab to two important combinations in the transplant ineligible, Lendex and VMP, VTD in the transplant eligible population. But these guidelines are basically old, and today in 2025, new guidelines are going to be published very soon, in which you can see how in both transplant and eligible and transplant ineligible population, the monoclonal antibodies anti-CD38 are important players for all patients. The incorporation of these anti-CD38 monoclonal antibodies as part of the first line of therapy are going to contribute clearly to reach the main goal we have for newly diagnosed myeloma patients. And what would be this goal? Of course, to control the symptomatology, but maybe now we are in the right position in order to offer the cure to some newly diagnosed myeloma patients throughout the achievement of undetectable measurable residual disease. And the final and realistic objective today for newly diagnosed myeloma patients will be to try to offer them survival comparable to their life expectancy. And we have a minimal residual disease as maybe the most important prognostic factor predicting outcome in multiple myeloma, and this is minimal residual disease in the bone marrow, but we can incorporate PET-CT in order to evaluate the complete metabolic response. And if we combine minimal residual disease inside and outside of the bone marrow, we can actually reach excellent outcomes for those patients reaching complete metabolic response and minimal residual disease negative in the bone marrow. But we have, or we can potentially improve, and today you will see how in the majority of the clinical trials conducted in newly diagnosed myeloma patients, we move towards sensitivity levels of 10 to the minus 6, as well as the concept of sustained minimal residual disease negative over time. And with these two important informations, I think that we are going to see how we are in the right position in order to offer functional cure to some patients with newly diagnosed multiple myeloma. But also for doing this, and based on the attrition rate we see between the first and the second line of therapy, the second and the third one, and so on, this slide underscores the need to use the most optimal treatment regimes up front, because we are going to offer this to more patients and the benefit is going to be much more evident. How to proceed in front of newly diagnosed myeloma patients? Maybe we have, of course, to evaluate very well the disease, and we can characterize the disease as a standard or high risk. But maybe you agree with me that the first thing we do is to consider if the patient is eligible or not for autologous stem cell transplantation. For this eligibility, we consider not only the chronological age, but also the performance status, comorbidities, and why not the patient's preferences. If the patient is eligible for autologous stem cell transplantation, the most recent standard of care approved by the European Medicine Agency was daratumumab in combination with VRD, 4 induction cycles, followed by autologous stem cell transplantation, 2 consolidation cycles with the dara-VRD, and maintenance therapy with the daratumumab plus lenalidomide, with the possibility for stopping daratumumab if the minimal residual disease negative is sustained for at least 1 year and patients have had at least 2 years of treatment with the daratumumab. And this approval is based on the Perseus study, phase 3 clinical study, included more than 700 transplant-eligible newly diagnosed myeloma patients, VRD transplant VRD-LEN versus dara-VRD transplant dara-VRD, dara-LEN maintenance with the possibilities for stopping dara according to what I previously pointed out. And this is the primary endpoint, progression-free survival, and maybe this is the best PFS we've seen until now for newly diagnosed myeloma patients transplant eligible, and after a median follow-up of 4 years, 84% of the patients treated with dara-VRD remain alive and progression-free. This superiority in terms of PFS was basically sustained across the different subgroup of patients, including those patients with high-risk cytogenetic abnormalities. In terms of complete response rate or better, basically almost 90% of the patients in the dara arm achieved at least complete response, significantly superior in comparison with the control arm. But I previously alluded to the importance of the minimal residual disease negative, and post-consolidation, 57.5% of the patients treated in the dara arm achieved MRD negative, but overall the MRD negativity rate in the dara arm was 75.2%. These figures are significantly superior in comparison with VRD alone. Disease sensitivity 10 to the minus 5, but 10 to the minus 6 was also evaluated, and again, the magnitude of the benefit is very clear for the combination including daratumumab. In this slide, you can see how the minimal residual disease negativity rate evolved and increased over time, and overall, 75% of the patients treated in the dara arm achieved minimal residual disease negative. I alluded to the sustained minimal residual disease negative over time, and here you can see how 65 and 60% of the patients maintained the minimal residual disease negative for at least 1.5 years. And what is important, remember that it was possible to stop daratumumab, and in the Perseus study, approximately 65% of the patients stopped dara because they met the required criteria. This is extremely important because this means that if we use the Perseus, patients are not going to receive daratumumab forever, and it is possible to stop at 2 years in the majority of the patients. And here you can see the clear relationship between minimal residual disease negative, 10 to the minus 6, and outcomes. And the progression-free survival is excellent, with more than 95% of the patients alive and progression-free after a median follow-up of approximately 4 years. What about the safety profile? The use of dara-VRD as part of the induction as well as part of the consolidation resulted in a very good safety profile. And in comparison with the control arm VRD, we are going to see a slightly higher incidence of neutropenia, grade 3 and 4, no more peripheral neuropathy, and indeed the incidence is quite low, 4% grade 3 and 4, and only there is a slightly higher frequency for infections, but it's true that these infections resolved in the majority of the patients, and no more patients in the dara arm had to discontinue because of toxicity. In addition, the incorporation of daratumumab to the induction didn't impact in the stem cell collection, as well as autologous stem cell transplantation, and all patients engrafted without any problem. Together with the DARA-BRD that, as I previously said, it is already approved by the European Medicines Agency, there are other quadruplets available, but under investigation and not approved yet. This is the case of isatuximab in combination with bortezomib, lenalidomide, and dexamethasone, evaluated in this German study. And the primary endpoint, MRD negativity rate after induction, it was 50%, and after transplant, 66%, superior to the control arm, with benefit in progression-free survival in comparison with RVD without isatuximab. So this study is also positive, although it is true that the magnitude of the benefit seems to be better for the Perseus study, but you have to know that here patients after autologous stem cell transplantation, there was a second randomization to receive maintenance with Len alone versus isatuximab in combination with lenalidomide. In addition, the benefit, the superiority of ISA-RVD is basically sustained in the different subgroup of patients, although I would like to note how in patients with RISS3 or in patients with high-risk cytogenetic abnormalities, the benefit of the superiority is not so evident, especially as we had the opportunity to see in the Perseus study. A key question that we can plan now is about autologous stem cell transplantation. Today, transplant is a standard of care. And indeed, we have here this determination study confirming the role of autologous stem cell transplantation because it was superior to no transplant in terms of PFS, but no benefit in overall survival. In this study, as you probably know, the induction was not based on quadruplets, just bortezomib, lenalidomide, and dexamethasone. And based on this information, and basically based on this slide, we can see how the minimal residual disease negativity can potentially drive the transplant. And here we can see how patients who receive and patients who didn't receive autologous stem cell transplantation, if they had achieved minimal residual disease negative, the outcome was comparable. And this means that maybe in the future, after an optimal induction regime with quadruplets, if the patients are at a standard risk and they achieve the minimal residual disease negative, maybe transplant is not necessary. And this is going to be evaluated in this French study, ISA-KRD 6 cycles, and if the minimal residual disease is negative, patients are being randomized to receive a consolidation versus autologous stem cell transplantation. And we have just some preliminary data indicating that 63% of the patients after ISA-KRD achieved MRD negative and they were randomized to receive transplant versus no transplant. And to complement this study, the MASTER-2 conducted in the US is going to address more or less the same question. The induction therapy will be here DARA-BRD, MRD negative DARA-BRD versus autologous stem cell transplantation. And following with the novel immunotherapy approaches, you probably know the CARTITUDE-6 clinical study in which a transplant is going to be compared with the Thin-Tacel BCMA CAR-T after induction therapy with daratumumab, bortezomib, lenalidomide, and dexamethasone. So it is possible that in the future, not all patients will require from autologous stem cell transplantation. We have also some preliminary information about the bispecific monoclonal antibodies in the transplant-eligible population. This is the case for teclistamab in combination with the DARA or in combination with the DARA, bortezomib, and lenalidomide. I am not going to evaluate in detail this cohort of patients, but just to see how the majority of the patients responded. Basically, the MRD negativity rate after induction incorporating teclistamab to this standard of care was 100%, and we have to consider also the safety profile. If we have patients with high-risk features, should we treat equally to these patients? So I think that we move towards risk and response-adapted therapy. And today, maybe no significant changes can be done in patients with high-risk features compared with the standard risk. But here we can see the Perseus study in how patients with revised high-risk cytogenetic abnormalities clearly improved their outcome when they receive daratumumab added to VRD. And indeed, in the master and briefing study in which daratumumab was added to the standard of care, the poor prognosis for patients with just one high-risk cytogenetic abnormality was completely overcome because the outcomes were comparable to patients with no high-risk cytogenetic abnormalities. This is a more detailed analysis of the Perseus study, and according to the revised ISS, it is possible to see how patients with intermediate, high, and even high risk benefit from the quadruplet combination. For these patients with high-risk features, I think that a transplant continues being very relevant, as it was observed in the determination study as well as in the Forte study. And the key question is maybe about the need for tandem autologous stem cell transplantation. With the conventional agents, and this is present on the left-hand side of the slide, the answer was yes to tandem autologous stem cell transplantation. In the right-hand side of the slide, with the benefit we've seen in patients with just one high-risk cytogenetic abnormality, the answer is maybe this is not the case for patients with high risk if they receive quadruplets as part of the induction. And in terms of maintenance, I previously alluded to the role of daratumumab plus lenalidomide, and this is going to be the new standard of care because you can see how responses deepened over time. And after maintenance, overall, the complete response rate was almost 90%. This was previously observed in a previous slide, and 75% of the patients achieved MRD negative. And in order to complement the data reported in the Perseus study, we have the Auriga phase 3 study, dara-len versus len alone, as part of the maintenance therapy, and the primary endpoint was the MRD negativity conversion rate by 12 months. 50% of the patients reached MRD negative, and overall, the conversion rate was 60%, with this benefit in progression-free survival. But the bispecific monoclonal antibodies can be also used as part of the maintenance, maybe in the future, and in this safety running cohort study, teclistamab or teclistamab plus lenalidomide was evaluated as maintenance. If we evaluated the response post-autologous stem cell transplantation and the best response on maintenance with the teclistamab or teclistamab plus lenalidomide, the response is clearly improved. All patients are in minimal residual disease negative. We have other phase 3 clinical studies with teclistamab, and after the safety running cohort, patients are being randomized to receive tecalon or lenalidomide, another similar study with elranatamab. So this is basically the summary for the transplant-eligible population, and I would say that today the quadruplets combinations are the optimal choices. Dara-VRD is the new standard of care. ISA-VRD maybe will be also approved. Transplant continues being today's standard of care, and dara-len maintenance is the new standard of care for maintenance. And in the future, as I pointed out, CAR-Ts and bispecific monoclonal antibodies will be incorporated. And I would like to ask you this question: what would be the expected median PFS for a young, newly diagnosed myeloma patients treated with the Perseus scheme? 6-17 will never progress 9 years. Maybe we are going to see some patients that will never progress, but the median progression-free survival expected for this patient is 17 years. What it is completely unexpected and extremely optimistic and extremely good for newly diagnosed myeloma patients. Briefly, I am going to address the role of the transplant in eligible population, in which we moved to the incorporation also of anti-CD38 monoclonal antibodies, and the quadruplets are taking part of the first line of therapy today. VRD is maybe not an optimal standard of care for transplant ineligible anymore, basically because in spite of the superiority overall in the population older than 65, VRD showed not to be superior to Lendex alone because of a lot of toxicity. DARA BMP is standard of care, although it's true that it is not very commonly used. However, this is just a starting point, a proof of concept to see how when we add daratumumab to VMP, the progression-free survival significantly improved with a superiority also in terms of overall survival. And DARA Lendex is maybe the most common standard of care for the transplant ineligible population because of the superiority in overall response rate, 93%, 51% of complete response, 32% of MRD negativity rate, median progression-free survival longer than 5 years, and the median overall survival 90.3 months. So these data are maybe the best data we've seen for transplant ineligible population, and this is basically the standard of care we commonly used for all transplant ineligible population. Superiority across the different subgroup of patients, even in patients with high-risk cytogenetic abnormalities. Again, patients with just one high-risk cytogenetic abnormalities presented a similar outcome to patients with standard risk. And in the Maya study, the population, the median age was 73, and you can see how there is a great benefit in PFS for patients between 65 and 70, 70 and 75, overall younger than 75 years, and this benefit translated also in overall survival. But probably you know that the transplant ineligible population is quite heterogeneous. Frailty is important because frailty impacts on the overall survival with more power than chromosomal abnormalities or chronological age. And the key question is how to identify fit and frail patients. This is something that we are going to do throughout formal frailty scores or without any frailty score. But what we've seen is when we add daratumumab to either VMP or Lendex, we are going to significantly improve the outcome for patients fit, intermediate, but also for the frail population. As I previously pointed out, we move to frailty-adapted therapy. And for the frail patients, it is possible to optimize DARA-Lendex as the French group did in this study. They planned lenalidomide plus daratumumab, and dexamethasone was given only during the first 2 cycles, and patients didn't receive dexamethasone from the cycle number 3. The median age for these patients included in this study was 81. All patients were frail, and you can see here the progression-free survival, 53.4 months, closer to the 60 months reported in the Maya study, with an excellent toxicity profile. This means that it is possible to adapt, to adjust DARA-Lendex to the frail population in this way to convert DARA-Lendex in a safer and very effective combination for frail patients. And for the fit patients, you know that we are moving towards the use of the quadruplets combination, ISA-VRD versus VRD in the INROTH study, and the minimal residual disease negativity rate was almost 60% with a superiority in terms of progression-free survival. This is only for fit patients, and the same is applicable to the CEPHEUS study with DARA-VRD versus VRD. 60.9% of minimal residual disease negative, with significant benefit also in progression-free survival. And as expected, when we evaluated the outcome for those patients in minimal residual disease negative, the progression-free survival is outstanding. But new trials are coming, and for the fit population, the next step is to evaluate VRD followed by Lendex versus VRD followed by Filtafel. And this is going to be, this is being evaluated in the CARTITUDE-5, and we will have some data maybe very soon. We have also bispecific monoclonal antibodies in the fit transplant ineligible population, teclistamab, daralen, talquetamab, daralen, or daratumumab, lenalidomide, and dexamethasone. Elranatamab has also another study in this population, transplant ineligible, but also the bispecifics are going to be evaluated in the frail population. And this is an European myeloma network study in which frail patients are going to receive TEC-DARA or TAL-DARA fixed duration, 18 cycles, so patients will have a treatment-free interval with the possibility of restarted treatment at the moment of biochemical relapse. And this is the last slide, and in this case, for the transplant ineligible population, I think that the quadruplets are being the choice for the fit transplant ineligible population, but for the rest of the patients, DARA-Lendex continues being an excellent option with the possibility of modulating the dose of Len and Dex in order to convert the DARA-Lendex in a convenient and safe regime for the frail population. And I stop here. Thank you very much for your attention. And if you have any question, so it will be pleased to reply to your questions.
Thank you very much, Prof. Maria, for this excellent and informative presentation. And now time for questions. Okay, I can ask a question. We can see in most of the clinical trial that plasma cell leukemia patients were excluded. So what could be the standard of care for those poor outcome patients?
Yeah, thank you for the question. And it's true that the plasma cell leukemia are usually excluded from all clinical studies, although you have to know that some new clinical studies are going to be conducted in patients with plasma cell leukemia. And this is the case for CAR-Ts or even some BCMA bispecific monoclonal antibodies. But today, the standard of care for this population in our center include induction with the quadruplets, DARA-VRD, and if the response is optimal, so this is the only indication today in which we do autologous stem cell transplantation. If the patient is young and the patient has a donor, we continue with allogenic stem cell transplantation. This is our standard of care, but it's true that it is evolving, and maybe we are going to include our patients in clinical studies with either CAR-T or consolidation with bispecific monoclonal antibodies, and we hope these new approaches will significantly improve the outcome for patients with plasma cell leukemias. But today we do DARA-VRD, auto, allo if available and if have donor, and followed by maintenance, and if possible always maintenance based not only on lenalidomide plus PI until the approval of daratumumab and maybe daralen once daralen is approved.
Okay, there is another question from Dr. Mohammed Abedat. Do you recommend stem cell harvesting or collection for transplant in all patients or only in high-risk cases?
Well, this, of course, does depend of the store availability. So in our practice, we collect only for one single autologous stem cell transplantation and for 2 transplants only in patients with high risk. And I think that this is more and more the trend, basically because I put in a slide how the expected median progression-free survival with Perseus is going to be 17 years. So if we collect for 2 transplants, it is going to be unlikely to need the second autologous stem cell transplantation at the appropriate timing. And maybe more than 10 years, we do usually waste the stem cells collected. And based on this, I think that we are going to collect less and less for tandem autologous stem cell transplantation, and just with one is enough.
Okay. Also, we can see in different clinical trials that some of the clinical trial gave 4 induction cycles versus 6 induction cycle. So what could be the proper or the more used one or the recommended one?
Yeah, this is also a good question. And according to the Perseus study and according to the new phase 3 clinical studies, patients usually receive 4 induction cycles and 2 consolidations. I think that in the clinical practice, we can, and this is what we do evaluate the kinetic of the response. And if we consider that the patient is maybe in VGPR, but the patient is being very sensitive to the induction regime, we prefer to collect stem cells and to continue with the 2 additional cycles before going to autologous stem cell transplantation. By contrast, if the patient is already in complete response, I think that it is not necessary to go to 6 induction cycles. And the same is applicable to consolidation. If the patient after autologous stem cell transplantation would be already in minimal residual disease negative, we don't usually go to consolidation and we go directly to maintenance therapy. So from my point of view, the good situation would be to have a flexibility for using these 6 induction cycles, either 4+2 or 5 or 6 at the beginning transplant and no consolidation. And I think that this is the best approach in order to manage the patients in an optimal way.
Thank you very much. I think there is no more questions. Thank you again for you, and hope that we will see you face to face in the near future. Thank you.
Thank you. Thank you very much, and I hope you are enjoying your Congress.
Assalamu alaikum. It gives me a great pleasure to introduce our next speaker, Professor Michael Crumb. Professor Mike Crumb is a professor of medicine, and he is currently, he completed his postgraduate training in internal medicine and hematology at the University of Toronto, and he completed his fellowship in medical oncology and autologous stem cell transplantation at the University of Texas and Duke University in North Carolina. Dr. Crumb is currently a professor of medicine at the University of Toronto and attending physician in the Division of Medical Oncology and Hematology at Princess Margaret Hospital, University Health Network. He has served as a clinical director of the autologous stem cell transplant and the lymphoma site leader, and for longer than anyone cares to remember. He had a very good fortune to serve as a co-chair of Canadian Cancer Trial Group Hematology Committee and Lymphoma Working Group Chair from 2005 to 2018. Dr. Crumb's current research interest includes clinical and translational research in lymphoma, with a focus on development of novel therapies as well as late effects of treatment. He has been the principal investigator of numerous clinical trials in lymphoma and has authored and co-authored more than 200 peer-reviewed publications. Dr. Crumb, the floor is yours.
Thank you very much, Mohammed. I just want to make sure you can hear me and you can see slides in presentation mode.
We can see you, but we cannot see the slides and the presentation.
Sorry. Is that better?
We can see your slide.
Yeah. You can.
Yes, you can start.
Okay. Well, thank you to the organizers for inviting me to this very interesting conference. I'm really pleased to be able to participate, even though I'm 8 hours behind you in time and quite a lot of kilometers away. I used to treat breast cancer at the beginning of my career, so I was very interested to hear the what's new in breast cancer. So I chose my own topic. Mantle cell lymphoma is not a common lymphoma, as you all know, but it's there's been a lot of activity in this lymphoma, both in the front line and the relapse setting. And most of my talk is going to be focused on evolving therapies in the frontline setting, because I really think that's where the biggest impacts are going to be seen. So these are my conflicts of interest. I do have some research funding to the institution for clinical trials that I'm involved in, and I provide consultation to the drug approval system in our publicly funded healthcare system. So I'm going to review the current approach to primary therapy for mantle cell lymphoma for two reasons. One is that we may be discarding a treatment that's been around for a long time, and we have to think carefully about that. But also, I think to innovate, you have to understand what you're where you're starting from. I'm going to talk a little bit about identifying risk, because we speak a lot about high risk mantle cell lymphoma populations, and it's good to be able to identify those. The role of targeted therapies and how that's really changing quite quickly, and in particular incorporating BTK inhibitors into primary therapy. Maybe these strategies can either replace chemotherapy or stem cell transplant or both. So as you're aware, mantle cell lymphoma can be an aggressive B-cell lymphoma. There's really three types. The classical mantle cell lymphoma that has an aggressive course is associated with genomic instability, and at least in the pathology lab, commonly overexpresses SOX11. There's the leukemic non-nodal form, where patients often present simply with a leukocytosis and perhaps splenomegaly, and those are patients that often can be observed for years without any disease progression. And then the type that attracts a lot of our attention and has to be managed quickly, that is blastoid mantle cell lymphoma, which frequently can be confused with other high-grade lymphomas. It has almost always a TP53 mutation or other oncogenic abnormalities, and is really quite a formidable disease to try to control. So on that note, there are some key genetic abnormalities in mantle cell lymphoma, other than the defining translocation between
Dr. Kram, just you can press on share screen from the below bar, because we are only seeing the first slide only.
Oh. Apologies.
Share screen.
This is what I did before. Do you see my slides?
Yes, we see now the K genomic abnormalities in mantle cell lymphoma. You can continue manually. Yeah. Yes, from here, I think.
Sorry about that.
Michael, I think it needs to be in presentation mode before you share the screen. I think that's maybe what's happening.
Oh. It's hard to do because my screen is entirely taken up by the presentation mode. I didn't have an opportunity to practice, I'm sorry.
It's okay.
Victoria did this so neatly. Yeah. So I can when I put it in presentation mode, I can no longer see any of the features of your.
خلص عملت شير. We can't share it. This is difficult.
Yeah, you can just select each slide manually, Dr. Crum.
Yes. Is this big enough for you to see? I don't really want to present it this way, but. Can you see that?
Yes.
Yeah, we can see the slide, but if you want to change it from one to another, I think you may need to change it manually.
Did you see this? I'm sorry to be incompetent. Did you see this change just now?
It did not change. It's
Still genomic abnormalities.
yeah. We will share it from here.
Maybe. I'm really sorry. I'm not sure why it's not. I don't have any other options available to me.
Can you see the slides now, Dr. Crum?
Can you just let me continue to share? Maybe I've solved the problem.
Can you see the slide? The slide from our side, it is outlined, the first slide now.
Just a minute.
Okay.
No, I don't. Let me just try one more time, if you'll bear with me. Does it look like they are moving?
No, we can. It is not sharing completely. You can change the slides manually, Dr. Crum.
Well, that's what I'm trying to do. There's a button on the screen that is, when I'm moving the slides forward using this button in the web browser, in the WebEx. But you're not seeing it move?
Okay. Just manually, يعني هو بيمشي على slides slide by slide manually.
I don't.
Yeah, that's the slide now is changing.
Okay, so we will abandon presentation mode because it's not working any other way. You see it now?
Yeah, K genomic abnormalities in mantle cell lymphoma.
Okay. Well, I'm not sure why it's not allowing me to do full presentation mode, so I'm really sorry.
It's okay. No problem, Doctor.
Anyway, where were we? I've already used 10 of my minutes. So there are key genetic abnormalities other than the translocation that increases cyclin D1 expression and increases cell cycle progression in mantle cell lymphoma. It's been appreciated that early treatment failure is associated with the mutations listed on the slide in KMT2D, T53, and deletions of the retinoblastoma gene, P16 and T53. So in a study that was done by the European Mantle Cell Network, using patients enrolled on their clinical trials, about 80% of patients had at least one mutation in either blood or marrow that imparted a poor prognosis, such as ATM, TP53, and KTM2D. So these are quite common if you look for them, and may explain partially why the biology of mantle cell lymphoma is unfavorable. It's also appreciated that older patients have a greater degree of genomic instability. They more frequently have retinoblastoma, ATM, and cyclin gene deletions, as well as mutations and deletions in TP53. Oops. So despite all of that, how do things look? I hope you can see this okay. These are data from the province of Ontario that have been submitted for publication. This is work by Anka Prika, who you know, Mohammed, from our MCCs. The panel on the left shows overall survival in the patients that are considered eligible for stem cell transplant. Those are under the age of 70, generally using doxorubicin-based induction therapy, followed by stem cell transplant at about 2/3 of the patients. And those are the transplant outcomes in the middle panel. The outcomes in our province are not quite as good for patients over the age of 70. Predominant regimen there is bendamustine and rituximab, and pretty much everybody gets maintenance treatment. But you can see the age makes a very big difference in terms of overall survival, maximum about 40% depending on risk factors. So there have been a number of changes in treatment. I think that we would all agree have led to overall improvements in the outcome of patients with mantle cell lymphoma, taking it from a disease that had a median survival of about 3 years when it was first identified to the data that I just showed you. So those changes would included the addition of the CD20 antibody rituximab, as I already alluded to, high-dose therapy with stem cell support for those who have chemotherapy sensitive lymphoma, more effective induction regimens, adding cytarabine, especially high-dose cytarabine, is a more effective regimen, although probably a more toxic regimen than R-CHOP. Rituximab maintenance, both in the older patient population who are not candidates for a transplant, as well as in the transplant setting, has improved progression-free survival and quite probably overall survival. And we replaced older regimens that were based on fludarabine, which were toxic, associated with infections and maybe second malignancies, and replaced that with bendamustine. So just to speak to those adjustments and improvements in therapy, the University of Iowa Mayo Clinic consortium that has a prospective population-based database and outcomes exercise published this paper recently that compared what was going on in the previous era, in the first part of this millennium with regard to therapies, and contrasted that to more recent times, 2010 to 2015, as you see on this slide. And at least in both younger and older patients, things have changed. So as you can see from the slide, more reliance on the Nordic high-dose regimen. It includes cytarabine or the alternating R-CHOP and R-DHAP, less simple CHOP-like recipes, less hyper-CVAD, which has a lot of toxicity for even in the younger patient population, and more conformity around using rituximab and bendamustine in elderly patients who are not transplant candidates. So you can see the two curves purport to show that there's improvement. The blue curve is the more recent time period, same pathologists, same diagnosis, shorter follow-up, but you get the impression that perhaps some of these innovations really are improving survival and not just progression-free survival. Oops, sorry. So we talk about refinement of risk and tools that we can use, and my center doesn't do whole exome sequencing. We don't do NGS testing. We do look for p53 mutations, but there are simpler, more clinically applicable indices. So you're familiar with the Mantle Cell International Prognostic Index that uses age, LDH, white cell count, and stage to partition patients. And the addition of Ki67, something that all of our pathologists are now reporting, can really refine risk kind of at the bedside. You'll notice at the bottom, or I hope you might be able to see at the bottom, there's a website from the European Mantle Cell group, sorry. Goodness me. So you can plug the numbers into an app and figure out what the MIPI risk score is. These are in this particular analysis done by our European colleagues. These were from the mantle cell lymphoma younger and elderly trials. And you can see that it does separate patients into defined groups that have very different outcomes. The low risk patients have an excellent 5-year overall survival. The patients that have high risk disease based on their standard MIPI and a high Ki67, although it's a very small number of patients, have really poor outcomes. This is shown graphically on the slide for both the younger patients on the left and the older patients on the right, and the treatments received which are actually backwards. The younger patients received a stem cell transplant, the older patients received CHOP and FC. But this fairly simple prognosticator does hold up and is important for us when we're talking to patients, and it's really important for us in understanding the outcomes of new clinical trials and maybe even designing clinical trials. I'll talk more about that shortly. You can add that to that the expression or presence of a mutation in P53. This particular exercise by our European colleagues actually used protein expression with a threshold of over 50% as being higher risk. Usually that connotes TP53 mutation. But both in the younger patients and the older patients, it does add to the combined MIPI score and defines a very high-risk population. So the Kaplan-Meier curves at the top are for the younger, the MCL younger study patients who had analyzable tissues. Failure-free survival for the high-risk patients, despite intensive therapy, was only 1.1 years as opposed to 5.6 years for patients who lacked high-risk MIPI or P53 overexpression, and similarly for patients in the mantle cell elderly trial below. So these are ways that we can both understand the results of therapies, but also, I think, thoughtfully plan the next generation of trials. I'll come back to this, but we might be at a point where we could consider therapy minimization in some patients, depending based on these fairly available variables. So just to say that before we completely turn our backs on chemotherapy in mantle cell lymphoma, we're not really going to do that right away, but I feel like we're heading in that direction. There have been some successes. So you're aware of the LYM-3002 trial, which took out vincristine from R-CHOP and substituted bortezomib on the strength of numerous phase 2 studies that showed a response rate of about 40% in previously R-CHOP treated patients with mantle cell lymphoma. This study largely gets ignored, because for various reasons, but it's a large randomized trial that actually shows an overall survival improvement, which is quite uncommon in mantle cell lymphoma. The panel up on the upper right shows the overall survival with the long-term follow-up of this trial is 90 months versus 56 months for R-CHOP. The R-CHOP result, I think, is quite believable. So there's definitely improvement with a fairly simple, slightly more toxic regimen by adding bortezomib in its classical schedule. Below is the study that actually is a lot smaller. It's a subset of a larger study by the German low-grade lymphoma study group, as you recall. So these 100-odd patients changed therapy in my country because of a significant improvement in progression-free survival of just over a year. There's no difference in overall survival. This analysis wasn't really powered to look at that. So just something to consider when thinking about frontline therapy and the weight of evidence that might be supporting one regimen over another. The LYM-3002 study is more mature, has survival improvement, something to continue to consider. And we did observe successive maintenance therapy in the European Mantle Cell Network older trial. This was a study that had an induction question and a maintenance question. The induction question asked about fludarabine and cyclophosphamide versus CHOP, as I mentioned at the beginning of my talk, and then asked a question about continuous maintenance with therapy with rituximab versus interferon alpha, which was a drug that was featured in many low-grade lymphoma trials coming from Europe. So this is continuous dosing of rituximab. In our country, rituximab is given for 2 years. There are trials that have tested 3. As it turns out, most patients actually stopped shortly after the 2-year duration, but nonetheless, there was an improvement in overall survival with rituximab maintenance. So now we can safely say that it's worth it for patients, I think, to receive maintenance therapy, especially those who are not undergoing stem cell transplant. So a couple of slides about autologous stem cell transplant, something we've been doing at our center for about 25 years, and we're going to do a lot less of it. But so there is improvement in progression-free survival and now overall survival from this original German low-grade lymphoma study that randomized patients to receive interferon maintenance or stem cell transplant after induction with CHOP chemotherapy. So you can see at the bottom here that the median overall survival has finally been, or the follow-up is long enough to have a look at overall survival, and it's significantly longer in the patients who underwent autologous stem cell transplant with TBI and cyclophosphamide, a fairly simple regimen. The more modern approaches, which is the one that's taken at our hospital, comes from the mantle cell younger a trial that compared CHOP induction and the previous high dose therapy regimen of cyclophosphamide and total body radiation to a regimen that included high dose cytarabine both during induction, delivered via DHAP, and then coupled with high dose therapy, with the high dose therapy component, including melphalan and total body radiation. So you're quite familiar with these data. They've been updated with a median follow-up of more than 10 years. And although the separation of the survival curves on the right-hand side is modest, it does represent a statistically significant improvement in overall survival, certainly a fairly important duration of remission, improvement in time to treatment failure or progression-free survival. So these are the data that have been around for a while, and we're quite comfortable in talking to patients about the benefits. We're going to get to the part about how that conversation is going to change in the coming months to years with the data that I'm going to show you. So, I mean, at least right now, this is the treatment algorithm for, in many centers, it looks a lot like the ESMO guideline that was published in 2017. It's probably because it basically was copied from there, but in blue are the patient amongst patients who require therapy, patients that are fit for an autograft at our center, it's up to about age 70. Patients receive the standard, for now, induction therapy with our CHOP and our DHAP and the same high dose therapy regimen. We have a center, at our center, we can give total body radiation, and then they receive maintenance treatment. There are a number of patients who can be observed, such as the patients I talked about at the beginning, those with non-nodal presentations, but even some patients with nodal presentation. At the time that they're evaluated for treatment and not felt to be fit for transplant, then the discussion is about the patient's fitness for and the intensity of combination chemotherapy. We use VR, although I just said I'm a bit puzzled as to why we don't use VR cap a little bit more often. We rarely use RBAC, but it's on the list here because there are centers in Europe and perhaps you use this yourselves. If patients are not fit for full dose therapy, then dose reductions or dropping a day from the bendamustine recipe is a strategy. Our CVP is sometimes something we use, and maybe significantly dose reduced VR cap. Patients will receive, who are not fit for transplant, will generally receive maintenance rituximab in our center. But although I'm not going to go into a lot of detail about second-line therapy because of the breadth of the topic and the time that we have, it's clear to, I'm sure, to all of you that this is a game of somewhat diminishing returns. So these are data, recent data from the Swedish Cancer Registry that tracks both incidence and demographics of lymphomas in that country, but also tracks therapies and even duration of response. So these are data from the same time frame that we've been discussing so far, the early part of this millennium, with a median follow-up of 4 years. What the curves in the box on the right show you is that both overall survival for younger and older patients, and it clearly diminishes with each subsequent line of therapy. So at the bottom there's progression-free survival after first to fourth line therapy goes from 29 months down to 2.7 months. So while responses are sometimes easy to obtain in mantle cell lymphoma, historically durable responses are really what seems to be lacking. And I think our therapies need to be weighed by how long disease control lasts and not whether or not responses happen on an imaging test. So we're certainly, although we've made a lot of progress in frontline therapy, there's still a lot to be done once frontline therapy stops working, and perhaps that would be the topic for the next symposium. So it's pretty clear that we've been fortunate enough to witness improvement in outcome by the incorporation of BTK inhibitors into the mantle cell lymphoma arena, both in the relapse setting, but also increasingly, I think, in the upfront setting as well, as I'll show you. So these agents, ibrutinib and zanubrutinib, are approved in Canada. Acalabrutinib is about to be approved. All are available, at least in our publicly funded system. These are solidly, I would say, moving into second place outside of circumstances where patients might have had a very long remission after a transplant, and we might consider chemotherapy. Almost everybody gets a second-line BTK inhibitor now. And this is one of some of the data that would support that perhaps it's better to use these agents earlier. So these are from 3 early phase 2 studies of ibrutinib. In the relapse setting. They're all uncontrolled trials, and a comparison in the Kaplan-Meier curves on the right-hand side is just between the patients who received ibrutinib as second-line treatment versus those who had it for third or later lines of therapy. And what's interesting, given that there's a novel mechanism of action here, the inhibition of a protein that's central to B-cell receptor signaling, that's still in patients that are heavily pretreated with largely chemotherapy, would appear to have a lot more resistance, or at least much more transient benefits. So how does this mechanism of resistance evolve under the pressure of chemotherapy? I guess that's for something we can talk about in the question period, but for a thoughtful lab scientist to help us figure out. But I think these data would suggest that, at least in patients that are not having too early a treatment failure, that second-line therapy would seem to be the best way to use these agents. And of course, the data that I just showed you are still have their limitations. So BTK inhibitors are now looking for partners, and there are many ways to partner, both with CD20 antibodies, and what's increasingly being tested is the addition of the BCL2 inhibitor venetoclax. So these are data that have just been published this month in Lancet Oncology, a study called Simpatico, where patients with relapsed and refractory mantle cell lymphoma were randomized to placebo and ibrutinib or venetoclax and ibrutinib. 2 years of venetoclax at 400 milligrams daily and indefinite therapy with ibrutinib. And you can see the progression-free survival is significantly prolonged with this strategy, longer by nearly a year, going from 21 months to 32 months. The small plot in the upper corner suggests that although the follow-up of the study is quite long, it's more than 4 years, there's no difference in overall survival. But this is an example of how building better regimens that are based on targeted therapies is current great clinical interest, but also the focus of a lot of clinical trials that are ongoing. What was important about this trial is that there was a cohort of patients that was identified in the relapse setting as having a TP53 mutation, but also there was a cohort of previously untreated patients, just to explore what the response rate would be in that patient population. And what's highlighted in this slide is the performance of this regimen in patients with mutated versus wild type TP53. So progression-free survival, as I said, is really probably the most important thing to look at in a study of mantle cell lymphoma. 22 months for the patients with a mutation treated in frontline versus 21 months for patients treated in a second line or greater. That's not by any means a randomized comparison, but at least it tells us that there's the potential, or at least the expectation, that if this therapy moves into the front line, that we are still going to be facing a group of patients that are going to have fairly short remissions, even with modern novel combinations in the upfront setting. So if something works really well in the relapse setting, being the empiricists that we are, it makes sense to try to add BTK inhibitors to chemotherapy that's commonly used. There are a number of these trials going on. We have one in our center that's adding acalabrutinib to CHOP and try to replace transplant that way. This is the SHINE study, which was a randomized trial adding ibrutinib to bendamustine and rituximab, now a fairly common global regimen for mantle cell lymphoma. So patients were treated with with standard doses of both agents, treatment until progression with ibrutinib or placebo. The primary endpoint was investigator-assessed progression-free survival. And these data have been were published last year or 2 years ago, and certainly did show that there was a benefit to adding ibrutinib to bendamustine and rituximab in terms of progression-free survival, but unfortunately there was no difference in overall survival. So that 2-year difference in progression-free survival didn't translate into survival. There was some crossover in this, but I think the big concern was that this was in the older patient population. This is a study that enrolled patients over the age of 60 who are not felt to be candidates for a stem cell transplant, that it was really too toxic. And you can see on the bottom right that deaths from adverse events during treatment, which I think clinically feels like an uncommon event, happened about 10% of the time in patients receiving ibrutinib with BR as opposed to 6% of the time without. So at our center, we viewed these results with somewhat soberly, and it's not been adopted as a standard of care at my hospital, although it is possible to get access to ibrutinib for first-line therapy if one chooses. We think this is really just too toxic for general use. And this is shown on this slide. There was a lot of more infectious deaths, other things you might expect on the left-hand side, such as atrial fibrillation, skin rash, skin toxicities were a bit more common. That was to be expected, but really it was the infectious morbidity either related to COVID-19, which is shown in the box on the right, or other infections. So since we're always talking to all patients with cancer that's not curable about the balance between toxicity and efficacy, as I said, I think this regimen may leave something to be desired in terms of that balance. So this is sort of the replacement trial, ironically called ECHO, looking at the addition of acalabrutinib to bendamustine and rituximab versus placebo. And basically a similar patient population, not surprisingly, it's the same first author as well. So older patients previously untreated with good performance status were randomized to acalabrutinib in standard dose and bendamustine rituximab in standard doses. This study did specifically build crossover into the control arm. So if a patient had disease progression on placebo, they could, per protocol, be crossed over. Otherwise, acalabrutinib or placebo were continued until disease progression. And again, progression-free survival was the main endpoint, and that endpoint was met. There was a significant improvement in progression-free survival with the addition of acalabrutinib by about 17 months. A significant number of patients actually did cross over, which may be the reason why there is no difference in overall survival. But for now, this would seem to be a slightly more favorable way to add a BTK inhibitor. This is a summary of some of the adverse event data. You can see on the right-hand side that there were more infections still with this less permissive or promiscuous BTK inhibitor in terms of inhibiting important leukocyte enzymes. But so there were still a significant number of infections. And in both groups, there were a lot of patients that discontinued therapy because of toxicity. So fully 43% of the patients who received acalabrutinib had to stop because of an adverse event that was attributed to acalabrutinib. So may not have the mortality signal that ibrutinib had, but I still think it's a lot to try to add a BTK inhibitor to the BR backbone, and we have to be really careful in terms of dosing and monitoring and give some thoughtful advice about how to protect patients from infections. So I mentioned at the beginning that stem cell transplant in this disease has been around for a long time, and I think it could be argued that we are either going to try to improve the use of it or just replace it altogether. And I'll show you two studies that addressed those strategies. The study is called Triangle by the European Mantle Cell Network, has attracted a lot of attention. It's been presented at various meetings and recently published. in the Lancet by Martin Drayling. So this was a trial that had 3 arms. Arm A at the top is the standard of care at the time that the trial was designed, which is the same induction and high dose regimen that I showed you earlier for the mantle cell Younger trial. Maintenance therapy in arm A, which is the control arm, was optional depending on what the centers were doing. But in the 2 experimental arms, ibrutinib was added both during induction therapy as well as during maintenance, either with or without the rituximab. The key and most interesting, I guess, arm is the one at the bottom, arm I, which is ibrutinib alone, where stem cell transplant is for patients who are responding to therapy is actually not given. The patients simply move on after the induction phase to receive maintenance. Therapy is usually prescribed and then observed after that. So the first results that were presented were confirmed. There is improvement in progression-free survival if you compare standard transplant approach to adding ibrutinib to that approach in terms of failure-free survival. But interestingly, if you compare a standard transplant approach, that's the red curves in both of these figures, just ibrutinib alone seems to have been able to replace, so to speak, the need for high-dose therapy and stem cell support. So important, significant improvements in progression-free survival, including in patients that have unfavorable features. In this study, T53 derangements were assessed using immunohistochemistry. Our German colleagues have shown that this is a fairly reliable predictor of mutation. And in the high-risk patient population, stem cell transplant or this therapy seemed to actually be effective as well. So this is combining both of the results together. These data were just updated at the recent ASH meeting with a median follow-up of 53 months. And failure-free survival in both of the experimental arms is pretty similar. It's 86% and is superior to transplant alone without BTK inhibitor. This was not designed to be a non-inferiority study, so I think you could look at these data in 2 ways. You could feel that longer follow-up is needed to know whether the long-term outcomes of a strategy without a stem cell transplant hold, and I think that's a reasonably sensible way to look at it. We have 10-year follow-up, as I showed you earlier, with autologous stem cell transplant. We only have about 4-year follow-up from this trial, so a conservative person might wait. A person who wants to avoid toxicity might say, maybe we're ready to replace transplant with a BTK inhibitor, but that doesn't come without toxicity, and it certainly doesn't come without cost. So the other really interesting strategy to address the need for transplant was provided by our colleagues in the North American Lymphoma Intergroup. It's a bit beyond the scope of my talk to go into detail about MRD testing, but I'm sure you're aware that in many lymphomas, including mantle cell lymphoma, focus on MRD negativity as a response endpoint has been part of the clinical trials literature for some time. And I thought quite boldly the US Intergroup, using a proprietary peripheral blood MRD test that looks for a immunoglobulin rearrangement, designed this trial. This is done by the ECOG 4151. So the schema is in front of you. Patients are tested to make sure they have an identifiable marker. If they have a clonal marker identifiable, then after induction therapy by physician's choice, those who are MRD negative at a very low threshold, 1 in a million cells, less than 1 in a million cells, are randomized to either just carry on with maintenance therapy or go through an autologous stem cell transplant as per the standard of care. There are other cohorts and arms in this trial, but the data that were presented at the ASH meeting a couple of months ago kind of were the most provocative, and that is the randomization between arms A and B, that is patients with a deep MRD response randomized to a transplant as standard versus not. Quite a large study for mantle cell lymphoma, more than 500 patients. And this was considered to be a positive result of progression-free survival is pretty similar in between the two arms, and overall survival is also the same at 3 years, 82%. Patients who did not have a transplant could go on and receive a second-line transplant according to center preference. But these are provocative in two ways. One is that having excellent induction regimens that produce deep responses is still a focus and still can be optimized. And the second is we've been talking about MRD testing for a long time, but nobody's ever actually employed it, at least in mantle cell lymphoma, to try to direct therapy. So I think this was an important result, and we're going to hear more of it once the publication comes out. So can we replace chemotherapy, broadly speaking, in mantle cell lymphoma? You're probably aware that there's a number of trials that are actually testing this, comparing a BTK inhibitor, perhaps with an antibody, or with soon with venetoclax. This is a chemo-free frontline study that came from our colleagues in the UK and in the Nordic lymphoma study group. Patients over the age of 60 who are not felt to be transplant candidates were randomly assigned to receive ibrutinib and rituximab, or either R-CHOP or bendamustine rituximab, depending on center preference. All patients received rituximab maintenance in a standard dose and schedule, which was every 2 months for 2 years. And ibrutinib in the experimental arm was given until progression. So older patient population, much like you'd expect, a lot of high risk features, but decent follow-up, almost 4 years. And in that presentation at the ASH meeting in December, ibrutinib rituximab was superior in terms of progression-free survival compared to rituximab and chemotherapy, a difference of 23 months, which was statistically significant. And the hazard ratio seemed to be particularly favoring patients receiving R-CHOP. No difference in overall survival, but the data are still relatively immature for mantle cell lymphoma. But I think, this is definitely a sign that there are agents that could, at least in the front line, replace what we've been doing for many years and been frustrated at the limitations of those treatment strategies. So I'm a little bit over because of my 10 minutes of incompetence with the technology, but I'll close with these remarks. So first of all, we do have tools that are available to us to identify patients where there are still high-risk features and therapy minimization may not be the best strategy. Could there be, for example, that based on the triangle data, that patients who have a TP53 mutation or who have overexpression still receive a transplant? But I think these tools will allow us to do more risk-adapted trials, which is, I think, needed in all treatments of lymphoma, but in particular, and it may be the case with mantle cell lymphoma. MRD testing has finally been tested and shown its worth, and I think there's going to be more to be said about the ECOG trial once they're published. But again, reducing toxicity may be a strategy that MRD testing is going to allow, or shortening the duration of a BTK inhibitor, since right now a lot of BTK inhibitor therapies are until progression. Combining targeted therapies into frontline is challenging. Chemo-free and chemotherapy-free is not toxicity-free, but it might be superior. It'll be interesting to see whether venetoclax, BTK inhibitor combinations are better than chemotherapy. But I really do think, given what I've shown you is actually a fairly rich history for an uncommon lymphoma, that randomized trials have been the agents of change. I was watching with envy Dr. Mateo's talk about the many randomized trials in myeloma, but it's clear that we can do this in mantle cell lymphoma, and we must if we're going to make smart decisions, because the therapies that we're adding to these days, while they may be better than chemotherapy, they're a lot more expensive. I'm alluding to the inclusion of bispecific antibodies and CAR T-cell therapy, which come with considerations of access and affordability, especially in publicly funded healthcare systems. So again, I think this is a call for properly controlled clinical trials to help us define how to replace the things we've been giving for many years in the treatment of mantle cell lymphoma. I hope you could see my slides and hear me well, and I apologize for the technical hiccups, and I'm happy to entertain questions. Thank you again for the invitation and for listening. My greatest fear is that when I stop sharing, I find that you've all disappeared, but you're still there. If people are speaking, I cannot hear you.
Unmute. Dr. Kam, can you hear me?
I can hear you.
Yeah. Would you adopt the triangle protocol and to avoid transplant in patients with a high risk maybe score who were treated with ibrutinib in the front line?
We are starting to do that. So I think my answer to that is yes. We don't have approval in Canada for ibrutinib as part of upfront therapy. That's still being sorted out. We are able to get it from Janssen, but I would say, based on the triangle data, that's a reasonable thing to do. If you have actually, we are using. I'm treating one such patient now who he has other reasons why I think doing a transplant may be a challenge, but we're using the same backbone. We're not giving the Nordic regimen. It just has high dose cytarabine. We've been using the mantle cell network strategy with DHAP and watching people's renal function closely. But for some patients, especially older patients, we had hesitantly gone forward with stem cell transplant. I'm talking about people over the age of 65. We are now giving chemotherapy with a BTK inhibitor.
We have another question from Dr. Inas Abu Salim. Is there a benefit from adding ibrutinib to CAR-T for second-line treatment for mantle cell lymphoma?
I don't know. I mean, there are lots of data that suggests that ibrutinib, because of effect on some T cell kinases, may enhance T cell fitness and make the CAR T cells better. To my understanding, we just had a conversation because we just had our own cell therapy meeting a couple of weeks ago that this is largely in vitro data and retrospective. So we will continue a BTK inhibitor if it's safe to do so in a patient that's referred for it's actually third line CAR T therapy. So the approval in Canada is after a BTK failure. So we continue it until the lymphodepleting chemotherapy based on, I guess, expert opinion about what it does for T cells. Whether or not it works to continue it afterwards, I don't think anybody knows. That strikes me as being a perfectly good question for a clinical trial. So rather than adopting, I would say we should probably just be testing it.
So if you have CAR T cell therapy and ibrutinib, would you choose CAR T or ibrutinib or BTK?
So for second line, yeah, we don't have a choice. I think the data are mostly beyond, are mostly been in patients who've had at least 2 lines of therapy. I do have a CAR T cell slide which has the lysocell and brexucell data side by side, but so the way it's funded in my country, patients have to be previously treated with a BTK inhibitor, and it has to be for third line therapy because that's where the Zuma 2 data came from. So I think so to answer your question, I would certainly pick the BTK inhibitor if somebody had never had one, because it wasn't part of my talk, but the toxicity in our hands of brexucell in older patients with mantle cell lymphoma is substantial. The toxicity data for lysocell look a little bit better, as they do for other lymphomas as well. Definitely less neurological toxicity, which is a problem that seems to be worse with brexucell in older patients with mantle cell lymphoma. So much less ICANS and more manageable CRS. So I don't know that this product is going to be approved in Canada for mantle cell lymphoma. It's not going to be anytime soon. So for those reasons, even though BTK inhibitors are not free either, I would probably pick the BTK inhibitor.
Thank you, Dr. Kram, for your great presentation and continuous support for our activities. And we hope that we can see you next year face-to-face in Jordan. Thank you very much.
It would be great. Thank you very much for the invitation. I'll see you next month at the MCC, Mohammed. Enjoy the rest of your meeting.
Next Wednesday, yes. Thank you.
Yes. Bye.
Can we start? Good afternoon, everyone. Welcome to today's session. I'm Dr. Salim Nihyali, hemato-oncologist practicing in the Jordanian Ministry of Health, and I will be your moderator. It's my pleasure to introduce our esteemed speaker, Dr. Donald McLornan. Dr. McLornan specializes in hemato-oncology and allogeneic stem cell transplantation. He has a particular interest in myeloproliferative disorder, myelodysplasia, acute myeloid leukemia, and allogeneic stem cell transplantation. He is also actively involved in the NCR and MPN working group and chairs the MPN subcommittee of chronic malignancy working party of EBMT. Today, Dr. McLornan will be discussing myeloproliferative disorder, especially polycythemia, ribera, essential thrombocytosis. Please join me in welcoming Dr. Donald McLornan.
So thank you so much, everyone, and thank you to the Society for the very kind invite to speak today. Can I just check that you can see my slides and they're moving okay?
Yes.
Perfect. So I get the fairly tough task in 30 minutes of updating on PV and ET, and thank you for giving me the topic to discuss. So in this first slide, I really just wanted to highlight the massive changes that have happened within the MPN field over the last 150 years. It's quite sobering to think that actually PMF was first described in the late 19th century, ET in the 1930s when patients with high platelets were noted to have a bleeding diathesis. And if we fast forward to the early 1950s, William Damchek, a key pivotal figure within the American Society of Hematology, was the first to coin the phrase myeloproliferative and group these disorders together. And in comparison to other blood disorders, quite rapidly, there was a study group focused on PV that was formed, the PV study group, and they led quite pivotal trials in the 60s and 70s, looking at hydroxycarbamide and old cytoreductive strategies such as busulfan, chlorambucil, etc. If we fast forward to 2005, as we all know, 3 groups simultaneously published on the JAK2 V617F mutation. In 2011 at ASH, we had the pivotal detection of calreticulin. And in the last 3 to 5 years, we've seen an explosion of new therapeutic modalities in ET, PV, and in particular myelofibrosis. But for us as clinicians treating these disorders in 2025, I think is a time to reevaluate our historical approaches, many of which have not changed for many years, and think rather than normal endpoints, think about disease modification. But most importantly, when we have this therapeutic armamentarium, it's important to recognize that not all patients need treatment, and in particular, some of those patients with triple negative ET. So I don't need to tell this audience about PV. Our practice for many years has been based on the estimation of thrombotic risk historically, based on a previous arterial or venous thrombosis or chronological age over 60. And we know that the clinical phenotype of our PV patients is frequently heterogeneous. Many have significant symptom burden. Some have splenomegaly. And in PV, there's an estimated 8 to 14% risk of transformation to either post-PV MF or blastic phase disease. But I think it's really important when we're faced with a very standard diagnosis for us as clinical hematologists is to recognize that low risk PV does not mean no risk. And this is a quite simple study looking at thrombotic incidence per year, comparing the general population with both low and high risk PV. And even if you can look at the general matched population with multiple cardiovascular risk factors, there's a twofold increase of thrombosis in PV and a more than threefold for those with high risk PV. One of the challenges for us in PV is that there's a complete discord between thrombotic and survival risk estimation and the symptom burden of our patients. So in our practice, I'm sure like yours, we use the MPN-10 total symptom assessment form. We get our patients to fill this in online prior to their clinic view. And this is quite sobering to think that, yes, we very much focus on hematocrits, control of platelets and white cells, but almost 9 out of 10 patients have significant fatigue affecting their day-to-day quality of life. 2/3 have significant pruritus, early satiety, brain fog, concentration issues. And not only does the patient have to deal with these symptom burdens, but we know from the landmark studies, both in the US and across Europe and Australasia, that the symptom burden and quality of life issues can affect family relationships, can affect occupation. Many patients with MPN need to give up their work, etc. So it's a particular challenge. So how do we address the question of cytoreduction in PV? I think it's straightforward for those who are high risk, i.e. previous thrombosis or chronological age over 60, cytoreduction is mandatory. But in the low risk PV population, the updated ELN guidelines in 2022 highlighted some key factors when we should consider cytoreduction in the low risk PV. So it's definitely recommended for those patients who have poor tolerance to phlebotomy, difficulties in venous access, recurrent vasovagal episodes, for those patients with symptomatic progressive splenomegaly, or for those patients who have a persistent leukocytosis with a white cell count greater than 20 for at least 3 months. It also should be considered based on the dynamics of rise in the white cell count. Those patients with an extreme thrombocytosis, in our practice, just like we follow the ELN, if they have a platelet count greater than 1,500 in their low risk, classically, they're a high risk actual patient, so we start cytoreduction. And in those patients who have an adequate hematocrit control, requiring at least 6 phlebotomies in a 12-month period. It's also important to think about that issue of quality of life and symptoms. If patients have a total symptom score on the MPN-10 of 20 or more, or their cardinal score is for pruritus, which, as we all know, can be particularly debilitating in PV, that can also be an indication for cytoreduction. Some practices will use the JAK2 VAF level, the VAF level, as regards an indication if it's greater than 50%. And some very nice work published by the Italians, this just at the end of last year, looking at the white cell count issue. So here they compared the neutrophil lymphocyte ratio, and in those patients with PV with the neutrophil lymphocyte ratio greater than 5, they had poorer risk disease, a higher incidence of bulky splenomegaly and impaired quality of life, and a higher risk of disease transformation. In our centre, our first line of choice is pegylated interferon, but if we look on a global basis, clearly hydroxycarbamide is the most frequent, and it's an effective drug. We see responses, either CR or PRs in 90% of the patients, and we only see resistance or intolerance in between 11 to 15%. And as regards toxicity, it's particularly hematological cytopenias that are difficult to manage while trying to manage the hematocrit, and the issue of skin malignancies for patients on hydroxycarbamide and other PV-directed therapies. But actually, if you look at all the data that we have globally, clearly historically the trials have focused on high-risk PV, and we actually have very limited data on the use of cytoreductives in patients with classical low-risk PV. So at ASH last year, so a few months ago, Francesca Palandri, on behalf of the Italian MPN group, published a subset analysis of the PV-ARC study. And they had a few questions with this. They really wanted to look at the clinical triggers, laboratory triggers for starting hydroxyurea in low-risk patients, to evaluate the rates of thrombosis in 3 cohorts: those with low-risk disease, those with high risk PV based on age alone, or those with high risk based on thrombosis, and look at those ELN-defined clinical and signs and symptoms that I've discussed previously on how they may modulate thrombotic risk. So this is the overall schema. In the essence of time, there were approximately 740 patients with PV treated with first-line hydroxyurea. High risk, as expected, accounted for almost 4/5 of the population. There were 137 low-risk patients who received hydroxycarbamide. And actually, they actually looked in the real-world setting. So we're very good at generating academic guidelines, but we all know that practice differs in the real-world setting. And actually, as regards the ELN clinical symptoms and signs for starting cytoreduction, many clinicians were starting hydroxycarbamide in conventional low-risk PV when the platelets were greater than 1,000 rather than 1,500, with them needing less than 6 phlebotomies in a year, and looking most importantly at cardiovascular risk factors. And in this study, they defined that as at least 4 out of 5 of being a smoker, hypertension, dyslipidemia, diabetes, or an elevated BMI. And most importantly, when we think about the overall high and low risk cohort in this study, the presence of these ELN-defined clinical signs and symptoms was associated with a worse thrombosis-free survival in the overall cohort. If we look at the 3 groups of low risk disease, high risk based on age, and high risk based on thrombosis, you can see again in each of these categories any of those clinical signs and symptoms associated with a worse thrombosis-free survival. So this is quite a messy Kaplan-Meier, but I think it was super interesting when this was presented at ASH 24, that if you look at the top green and blue line, the best thrombosis-free survival, as we would expect, was observed in low-risk disease or high-risk PV based on age alone without ELN-defined clinical signs and symptoms. There was an overlap between low risk and high risk for age with clinical signs and symptoms, which had a comparable thrombosis-free survival to those with high risk disease based on thrombosis alone without clinical signs and symptoms. And then we see a dismal thrombosis-free survival for those patients with previous thrombosis who have any of these ELN-defined clinical signs and symptoms. So it was interesting, and I didn't show all the slides from this presentation, but actually in real-world practice, we were quite interventional globally about starting cytoreductive therapy in the low-risk population. These very easily applicable clinical signs and symptoms identify an increased thrombotic risk phenotype in all risk categories and suggest that we should think about incorporating them into existing prognostic models. And if we think about the ELN, CSS, the key ones were cardiovascular risk factors, progressive splenomegaly. So moving on, what else have we seen at ASH and published over the last few years? I think just to show this very briefly, many of us will be familiar with the REVEAL study. It was the largest global observational study of PV patients in the United States. 2,271 patients were eligible for observation over a 3-year period. And the take-home message here was, interestingly, when they looked at hematocrit control and dynamic changes in total white cell count, as regards the hazard ratio for thrombosis, this actually favored a white cell count even more so than an adequate hematocrit control, emphasizing again monitoring the white cell count in our PV patients and intervening early. About 7% of the population who were evaluable transformed to post-PVMF. On univariate analysis, this was associated with longer disease duration, prior arterial or venous thrombosis, a higher JAK2 VAF level, and again, the presence of leukocytosis. So all of this data is leading us to think about, rather than focusing on not only clinical endpoints, but also thinking about disease modification early. The low PV study was a randomized study in Italy led by Tiziana Babui, who randomized patients between phlebotomy and aspirin and a fixed dose of Besremi, so Ropeg interferon, which was given 2 weekly. The primary endpoint of the low PV study was the proportion of patients achieving an hematocrit less than 45% at 1 year and an absence of progressive disease. But actually it was an intention to treat analysis, and because it favored so strongly Besremi, after 100 patients, the accrual actually was halted due to overwhelming efficacy. Here we can see the achievement of primary endpoint in orange, the achievement of Hematocrit less than 45% and dynamically monitored over a 12-month period, favoring Besremi over phlebotomy and aspirin alone. And looking at hematocrit control only, there was no disease progression in the Besremi arm, and around 8% of those in the observational cohort receiving phlebotomy and aspirin had disease progression. Importantly, when we think about changes in the JAK2 VAF level and disease modification, we can see here in the plots that row-peg responders in red had a significant decrease in JAK2 VAF, and this is particularly in those who had a high JAK2 VAF level at presentation greater than 50%. Quality of life favored row-peg, and here we can see in these graphs improvements in quality of life dynamically, and looking at the factors in the MPN-10 symptom assessment form, this strongly favored the introduction of row-peg interferon. So, as you know, in the States, the NCCN guidelines have recently changed their PV guidance about earlier use of Besremi. In the UK, and now I'm switching to high-risk PV, we had an academic-led study called MAGIC PV. This was a rapidly recruited study, a phase 2 multi-center trial. These were high-risk PV patients intolerant or resistant to hydroxycarbamide, randomized on a 1-to-1 basis between ruxolitinib or BAT. As regards BAT in the trial, as you would expect, it was firstly hydroxycarbamide, secondly pegylated interferon, and thirdly a combination of pegylated interferon and hydroxycarbamide. And really what we wanted to see with this academic trial was long-term benefits of ruxolitinib, looking at dynamic control of hematocrit and white cell count and molecular responses in patients with high-risk PV. This is the baseline demographics of the group, and just to say, if you look at the overall group, around a third of the patients were high risk as regards previous thrombosis. Around a third of the patients had poorly controlled hypertension. And importantly, before I jump into the molecular analysis, there was no difference in the BAT arm versus ruxolitinib as regards the JAK2 VAF, which was above 50% in both cohorts. Here we can see the chance of achievement of best response of complete remission. So this was quite a stringent trial. It used ELN criteria for CR and PV, which, as you know, is a hematocrit less than 45%, platelets less than 400, white cells less than 10, and no evidence of splenomegaly. But we know in practice that's pretty difficult to achieve. But actually, you can see that almost half of the patients treated with ruxolitinib achieved a CR within 12 months, versus only 26% in those receiving BAT. The time to discontinuation and duration of CR favored ruxolitinib compared to BAT. As we would expect, hematocrit levels were lower in patients receiving ruxolitinib. And thinking about our patients' time at hospital, most importantly over the follow-up in this study, in the ruxolitinib cohort, there was a total number of 83 phlebotomies versus over 300 in the BAT arm. So thinking about disease modification, this is some of the very interesting data from this study that was published, as you know, last year in JCO. So looking at the composite endpoint of event-free survival, so lack of events being major hemorrhage, thrombosis, transformation, or death, this was clearly statistically superior for ruxolitinib, and most importantly for those attaining a CR within 1 year. And if you achieved a CR within 12 months, this was associated with almost a 60% reduction in major thrombosis, hemorrhage, transformation to post-PVMF or death. And that really highlights the dynamic importance of comprehensive control of blood counts in your PV patient. And one of the most striking things from this was the dynamic of molecular changes happening in the JAK2 VAF. So this happens slowly. In brief, at the final time point in the trial, the molecular response here defined as a 50% reduction in baseline JAK2 VAF. This was 56% for Rux and 25% for BAT. And when the translational laboratories in Oxford looked at the stem cell level, you could see that you were getting some super deep responses. And what does that actually mean for our patients? Why is that important? So when we looked at the survival analysis, molecular response at 1 year was strongly correlated with superior event-free survival. And those who had durable molecular responses at the last time point analysis had significant improvements in both EFS, PFS, and overall survival. And that led then to the question, when we have this subset analysis, are there any backseat mutations non-driver mutations that can affect survival. And here we can see that pathogenetic mutations in ASXL1 had an independent adverse effect upon EFS. So this is really looking at bad risk PV that was hydroxycarbamide intolerant or resistant. We can see that ruxolitinib improved event and thrombosis-free survival, and we were seeing some suggestive evidence of disease modification. We've seen an explosion of new drugs outside conventional cytoreductive strategies. We know that rusfertide was the first hepcidin mimetic to make it into a phase 2 trial that rapidly recruited globally, and now we have a phase 3 trial looking at rusfertide in PV. So REVIVE was the phase 2. It was quite a complex trial design. It was part 1, which was dose finding and titration. Part 2 was randomized to placebo, and then everyone could enter into the open label extension of rusfertide when there was dose titration of the rusfertide. Importantly, in this trial, just a caveat, patients could be on cytoreductive therapies or not, and there were strict criteria when additional cytoreductive therapies could be modulated. But importantly, thinking about the endpoints, we can see that it was highly significant as regards good hematocrit control, as can be seen here in orange, and compared to placebo as expected. Here we're seeing durable control of hematocrit through the open label extension phase up to 2.5 years. The red line is highlighting the randomization part before patients were able to switch back to active drug. And importantly, we can see normalization of serum ferritin levels at the same time. So rusfertide in this phase 2 showed long-term durable control of hematocrit, decreased phlebotomy use for at least 3 years. And this is very important for our patients. And the rate of phlebotomy decrease went from almost 9 per year to less than 1 per year in the open label extension. It normalized serum ferritin levels through the same time and was well tolerated and had a safety profile of maybe grade 1 to 2 injection site reactions. So as you know, globally, we have the phase 3 VERIFY trial. It's a super important trial for our patients who have an adequately controlled PV and adult patients, and it's a placebo-controlled trial. So we will see some interim analysis of this in 25 and 26. And finally, to finish on PV, what about RUX in first line? So I've focused on high-risk PV who've been previously treated. So that then begs the question, should we be using ruxolitinib as a first-line therapy? We know that the trials leading to licensing of ruxolitinib, response 1 and 2, were in the hydroxycarbamide intolerant or resistance group. I've shown you the MAGIC PV study. So the German group had the RUXOBEAT study trial. They published an interim analysis at ASH this year and looked at the PV cohort, and it was a randomization between ruxolitinib and BAT. And there were 78 patients available for the 6-month interim analysis. In contrast to what I've just shown you, actually in the first line setting, in this first interim analysis of a small cohort of patients, there was no difference in achievement of CR, ELN defined, between BAT and RUX, or overall response, or as regards reduction in phlebotomy. However, as expected, for those patients who had splenomegaly, it favored use of ruxolitinib, and for those patients with significant symptoms, we saw improvements in symptom and spleen burden. So the next stage of the trial will be eagerly awaited to see about the first-line setting. And we also have the Mithridate trial run by Claire Harrison in the UK, and also Jean-Jacques Calagian in France. This is a 1-to-1 randomization between ruxolitinib and BAT, being either hydroxy or interferon alpha, and there's a large translational component looking at molecular responses with this trial. So to get us back on track, I'll just finish through the ET part. I think ET, for most of us, is a fairly straightforward disease, but I think we're rethinking how do we consider high-risk ET. We're thinking about the heterogeneity of patients we clinically label with ET, and we're seeing a whole host of new drugs coming into the arena. I don't need to explain this slide to the audience about how we conventionally manage ET, but in our own practice in the UK, we have ready access to pegylated interferon. So most of us will use this rather than hydroxycarbamide. And when we audited our practice in UCL of our complete hematological responses to pegylated interferon, we were seeing this in around 87% of those patients achieved within the first 6 months. I think we have other scores. They're not always easy to apply to ET because we don't frequently expand the mutational annotation for this group, but we have the IPSET thrombosis group, which simply focuses on age, thrombosis, and JAK2 unmutated. And high-risk disease is anyone who's had a thrombosis history with ET or being over 60 and having the JAK2 mutation. We have the MIPS-ET, which does need an extended panel being performed, and it's based on chronological age, worse outcome if you're male rather than female, again, leukocytosis coming through in the model, and the presence of an adverse mutation as regards survival. And in ET, this is the presence of SRSF2, SF3B1, the additional spliceosome mutation U2AF1, and the culprit in many of our diseases, TP53. But actually, if we do have this information, it's quite sobering to think that a patient with low or very low MIPS-ET has an estimated survival greater than 5 years. But if you've high-risk ET, particularly if you've one of these adverse mutations, your estimated overall survival is around 8 to 9 years. And in the UK, we also have the Predict Blood tool. This was published in the New England Journal of Medicine several years ago, and it's a very easy online calculator when you can plug in hematological values, clinical values, your extended gene panels, if it's available for any of the MPNs. It incorporated over 1,200 patients with ET, predominantly those that were in the PT1 trial. And you can get a very helpful graph, particularly with an anxious young patient who wants to know about survival longer term, when you can estimate time in chronic phase disease and overall estimate their treatment journey. So this is a very helpful tool for us. We use it a lot within the UK. One of the problems with ET is that for our younger patients with ET, we apply rules that we've applied to a much older population who have a higher risk of comorbidities and a worse overall survival. So published in Blood Advances, we have a very expanded cohort of 348 patients who either had PV or ET diagnosed less than the years of 25. And this was coordinated by the EHA group. And the main aims of the study were to describe relevant outcomes, thrombosis-free, myelofibrosis-free survival and overall survival, and to investigate the impact of treatment on TFS and myelofibrosis-free survival. I won't have time to jump through all of this, but as looking at the ET cohort, there were 278 patients with ET. As expected, almost 4/5 of them were female, 1/3 of them were triple negative. Even in this young cohort, almost 10% had a history of thrombosis, 13% had cardiovascular risk factors, and on the IPSET thrombosis score, predominantly these were intermediate or high-risk disease. So thinking about thrombosis-free survival, and this was a combined analysis for ET and PV, again, leukocytosis came through very strongly here in the multivariate analysis as regards a worse thrombosis-free survival, and the presence of splenomegaly was associated with a decreased risk of thrombosis. But importantly, thinking about treatment, in this cohort, it was a heterogeneous cohort, almost about 70% of the patients were on a cytoreductive. The vast majority were ET because they needed a cytoreductive therapy because they had a platelet count of greater than 1,500. And the other biggest indicator for treatment in this young population was the thrombosis that we've described, or symptom burden. But comparing the available treatments, you can see that long-term myelofibrosis-free survival significantly favored interferon use. And I think that's very important about the use of interferon versus other cytoreductive therapies within this group. One of the challenges that we have is the triple negative ET. For all of us who look at bone marrows in multidisciplinary meetings, we know that we're often faced with a patient who has a sustained platelet count. They're often a younger female. Their bone marrow histology is not entirely normal, but they don't meet diagnostic criteria for ET. These patients lack canonical JAK2, CALR, or MIPL mutations, but they're not risk-free. Importantly, the triple neg ET population can have a thrombosis risk, if you look over decades, of somewhere between 10 to 30% over a decade. So what is the etiology of this heterogeneous group? I think there can be other clearly pathogenic acquired variants in MPN driver genes. There can be germline variants, and I think these are often missed. There can be pathogenic variants in other myeloid-directed genes, such as TET2, and there can be epigenetic factors that lead into this. So thinking about the treatment discussion, our first-line practice is interferon versus hydroxycarbamide. In the UK, we do not use a lot of anagrelide, and the only times we use busulfan is in the very elderly hydroxycarbamide or interferon intolerant patient. We know that the reason to start cytoreduction in the high-risk ET group comes from the Bergamo trial, looking at controlling the platelet count less than 600. And then in the PT1 trial, which was a UK-led trial with a big biobank, this compared anagrelide with hydroxyurea in high-risk ET. Hydroxyurea plus aspirin favored the vascular composite endpoint, and we saw fewer myelofibrosis transformations and fewer treatment withdrawals and less bleeding risk with the use of hydroxycarbamide versus anagrelide. So I've told you that in our practice we use interferon. Actually, the interferon data in ET historically has been based on smaller cohorts. We know that responses can be durable, and in some patients, just like we see in PV, we can see sustained molecular responses in patients on pegylated interferon and also histological responses. But what we're lacking in the field at the minute is long-term data, and that's currently being collated. And to finish in my last few minutes, what's in the field of the arena for new therapeutics in ET? There's a range of drugs, BET inhibitors, LSD1 inhibitors. We'll talk about Besremi and also immunotherapeutic approaches. So the ROPEG interferon surpass ET study is a very interesting study because it's really comparing fixed dose and then increased dose ROPEG interferon with anagrelide in patients who've got high-risk ET and who are resistant or intolerant to hydroxycarbamide. And very importantly, when we look at the top-line messages that were presented at ASH a few months ago, 43% of patients in the ROPEG arm achieved durable complete responses at months 9 and 12 versus only 6% of those patients treated with anagrelide. There's a strong rationale for LSD1 inhibition in MPNs. As you know, this is an epigenetic enzyme. It's required for the differentiation of MEPs to mature megakaryocytes. And there is overexpression in ET and also in myelofibrosis. So bomedemstat was originally evaluated in a phase 2 trial that was presented at ASH in 2022 for the treatment of high-risk ET. And this is the 24-week, so the 6-month analysis, and it's a single-agent drug. And at week 24, 77% of patients receiving the drug had achieved a platelet count less than 400, and there was no emergent thromboembolic events. And if you fast forward that to 48 weeks, this was over 90% of patients had achieved the endpoint of the trial. Thinking about tolerance of the drug, there is taste abnormalities, arthralgia in around 25%, and gastrointestinal side effects. But importantly, again, with these drugs, we're seeing a hint towards disease modification, and particularly those patients who are homozygous for the driving mutation, in particular JAK2. Another drug that's now recently been taken over by Novartis is pelabresib. So in the MANIFEST study, originally, as you know, there was arm 4, which looked at high-risk ET rather than myelofibrosis. Again, we can see that BET inhibition can control platelet counts adequately less than 400, maintain the hemoglobin, and also reduce the white cell count if it is elevated. And importantly, with this, again, we're seeing a hint of not only symptom benefits on the drug, but a hint towards reductions in the molecular drivers such as JAK2. And lastly, what will we expect in the next decade? I think we have a whole host of calreticulin targeted therapies. We've got vaccine studies for mutant CALR and JAK2 neotypes. We have the mutant CALR directed antibodies, bispecifics, and our group at UCL has also developed mutant CALR targeted CAR T. But I think we have to be clear, and clearly I think these are mostly being evaluated. We have trials open for ET and myelofibrosis, but we have to think about the MPN microenvironment for such agents to work. Often there's a markedly hostile pro-inflammatory cytokines that can abrogate the effect of these immunotherapeutic approaches. And certainly we're keen to evaluate these in myelofibrosis. It's tricky to treat, but potentially they're too intensive or toxic for patients with ET. But we're seeing some very nice early responses with the antibody targeted drugs. And this is the CAR T. Obviously, we're focusing on myelofibrosis that's being developed by Alex Rampotis, who's an academic clinical trainee within our group, and Beth Sila from Oxford. And this was presented at ASH 24, showing on-target effects of a novel designed CAR T against mutant calreticulin. And the team in London and Oxford are spending time now to develop a phase 1 first-in-human clinical trial. So I'd like to conclude that standard of care of ET and PV is not perfect. We should always look at the patient in front of us and not neglect cardiovascular risk. Identify those low-risk PV patients classically with higher risk features. Start interferon. Be particularly observant for the leukocytosis. Some patients may need less treatment. We're learning more about triple-negative ET, and the British Society of Hematology group and the UK MPN group, which I chair, we're putting together a good practice patient paper about how to diagnose and manage patients with triple-negative thrombocytosis. Clearly, I hope I've emphasized that interferon is the drug of choice in younger ET and PV patients. We're seeing molecular responses to ruxolitinib in the hydroxycarbamide resistant and intolerant setting, and improvements in event-free survival. And I've highlighted some of the new drugs in the field, and whether we will ever use CAR for CALR mutated ET remains a question for the future. So I'd like to thank you very much for your attention, and I'm happy to take any questions. Thank you so much.
Thank you, Dr. McLaurin, for the enlightening presentation, and we will now open the floor for questions. Please feel free to raise your hand and type a question in the chat box. I will do my best to ensure we address as many questions as possible within the time we have. Let's start within the first question. Dr. Muhammad Tawal asked about the role of JAK2 for a prognosis for polycythemia vera.
So I think it is important. I mean, up until 6 or 7 years ago, our lab didn't report the VAF of the JAK2, just reported it if it was positive or negative. But now, routinely, we're seeing the VAF reported in our panels, because all of our laboratories use an extended gene panel, even for routine diagnostics. So we have the VAFs of the driver and sometimes non-driver mutations. I think if you have a patient with, and it's often frequently in PV, with a VAF level greater than 50%, often they may have a more tricky disease to treat. So I think although that's not incorporated into the current algorithms, it is something I consider when I'm thinking about other reasons to start cytoreductive therapy.
Also, a question from Dr. Walid Ghanima. How would you treat a young patient, female, 20 years, no previous history of thrombosis, with BML 31, white PC 12 or 11, no previous history of cardiovascular disease with JAK2 positive and the platelet count 1,300?
Yeah, great question. I think, so even though I've tried to highlight the clinical signs and symptoms that we should be thinking about integrating into different scores, if we're looking at this likely ET patient, that was obviously talking about PV, the question is, do you wait until the platelet count hits this arbitrary figure of 1,500 or not? I think she has other risk factors. She's got a leukocytosis of 11. She's got an elevated BMI. Her driver mutation's JAK2, and she's got a platelet count of 1,300. So for me, I would start the patient on pegylated interferon.
Also, a question from Dr. Inas Absalim. Has there been a consideration to assess the benefit of targeted therapy, such as IDH inhibitors, for patients with MPN?
Great question. So the answer to that is we know predominantly in myelofibrosis, the incidence of IDH1 and IDH2 pathogenic mutations is probably between 2 to 5%, so much lower group that you're going to be targeting. But certainly it's a high molecular risk mutation. Predominantly the IDH2 inhibitors have been in combination with venetoclax and azacitidine in the accelerated and blast phase disease setting. But the early survival signals were no different than the HMA and venetoclax cohort alone. So I think it's something to explore, but it's a low incidence and hence a harder trial to set up and recruit to.
Thank you, Dr. McLaurin, for your valuable insight and for sharing your expertise with us today. And thanks you for everyone.
I have a question. Can I have a question, please?
Sure.
Now, in clinical practice, we come across several patients who have high hemoglobin, very high hemoglobin, 18, 19, 20, 22. And we do every single investigation, and they are not polycythemia rubra vera. They do not fulfill the criteria. And they do not fulfill the criteria of hypovolemia plasma-wise. And they are not on medication. We also do HFE mutations and additional points, and they are not. What do you do with this group of patients? They require, sometimes they're so symptomatic, they require bleeding. We have to vivisect them.
Yeah, I completely agree. We have exactly the same. So you've obviously highlighted all the diagnostic criteria they don't meet PV. You've extended all the other ancillary investigations. We have one centre in the UK that will do a congenital erythrocytosis screen that covers all of the genotypes associated with a congenital erythrocytosis. So we occasionally find a scattering, but if not, as you know, it kind of falls into the dustbin group of idiopathic erythrocytosis. And there in the PV guidance in the UK, we set a target of hematocrit of 0.55. But just exactly as you've said, there can be patients who have hematocrits of 0.5, 0.52 who are super symptomatic. So we venesect them intermittently based on their symptom score.
We have also questions from Dr. Faraz Fararji.
Dr. McLaurin, hi. Thank you for your lecture. I want to ask about the CALR mutated ET based on the new information that we have now that they have an increased risk for myelofibrosis. They progress to myelofibrosis more than the JAK2 ones. Do you follow them up any differently than the JAK2? Do you see them more often? Do you do any, I don't know, bone marrows every now and then or what? Thank you.
No, great question. I think that's super interesting data that we've seen for that and somewhat surprising, but we don't in our practice yet for us change how we monitor them compared to JAK2 or MIPL or triple neg ET. So we will monitor their blood films at each clinic visit to look for any changes of leukoerythroblastic, etc. All of our MF patients get a gene panel on a 12-monthly basis and an ultrasound on a 12-monthly basis. But I haven't changed practice based on driver mutation as regards frequency of monitoring. But I don't know if that will come in the future or not, but that was a great question.
Any question? Thanks, Dr. McLaurin, for your valuable insights and for sharing your expertise with us today. And thanks you to everyone in the audience for your active participation and engaging questions. Thanks, everyone.
Thank you so much. Have a wonderful conference. Thank you so much, everybody.
Are we on? Perfect. Dr. Foran, you can share your slides if you can hear me. Hello, everyone. Good afternoon. My name is Zaid Abdurrahman. I'm a hematologist and transplanter at the King Hussein Cancer Center. And it gives me immense pleasure to introduce Dr. James Foran. He is a graduate of the University of Manitoba in Canada, and he subsequently did his residency in Boston, and he liked it there, so he stayed at the Dana-Farber Cancer Institute in Boston. He then flew across the pond to do further training in the UK at St. Bart's Hospital, University of London. He then moved back to the US, where he held a couple of faculty appointments at the University of Nebraska and the University of Alabama in Birmingham, where he also served as the fellowship program director over there. And then he subsequently moved to Mayo Clinic, where he currently chairs the acute leukemia and myeloid neoplasm group at the Mayo Clinic Comprehensive Cancer Center. Dr. Foran has held several positions at several national and international study groups, namely the ECOG-ACRN Leukemia Core Committee, where he chaired the E2906 randomized clinical trial in older adults with AML. He's also a previous member of the ASH Community on Educational Affairs, as well as the ASCO Annual Meeting Program Committee. He's also a previous member of the NCI Leukemia Steering Committee and a current member of the NHLBI MDS Steering Committee. He's also a clinical investigator on a variety of trials. On top of all of this, Dr. Foreign happens to be my mentor, and you can either thank him or blame him for any issues that you have with me. And gives me, I'm incredibly excited to introduce him to the group. James, the floor is yours.
Thank you very much. Hopefully you can hear me okay.
Yes, just give us 1 second for the presentation to show up.
Is it sharing? I'm trying.
We're all good. Yes, perfect.
And Zaid, is it better if I do this slideshow presentation? That's probably better, isn't it?
It might work, may not work. Let's give it a shot.
Tell me if that's projecting.
We're not seeing it in slideshow, so you might have to do it manually.
Fine, happy to do that. Okay, is it showing now in just the regular format?
Yes.
Great. Zaid, thank you very much for the introduction, also for the invitation, and you have to bear with me. I'm a little tired today, only because, like every Canadian, I stayed up very late last night watching Canada beat the United States in ice hockey in overtime. So sorry if I'm a little sluggish this morning, but it was a day of rejoicing for Canadians last night. We haven't had that many of them recently. I was asked to give an update on recent advances on AML and unfit patients, which I'm delighted to do, and put some objectives together. I'm going to speak briefly about changes in the AML classification schemes, discuss some insights into precision medicine and clinical decision making to identify unfit AML patients, really focus for a while on venetoclax, how to maximize its impact and get the most out of it for patients. Some of the new areas of development, specifically menin inhibitors, which are now available in the United States, and a brief glimpse into the future of CAR T for AML. I took a moment to do a couple of things. First of all, I've never been to Jordan, and so I was looking to see where it was on the map, and you're almost on the exact same latitude as Jacksonville, Florida. I'm at the Florida Cancer Center site for Mayo Clinic. It's generally slightly warmer here in February. I looked that up also, although today it's not. It's like going to be 8 or 9 degrees. But you are, I guess I'm a third of the world away from you. I also looked to see if there were any ice hockey leagues or teams in Amman. I couldn't find if there were or not. I did see there were some skating rinks. So I guess that's consistent for a Canadian. That would be consistent with civilization. Some background on AML in the United States. So this is the most common leukemia diagnosed by incidence, although not by prevalence. And these are estimates from the American Cancer Society. This year, over 22,000 people diagnosed with AML, over 11,000 deaths. So just by proportion, you can see the difficulty of the problem. It also disproportionately contributes to cancer death relative to its incidence. It's 3 or 4% of cancer incidence and also 3 or 4% of cancer deaths. So unlike other malignancies, we've struggled to make as big an impact, although we're slowly doing that. I think there's an important question, excuse me, about how we diagnose AML in 2025. Most of you are no doubt aware that in 2016 was the updated WHO 4 classification, or what we call the WHO 4R, that was used for the original ELN, consistent with it, and really was guiding our clinical trial selection and diagnosis. 2022, 2 different working groups, the International Consensus Classification, the ICC, and also a WHO 5 group, came up with recommendations for an updated myeloid classification. And these were published over the last 2 years. And the tricky part is that there are some differences between the two. Now, in most areas, these classifications align, but in some areas, there are differences. In the ELN classification, they recognize that if you have more than 10% blasts, that's what they would call MDS/AML, whereas that would be considered increased blasts in the WHO 5 classification. AML with an antecedent disorder or prior exposure or therapy-related AML is considered a separate entity in the WHO and just a qualifier in the ICC classification. You can see that if you have a KMT2A rearrangement, an NPM1 mutation, a MECOM, that's 3q26 rearrangement, or a NUP98 rearrangement, that can be considered AML regardless of the blast count of the WHO 5 classification, although ICC still requires increased blasts. And then some other abnormalities like TP53 as it's a separate entity in the hierarchical classification for ELN, although not in WHO, and the issue of therapy related. This issue of the MECOM rearrangement came up recently where we had a patient who did not have increased blast, but had a MECOM rearrangement and was called AML. And so I think it still matters in the clinic that you know what you're treating. Well, there's a pathologic diagnosis, but there are also clinical indications to treat. And I'm still in the category of you know it when you see it, whether it's AML and it needs intervention. And I'm using these as permission to treat as AML when I need to, rather than feeling handcuffed by them. Now, just a quick screenshot of the most recent updated guidelines from NCCN. I'm a member of the AML panel for NCCN. And we're actually meeting in May to update this and go through our data and our discussions again. But the important part of this slide is we still break categories into favorable, intermediate risk, or poor or adverse risk. I will say I still haven't met an AML that's favorable, so I don't always love that terminology. But I think one of the key questions here, or one of the key points here, is that it matters to have sequencing performed to look for mutations of commonly recurrent or non-random common recurrent mutations that we see in myeloid genes. That really does help us predict outcomes. Dr. McLaurin's presentation, which was outstanding, noted the adverse impact of spliceosome mutations in the chronic myeloproliferative neoplasms, and they're also adverse in patients with AML. So this is really what we're using still as our framework for deciding on initiation of therapy, prognosis, timing of transplant. I put a note on the bottom that there is a move towards whole genome sequencing, certainly at Washington University. They have nice data on that. We've not started doing that routinely, although I suspect since that's going to be cheaper in the end one day than standard cytogenetics, which are still expensive and not cost effective in a lot of the time, that may be coming. Now, we're still trying to figure out what to do with all the different mutations. And I took screenshots of some of the papers that the Mayo Clinic Myeloid Group has put out in the last couple of years, looking at ETNK1 mutations, U2F1, STAG2, WT1, BCOR, GATA2, ETV6, ZRSR2, and DDX41. And not to say that we know the answer, we're kind of picking apart mutation by mutation to see, are there unique features of patients with this mutation group? I will say that we don't yet have a good strategy for how to deal with mutational complexity or genomic complexity with AML in terms of prognosis or driver mutation or what to target. And I think that's something where we really need to share data with other large high volume leukemia centers who have this kind of sequencing data and outcomes to really understand better what drives it. DDX41 you see in the upper right hand corner is going to come up again just on the next slide. But it's an area where we've put out more than 10 papers in the last 3 years trying to look at its frequency, associations, impact on therapy and outcomes. So I think there's a lot still to learn. One of the important features, or one of the emerging features in AML, and this is germane to older patients with AML, is the increasing awareness of germline mutations. Now, Dr. Abdel Rahman was recently in Florida. We dragged him over here when he was giving a presentation at a leukemia meeting. He gave us rounds to our hematology group and was discussing some of the unique aspects, molecular aspects of leukemia in Jordan, which was fascinating, and also the struggles with germline mutations. And this has been recognized in the American Beat AML studies, where 1 in 6 patients will have a germline mutation. The most common was DDX41, homobox mutation. It's almost 2% of patients. It was more prevalent in older individuals, had a marked male bias. The point there being that we always think that a germline mutation is going to manifest in a 20-year-old or a 40-year-old, but we're seeing this in 60 and 70-year-olds. There are other familial genes, GATA2, TERT, and the RAS pathway genes, PTPN11 and NF1. So we're seeing those as being germline genes. And no surprise, really, on reflection, that the DNA damage response genes such as CHEK2 and Fanconi anemia pathway genes, as you can see, are also recurrent germline mutations that you can see in older adults with AML. Now, this has important implications for donor selection. We're not quite sure what the implications are for therapy. Certainly gives us, or starting to give us, some insights into predisposition to leukemia. And it's an area where we are now putting more attention into germline testing and shifting more to hair follicles because they're easier to collect, and starting to get germline testing in more patients. I think this is something we're going to have to continue to learn about. I was asked really to focus on older adults and the unfit population. And so this is some older data from Sweden and also from Italy that was sort of put together as a composite, looking at the age of AML. And even though acute leukemia is the most common cancer between the ages of 20 and 40, has a median age of onset of 68 to 70 years in the United States. And we break AML down into younger patients aged less than 60 and older patients. You can see on the curve that most patients are in the older category. I put an estimate there. That's my own kind of estimate on the frequency of intensive induction therapy in older patients. Above age 65, it's becoming more and more of a question about giving intensive therapy, and I'll talk about that in a minute. And as you can see, over 75 and 80, almost nobody's really a good candidate for that. Importantly, there's some nice data from the Italian group published by Erika Borlenghi and some of her colleagues that shows that almost 40% of patients over 65 in their studies received intensive chemotherapy and are fit. And so that's the real question: who's fit and who's unfit over the age of 60 for treatment? Now, in the UK, Alan Burnett, who chaired the MRC and then NCRI Leukemia Committee for years before he retired, still a contributor to the group, several years ago put out data on 25 years of outcomes for AML. And this is almost all with intensive chemotherapy. You can see that there was a slow, steady improvement in 5-year survivals that were less than 10% back in the 1970s and 1980s. And through the early teens, up to 2014, had bumped up to the range of about 25% 5-year survival for patients over the age of 60. And they note in their paper that more intensive chemotherapy combinations have been facilitated by better supportive care and support from other medical disciplines, and particularly nursing expertise. So we can get more older patients over the age of 60 through intensive therapy. The question is, should we? Is that the best option? And what are other options? There's actually an online AML risk calculator. We've been using this. You're probably familiar with this. The web link is up above, AML-risk-model.com. They looked at over 3,600 patients, a 32 gene panel, the 16 molecular subclasses that Ellie Pep-Emanuel's lab characterized in 2016, and then a risk stratification score that was really able to re-stratify almost over a quarter patients into higher or lower risk disease. So if you're giving intensive therapy, which is the focus of this risk calculator and the outcomes associated with it, it's helpful. We're not quite sure about the unfit patients, and that's really the next frontier for us. One last thing about intensive therapy is to say that we do think we improve quality of life if you get a remission with intensive therapy. This is prospective data that we presented at ASH a year and a half ago that's currently in manuscript form for submission. We found that if you looked at the composite score of quality of life, we call it the trial outcome index, it's an established score, we saw a statistical drop during the nadir with intensive therapy in older adults, and statistical increase in responders so that their quality of life scores went up by 1 standard deviation after 1 month. So not only are we able to achieve remission with intensive therapy, we can improve quality of life. Yet again, it's just not always possible in older adults and unfit patients to do this. Finally, I'll say that I still bias towards intensive therapy if I find a fit candidate because we're better at getting people through it. We think we impact a quality of life if they get a remission. And we currently have our manuscript under review. But if you look at long-term outcomes for older patients, intensive therapy, who achieve MRD negative remission, which was 40% of them, almost half are alive and in long-term remission at 5 years. So it's important that we don't neglect the patients where we think we can cure them. And that might be a higher denominator than is appreciated. I think you can already see by my tone that I'm a little more of an intensive than non-intensive therapy person when it comes to older adults. Now, what's the issue here? Where's that Goldilocks moment? And I apologize, I don't know the Middle East culture as well, and Jordanian culture specifically, so I don't know if Goldilocks is a well-known character in Jordan. But we're really looking for that Goldilocks moment where with the 3 bears, you didn't want the porridge to be too hot and too cold. It's the same with chemotherapy. Intensive therapy is too much for some patients, the very elderly, the unfit, those with complex karyotype, and have toxicity. For lower intensity, it's too little for some. You want to make sure that you're picking the right curable patients, the more favorable patients for that. And you can see on the right, there's an area where you've got low efficacy, where maybe too cold for some, or high toxicity, where maybe too hot for others. And so the goal is to find in a more precise manner who's the patient best suited to that therapy and to do the right thing for that patient. So who's unfit? That was really the topic I was asked to address. Well, age, of course, predicts it. Performance status predicts it. comorbidities, which we don't always account for systematically in hematology practice, and then some leukemia-related factors that are more appropriately treated with low-intensity therapies, such as those in older adults who have a complex karyotype with a TP53 mutation. And there was an important paper just over a decade ago by Ferrara, who looked at what are the operational criteria to define unfitness for intensive therapy. So over age 75, history of congestive heart failure or reduced ejection fraction, documented pulmonary disease, obviously patients on hemodialysis or renal cell carcinoma, liver disease with cirrhosis, ongoing active infection requiring therapy, mental illness was a factor, a performance status of 3 or worse, where somebody is unable to be up and around more than 50% of the day and care for themselves, and other comorbidities that might be judged by an investigator or by the patient to be compatible with conventional treatment. This is kind of a cumbersome list. Like, do you have to do pulmonary function tests in everybody, or how do you figure out if they've got liver cirrhosis and etc. Mental illness is not something we screen for systematically always in hematology practice if we're not already aware of it. So how do you apply this? And this is where some of the practices by one of the Italian cooperative groups in Lombardy really gave really nice insights. This is a paper published a few years ago by Dr. Borlenghi and her colleagues, where they looked at 700 patients, older patients, mostly de novo AML, over an 8-year period at 8 centers in northern Italy. And they found when they applied these criteria to patients, even in retrospect, it was easily applied, and 98% of the time they could come up with somebody who's fit or unfit or frail. And you can see the survival curves on the left. No surprise, the fit patients did better than the rest. The unfit patients did a little better than the frail patients in terms of median survival. So it matters to really find out who's fit. Now, they looked at what treatments were applied to those patients. And by the way, I'll say for the fit patients, I put that on a bullet point. The median survival was longer with intensive therapy than non-intensive therapy. This mostly predates venetoclax, so I would take that with a grain of salt, but it suggests it matters to find who those fit patients are. If you looked at the patients who got intensive therapy, regardless of their fitness score, they did have a survival advantage overall. So I do think it's possible to apply fitness, and I do think it's possible to select appropriate therapies with intensive or non-intensive strategies in practice using those criteria. Now, the big change for us was the innovation in the mid-2010s of venetoclax, the BCL2 inhibitor, showing activity in the early combination studies out of MD Anderson, Penn, and some other institutions. And then the randomized study, the VIALE-A study, published, I can't actually believe it's 5 years ago. And as you can see, there was a significant advantage of adding venetoclax to azacitidine. So a low intensity strategy that was tolerated, improves the complete remission rate for all subgroups of patients, and improved median survival from 10 months to 15 months, with the possibility of maybe a tail on that curve, as you can see beyond 2 years. And this curve, not so many events, but some long-term outcomes subsequent to this have shown there are some people in long-term remission. It's not always easy to dose venetoclax. There are a lot of different adjustments that people have or can or need to make. There were some recommendations that Courtney DiNardo and Andrew Way published in 2020. I put the paper reference there. But the point is that it's a major step forward adding venetoclax to azacitidine. So what are the principles of low intensity therapy with venetoclax? I'm just going to spend a minute on this slide. The first goal is to get somebody into complete remission, restore hematopoiesis. That's really been associated with the best outcomes. Importantly, though, some responses evolve slowly, and there's an advantage of continuation of treatment, even if they're not in remission, as long as that patient has not progressed. So in the absence of progression, patients should stay on therapy with appropriate dose reductions, and there are definite advantages to preventing progression, even if you're not achieving remission. In real life, no surprise, compared to a clinical trial, the median survival is shorter. These patients aren't as fit, or they're in community settings, or don't have access to the same supportive care. And several trials show that to be as low as 8 months, although we still think that's longer than without venetoclax. In practice, in community practice in the United States, more than 80% of patients get treatment schedule modifications and dose reductions, mostly from cytopenias and toxicity. But as long as they stay on therapy under monitoring, it doesn't, in most cases, appear to impact the treatment benefit in the responders. So I think that's giving us permission, once somebody gets into remission, to scale back on the duration of venetoclax or even of azacitidine to maintain them on therapy and make it tolerable hematologically. There is a real risk of tumor lysis syndrome. Now, I used to go around saying I didn't see it, but if you look at some academic series, 18% of patients will get biochemical tumor lysis syndrome, and 5% will get acute kidney injury. So you do need to watch for this with cycle 1 of therapy. And infections lower the survival rate, so patients should be on prophylaxis for fever, neutropenia, and monitoring for pneumonia and infections. I think an important thing to say is that despite somebody being on this continuous therapy, being on combination azacitidine venetoclax does delay the time to a drop in quality of life versus azacitidine alone. So even if they don't show quality of life scores increasing as we did with intensive therapy, we're showing maintenance of quality of life scores for longer with treatment than without. MRD negative remission is a thing with low intensity therapy in the so-called unfit population. Using flow cytometry for measurable residual disease, Keith Pratt's in the Viallier study showed that you can achieve an MRD negative complete remission, excuse me, with azacitidine venetoclax, and it happens more slowly. A quarter of the patients early, a quarter of the patients after 4 cycles of, another quarter of the patients after 6 cycles, and then the rest can happen sometime later. So if you don't achieve molecular remission early on and you're using a flow-based assay, A, be patient, keep that patient on treatment, and B, they may actually convert to MRD negative later. And the reason that's important is there's an advantage for the patients to get into MRD negative remission. As you can see, there's a significant survival advantage. Their risk of death is, almost, more than 70% reduced for the patients who achieve flow MRD negativity versus those who do not. So it is a goal of therapy to keep people on treatment, achieve a remission, continue therapy, and if you're able to assess for an MRD status, in this case with flow, using a reliable assay, of course, that's meaningful for the patient associated with better outcomes. We don't really know the optimal duration of venetoclax. So I have a number of different papers that are from Mayo data, mostly run by my colleague in Mayo Rochester, Systemic Angat, looking what is the optimal duration of venetoclax. In our studies, 14 days and 21 days retrospectively were similar. We favored 21 days. It wasn't significant, but it was a little higher if you have adverse ELN risk factors by karyotype. But we didn't see toxicity differences, and we're commonly giving 21 days to patients, and even in some situations off protocol, considering shorter durations of 14 days. There is even some 7-day data out there. Even though we're talking about unfit patients getting low intensity therapy, some of these patients become transplant candidates, and I want to ensure that that's not lost sight of. This is data from University of Colorado, where Dan Pollier looked at almost 120 patients getting aza-venetoclax. About half of them were considered for a bone marrow transplant consult. Of those 58 patients, 52 were considered eligible. 21 of those went to transplant. The other 14 decided not to because they were doing well or declined transplant. But you can see there was a significant advantage of getting a transplant versus not getting a transplant in the patients selected for it and in the patients eligible for it. So once somebody achieves a hematologic response, it is very reasonable and indeed appropriate. Often the performance status improves, and there's a benefit of transplant. In some cases, long-term remission you can see lasting beyond 3 years. You know, we know the concept of treatment-free remission well now from CML with ABL-based or the BCR-ABL TKIs, and we're getting some experience about treatment-free remission after venetoclax-based therapy. Now, I'm not endorsing this for all patients. I'm just showing that it is okay when you need to stop venetoclax if that person is in remission. This is data from a couple of centers from Colorado and from Australia. They looked at 146 patients. They took the 20% who were still on therapy after a year, and then they looked at the patients who stopped venetoclax and azacitidine versus the ones who continued. The people stopped it for medical reasons, sometimes personal reasons, prolonged cytopenias, but still in remission. And it turns out that when they stopped it, it wasn't worse than continuation. It looked a little better on the curves. The red curve looked better than the blue curve, although it wasn't quite significant. But you can maintain remissions for several years in some patients if they're in a prolonged remission and struggling with cytopenias. I've had several patients opt to stop therapy, be observed, and even consider restarting if in one case recently when they progressed. So not saying that this is the right thing to do for everybody, but reasonable for the select patients who are struggling with tolerating this, who have personal reasons, but have had a response to therapy and they've been on for at least 6 or 12 cycles. Importantly, not all patients benefit equally from venetoclax. There's a uniform increase in the complete remission rate, but adverse doesn't do as well as intermediate or favorable or the rare favorable risk AMLs. And not every subgroup showed a survival advantage. If you look at the Viallier study, all groups had higher CR rates with venetoclax than without it, but they did not all have the survival advantage. If patients were over 75, it wasn't significant. If patients had poor risk cytogenetics, a FLT3 mutation, a TP53 mutation, strangely even an NPM1 mutation in those subgroups. Now, the Viallier study wasn't stratified by this. This is a post hoc analysis or a retrospective analysis, but it raises the question, are there groups where we get a remission but we're not prolonging survival? How do we identify them? How do we do better for those patients? And again, I mentioned transplant already, but those are groups of patients where we would definitely consider transplant once we actually achieve a hematologic response if we don't think we're going to get a prolonged remission based upon their subgroup. And there are a couple of different decision analyses that have been published. This is Mayo data that I'm showing you, although there's recent data from the BEAT AML study, of which we also contributed, showing the same thing. This is Mayo data looking at 300 patients to see who's going to do better or worse after therapy. And we identified IDH2 mutations predominantly improve with survival, TP53, FLT3, RUNX1 mutations with worse outcome, ELN adverse risk type, or not getting a remission. And we're able to break the patients down into those who had a good remission and had more favorable genetics. You can see on the green curve where at 4 years we have more than 40% on long-term survival, and a high-risk group who had mostly TP53 mutations or didn't achieve remission who do poorly. And so I think we can start to predict early on who's going to get prolonged benefits from this and for whom we need to intervene, consider transplant, different maintenance strategies, or even clinical trial options. BEAT AML had a very similar classification. They also identified MLL2 mutation and KRAS mutation as being adverse. So I think we're really seeing, and some of that's not surprising. You don't get a remission, you have a TP53 mutation, your outcome is going to be worse. But it's important to have that awareness and that discussion with the patient. Oh, one other thing about this data, I apologize. In the upper right-hand corner in the B panel, you can see that for all of those groups, the better and the worse groups, there seems to be an impact of allogeneic transplant. Again, we're selecting the best patients for transplant who have donors and social support and get a response to therapy. But it does matter to be considering transplant, even in patients who were considered unfit for intensive therapy. They can sometimes still become candidates for transplant. We've started using in some of our frail patients or cytopenic patients a once-a-week schedule of venetoclax and decitabine. It's what's called a metabolically optimized, non-cytotoxic, low-dose weekly decitabine venetoclax strategy. This is data from Mount Sinai in New York, where they had a cohort of 39 patients where they came up with what's called a metronomic schedule of giving once-a-week venetoclax, and then the next evening venetoclax, the next morning getting low-dose decitabine. That decitabine dose is 0.2 milligrams per kilogram and comes out to about half the dose we would normally give. And so on a once-a-week schedule, they actually were able to keep people longer on therapy. They had slightly higher rates of transfusion independence, and they were showing clinical benefit. Now, we don't have survival. There is some survival data. We don't know how robust that is. They've recently published a follow-up letter in Blood last year of an additional 31 patients where they showed that 90% of people who you would not have expected to otherwise completed their first 3 months of therapy on schedule by giving once-a-week venetoclax and decitabine on the schedule, with remission rates of almost 60% and a median survival of 16 months. This was a mix of oligoblastic AML, some high-grade MDS. These were selected to be more frail or unfit patients, but there is a low-dose option, and we've been using that in select patients and like the clinical benefit we're seeing for it and find it to be tolerable on an outpatient basis. I would be remiss if I didn't mention that I think there's very good data in the older or unfit population or unsuitable for intensive therapy if they have an IDH1 mutation to get an IDH1 inhibitor, ivosidenib with azacitidine. This is data from a couple of years ago. Median survival is was very good, 2 years. And I think if they have an IDH1 mutation, most of us bias towards this versus azavenetoclax, although IDH1 does better with azavenetoclax than other mutations. So we don't have a clear comparison between the two, but this is an option many of us pursue. There are triplet combinations being looked at in this population. For instance, there was a study of cladribine, levetiracetam, venetoclax, CAV, high MRD negative remission rates in adverse risk group. We have no comparative data. We've used this. We find it a little harder. We're not sure if it's better. So it's an option, but we don't have anything to compare it to, so we're not using it routinely. For FLT3 mutated, there's very nice data in the relapse setting of adding venetoclax to a FLT3 inhibitor, gilteritinib, and in the first line, aza-ven gilteritinib with very high remission rates, very high early MRD negative rates using flow cytometry. I would say this is a little more involved. You have to pay close attention to the dosing. It's abbreviated. The gilt dose is lower. There are more cytopenias and high rates of infection, but it does get a deeper, faster remission. Now, I told you earlier, be slow and steady, get the remission when it comes. I don't know that a faster remission is better, but if you need a fast remission, this is a way to do it for FLT3 mutated and might facilitate more patients getting to transplant. And we really need some comparative data to know when we should be applying that routinely off protocol. TP53 is a tough one for us. You know, we've seen this, despite low intensity therapies, we've not seen a survival advantage. You can get remissions. You can get remissions that show decreases in the TP53 VAF to very low levels. We've looked at with decitabine or with azavenetoclax, but we're just not improving survival yet. We've been entospletinib, a SYK inhibitor, pevonedistat, in a trial that we ran at Mayo Clinic through Beat AML, and also other things in the Beat AML consortium. We don't have a hit yet on TP53. We've had multiple clinical trials recently in high-grade MDS also that have failed, and so we're waiting to see what our next best option is there and actually looking at clinical trials specifically in this situation. Now, I'm putting up this slide because I'm going to talk about relapsed AML. What happens in the unfit or unsuitable patient after venetoclax fails? Excuse me. And that is a really hard situation. I refer back to Greek literature for this one. This is Odysseus. I long for home. I long for the sight of home. If any god has marked me out again for shipwreck, my tough heart can undergo it. What hardship have I not long since endured at sea and in battle? Let the trial come. And that is the trial of relapsed and refractory AML after venetoclax. It's a really hard situation. You're probably aware of the Skeleton Coast off the west coast of southwest coast of Africa, which has the largest number of over 1,500 shipwrecks along that coast. I can't say it's the largest number because the Mediterranean may have more from ancient times. But this is a really difficult area to pilot, the area of relapsed AML after venetoclax failure. So what happens after venetoclax? Well, in reports from MD Anderson and from Mayo Clinic, median survival of 2 or 3 months. Approximately 20%, in one study up to 30%, would respond to intensive salvage therapy. But that's a very selected patient. Unfit for intensive therapy, gets azavenetoclax, relapses, who gets intensive salvage. So that's a very tough situation. There are anecdotes of targeted agents if they have an IDH1 or IDH2 mutation. And these are patients we would strongly consider for clinical trials. We at Mayo, we looked at the absence of a TP53 NRAS or SX01 mutation, found that patients did a little better after relapse if they did not have those, but boy, it wasn't good. And so that's a hard situation. And we do have some anecdotes. We used the triple CAV combination in a cohort of patients between the 3 Mayo sites, cladribine, cytarabine, venetoclax, to try to regain remission. This is 39 patients. You can see 28% remission rate. A few patients, 7 of the 39, got to a transplant after first-line venetoclax failure with the CAV regimen as salvage. And you can see the 1-year survival in that group is 24%. So yes, it was better to get transplant, but that's, again, a really tough situation for patients and tough group of patients to treat. And that's why we're focusing on clinical trials or, frankly, palliative hospice care in this situation. Now, one of the new exciting areas for clinical trials, many of you may be familiar with this already, are the menin inhibitors that are targeted to the HOXA9 MEIS1 pathway. It's overexpressed in AML, particularly in patients who have a KMT2A, which used to be called an MLL rearrangement, or an NPM1 rearrangement. Now, NPM1 is one of the most common mutations in AML, almost a third of patients. KMT2A, much less common, that translocation or rearrangement, 5 or 10%. One is by sequencing, the other is by cytogenetics and FISH to find KMT2A rearrangements. We're finding we're going back to FISH, which we've kind of given up on in AML to identify those patients if we're not seeing it on cytogenetics or we suspect it. And the menin inhibitors, which interfere with the interaction of menin with that complex to decrease the HOXA9 leukemia proliferation pathway and to actually encourage a differentiation pathway instead. There are promising agents, revumenib, ziftomenib, bleximenib. We've been a part of these studies, and actually revumenib is now FDA approved. I want to just say you're familiar with differentiation syndrome already, but I wanted to say it out loud that when you get new agents, you get new toxicities. Differentiation syndrome is a significant issue with the menin inhibitors. These patients, especially if they have active or residual leukemia, can differentiate even a little later in their course, up to 2 or 4 months, if they have persistent disease. We try not to stop the agent. We try to do supportive care with hydroxyurea, dexamethasone, diuretics. But it is a real issue, not just with ATRA and APL, not just with IDH1 and 2 inhibitors, but now with the menin inhibitors as well. And you can imagine that makes sense. You're trying to move the phenotype of the leukemia blast from proliferation to differentiation by targeting that pathway. And so it's not really a surprise. The first drug, revumenib, this is a Nature paper from MD Anderson and Memorial Sloan Kettering. And it showed activity with responses in about 30% of patients with a KMT2A rearrangement. And this was approved in December for patients with acute leukemia. There's relapse refractory with a KMT2A rearrangement. And so we now have an option that's FDA approved and that we can get covered by insurance for that particular group of patients. We've been heavily involved with one of the early menin inhibitors called ziftomenib, 35% remission rate in MPN1 mutation, relapse refractory disease. It takes a month or two to get into remission. The remissions last about 8 months, give or take. 22% risk of differentiation syndrome, so patients have to be monitored. But this drug is moving forward into pivotal trials, expanded phase 1 trials, and now randomized trials for this and revumenib are being developed, and bleximenib in fairness. So these agents are here. They're even being used upfront setting. Josh Zeidner from UNC presented this at EHA and then at ASH, adding revumenib to aza-ven if you have an NPM1 mutation or a KMT2A rearrangement. The accrual is updated since I made this slide, but very high remission rates, over 90% composite complete remissions, very high MRD negative remission rates, very good 1-year survival of over 60%. Still an ongoing risk of differentiation syndrome when you add revumenib to aza-ven, but for those patients, we are now going to be looking at triplet combinations, low intensity for the unfit, unsuitable population, or with 7 and 3 for the intensive population, to really look and define the efficacy of taking this drug with a 30-ish% response rate, maybe even 40, and moving into the first line setting in combination. And so these guidelines are a little out of date already. This is from 2020, but these were some ASH updated guidelines on older patients with AML. And the answer is you should treat versus best supportive care. You really should offer therapy. Intensive therapy if eligible, and then post-remission therapy. Otherwise, low intensity, mostly with HMA and venetoclax, and continued until progression or unacceptable toxicity, knowing that you can reconsider transplant or even treatment-free remission in select patients, and ongoing access to transfusion support. I think it just behooves us to offer more to our older patient population. I wanted just to show a slide or two on cell therapy because this is going to be relevant for patients even if they're not candidates for intensive therapy. We know there are particular challenges with CAR-T in AML, finding the right targets, mechanisms of resistance, the on-target but off-target effect or off-tumor effect where you're targeting CD33, you're targeting CD123. So finding what the right target is, trying to leverage CAR-NK cells. We're actually moving forward with CAR-NK-based trials really in the next month or two at our site, and it's happening in multiple sites nationally. It's been a lot harder to find the right target, leverage the right immune cell population, and to overcome some of the mechanisms of resistance in myeloid leukemia, which are unique. and different than those in ALL or B-cell lymphoma. We're starting CD19 is a little more straightforward. One of the really exciting presentations or publications was last year in New England Journal, based on the ASH presentation the year before, of a CD7 CAR T followed by haplotransplant for acute leukemia with CD7 expression, mostly AML, some ALLs. And this was done in China. It was a small cohort, 10 patients. Some got some low-grade cytokine release syndrome, but they were able to get remissions, achieve donor chimerism, and some of these remissions were durable. So it's telling us as a proof of concept this is possible. I didn't talk a lot today about the issue of haploidentical support or transplant in the older population. That's really a separate talk, but outside of China hadn't been done like this, and I think that's something we're going to be looking at to try to leverage or exploit. So I'll wrap up by saying that there are AML classification changes. We think there's going to be a reconciliation of those two different versions of what is AML. I'm still in the you know it when you see it category when it comes to proliferating AML versus indolent AML or smoldering AML or oligoblastic, and tailoring your therapy to that patient's needs. Real world data and more robust decision models are guiding treatment decisions, helping us incorporate genomics into modern therapy, and we need better strategies for that. There's the AML risk model website for intensive therapy, and we need to develop something more robust for low intensity. Be patient with treatment. Give patients time to achieve their maximum response. Allow dose reductions and treatment holidays when you need to, and we're waiting to see what happens with triplets. I'll kind of abbreviate by saying that we're still working on a reliable MRD platform. The menin inhibitors are here. We're looking at the combination studies, and even unfit or unsuitable patients become candidates for allogeneic transplant, and hopefully we'll have better cellular therapy options for them in the future. And I'll finish this with a quote by Dr. William Mayo, the father of the Mayo brothers, who said that the best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, a union of forces is necessary. And that's like why meetings like this are so important and collaborations are so important, and why I'm so happy and honored that I was selected to give this presentation and try to find ways to collaborate and share information together. So I'll stop there, and thank you very much for your attention.
Thank you, Dr. Foran. For the sake of time, we have room for one question. I'll share all the other questions via email with you. If there are any, and I'll just go ahead and ask that question. We're all very well aware of the shortfalls of the ELN classification, and I think we've talked about this last month when I was in Florida. There are a lot of patients who have classically favorable risk disease, but somehow they end up having other co-mutations that might carry a higher risk stratification, but they're not accounted for in the ELN classification. So the typical example is an NPM1 patient with a couple of high-risk mutations, such as a spliceosome mutations or something like that. So how do you handle these cases? You're muted, so you're going to have to unmute yourself.
I'm still trying to get a handle on mutational complexity, and it's hard to know. You really want to know what's the driver mutation in that group of patients, and a spliceosome mutation with an NPM1 is kind of a mixed bag. We'd still focus on the NPM1. We would be looking to see, do we still detect that in remission? We have an NGS MRD platform rolling out this quarter, and MRD would dictate transplant strategies in the older adults. But I think that's a really tricky area. We need better data sets for that.
All right. Well, thank you very much. I think we'll stop here and we'll end this session. Thank you again for joining us, and hopefully we'll have you in Jordan either later this year or maybe next year. Thanks again.
Thank you, everybody.
Good afternoon, or good evening, actually, everyone. So our next speaker at our next session is going to be one of the most interesting sessions, talking about early lung cancer. I'm biased to say that, but we have a very interesting and, a leading figure in lung cancer, Professor Maximilian Hoschmeyer. He's the leader of the respiratory oncology unit in the Department of Respiratory Critical Care Medicine at Clinic Philodrosov in Vienna. He completed his lung training as a lung specialist in 2008.
And, you know, in addition to his clinical and scientific responsibility, he was on the board of Australian Society of Pulmonology from 2008 and 2014. And he was the national delegate for European Respiratory Society from 2011 2014. His scientific interests covered the entire field of pulmonary with numerous national and international publications. It seems that interestingly in Australia and Germany, pulmonologists really treat lung cancer. So without any further delay, I invite Dr. Hochmeyer to present his lecture.
Thank you very much for your kind words. I always call me a pulmo-oncologist like Martin Reck. I think you know him very well. He's also a pulmonologist, and we try our best. We have education in oncology and we have education in pulmonary diseases. So this is the reason why. And nowadays I'm not doing also lung cancer. I'm not treating only lung cancer because we have so many cases in our country. I'm sad that I couldn't come to Jordan. We have here in Austria -3 degrees. We had a little bit snow, and it's really cold, so I'm freezing even in my room where I'm sitting. I could imagine your temperature is much, much cozier than in my country. Here's my disclosure. Lung cancer in Vienna, we have about 800 new diagnosed cases in Austria, in our center, and we try to collect these patients that are really dead at the end treated in our center. And here we have a registry, and here you see stage 4, early stage, and local advanced stages. And who is counting for the early stages? I would not always say that stages that are advanced are never for a local therapy. We can say the better our treatments are, the easier we get these patients to a local therapy. But normally early stage, we mean this group of stage 1, 2, or earlier stage 3 patients. On the other hand, we are now treating patients already since 10 years sometimes when we find the right target, the right strategy, and also discussing local treatments. Just to give here an advice in this setting, and it's also integrated in the new lung cancer system that we also have to separate between M1C1 when it's only one organ, M1C2 when there are multiple organs, also for the lymph nodes. This is how we work in our center. We have here the first symptoms of the patients, the first clinical contract, biopsy, and then histological report, including NGS. And I think this is the most important point where we really can be active and where we can improve. And we have now an NGS machine where we get the result after 2 or 3 days that we can do our targeted therapy or exclude patients without a target in situations like that. And then we can optimize our treatment. And also for early stage, the measurement of NGS is extremely important in this setting. Which mutations do we find? EGFR is for sure more rarer in our country in comparison to Jordan for sure, but we also have a lot of KRAS mutated patients in our center. The most patients have a KRAS G12C mutation. Generally, it's important to discuss everybody in the MDT. So we discuss each patient, but normally, to be honest, we have a standard of care of treating procedure for patients that are advanced and have no chance of a local treatment. These patients we don't discuss in the MDT. Here we have our guidelines, local guidelines, what we do. But for those patients with the patients who have just one single metastasis, who are needing a local treatment, these are patients that we always discuss in the MDT. When I started my education in the 90s in Berlin Charité, everybody said there, Max, please take over about these patients. It's so boring. We cannot do anything. It was very simple and a very few treatment options. Nowadays, we separate between driver mutations and different possibilities of immunotherapy. So the the developments of these patients is intense. We also know that when we test and find the right treatment, the patients are living longer. They are not living longer because they have an EGFR mutation or have a high PD-L1 staining. Even high PD-L1 staining is getting worse for the worse prognosis. So generally, we have to say it's important to test and treat the patient regular and in the right situation. We published this paper in the Lancet Health Europe to underline which markers we have to treat, which marker do we have to test, and which markers are optional. Here you see a masked markers, ALK, BRAF, BRAF, EGFR, MET, ROS1, KRAS G12C, etc. are masked. These markers are optional, where you can just understand better the disease in the setting, and also large panel NGS. Besides PD-L1, large panel NGS is clearly recommended in the setting. In some countries, still squamous cell carcinoma is not tested, but nevertheless, we also can find patients with a mutation. Sometimes it can be also adenosquamous carcinoma, but always think that we really should test everybody in this setting. When we want to summarize our treatment nowadays, we can say chemotherapy, immunotherapy, and targeted therapy are main options in the setting, but we have a huge development with bispecific monoclonal antibodies and antibody drug conjugates in different settings. Extremely interesting field. For example, we have a study running in the moment after chemo surgery. We're combining, in this case, pembrolizumab with an ADC or against pembrolizumab alone to also improve the outcome in the setting. So the mixture of all these different strategies are getting intensively, and we are learning more and more each day. The Keynote 189 study, don't be afraid. I will not focus on this study the whole time, but I only want to highlight when we saw and we published this data in New England, we have about 6,000 citations on this work. Chemo IO against chemotherapy, patients with EGFR and ALK alteration were excluded, and we have a clear overall survival benefit. But what I want to show you is when, and especially for early stage, the remission rate is here from 20% increased to 50% in the whole group. So when we treat patients with chemo IO, we want in the early stage, especially a remission and dose reduction. And here you can see with this strategy, we are reducing, we are increasing the remission rate and get more patients to local therapy. And I will show you this on our real world data set in this early stage. Even PD-L1 staining is 60% remission rate. Even PD-L1 negative ones had at least a doubled remission rate in this setting. The same for targeted therapy that are available in Europe. You see in EGFR, ALK, ROS1, we have different options in this setting. Now focusing on the early stage, where were we? Which options did we have? You see, with chemotherapy alone, disease-free survival against placebo hazard ratio 0.84. Overall survival hazard ratio 0.89. Really nothing astonishing that we are talking about. The same for patients after 7.5 years. The curves are coming together. So the need of adjuvant chemotherapy is really relatively limited, that we are not improving our outcome in this situation. When we look to neoadjuvant chemotherapy alone, what was presented in Vienna in August 2022, you see a modest impact of chemotherapy in this neoadjuvant setting. When we look now in our strategy, stage 4 patients receiving with driver mutations a targeted therapy, no driver, we're receiving immunotherapy or immunotherapy plus chemotherapy. But are we allowed to do that also only for stage 4, or can we put this data also in early stage? And from my side, a clear yes. I don't think that we have to separate between early stage and later stage in our strategies. On the other hand, we have labels and we have to consider that. But on the other hand, to go through each target all the time, no. Just one case in 2020 where we started to use chemo IO the first time in the early setting or local advanced setting. Here, 49-year-old patient, good lung function, not a fit patient. And you see here a tumor on the left side, squamous cell carcinoma, lymph node involvement, T4 and 2. The radiotherapist says, please make it smaller. The surgeon says, this is too big for me for surgery, infiltrating the mediastinum, probably pneumonectomy is necessary, please make it smaller. So we treated the patient in 2020 like it would be a stage 4. And then we did a CT scan, and you see, based on the RECIST criteria, on the criteria, how good is the remission when you just read the report, when you go for the diameter here, and you measure the diameter here also, you have a stable disease. But then we went for surgery, and in 2020, my pathologist called me and said, Max, there is no tumor anymore. And I had tears in my eyes, and I said, unbelievable, I never had that in lung cancer. Generally, the pathologist is always the most important person in my center because she's deciding at the end which treatment we need. But at this time, when she called me, I really said, this is astonishing. Patient received carboplatin, paclitaxel, pembrolizumab for a neoadjuvant treatment in T4 and 2, and we saw a complete pathological response in 2020. And the patient is still in remission. We would never think about that in the past. So this is, like you said before, the interesting topic, the astonishing or the life intensive, the really interesting topic in this field. Let's look about the data. Which data do we have in this neoadjuvant setting? For me, the king of the studies is the Keynote 671. Here, patients received chemotherapy plus immunotherapy against chemotherapy in resectable patients. We can always discuss who is resectable. Is it the patient also that could get resectable, or is it always only, in the studies, it was only those patients who were really initially resectable? But sometimes the surgeon says it could get, and then we end the discussion, what should we do in this setting? And the outcome for event-free survival for all groups, for the immunotherapy group, clearly better against placebo. Also for overall survival, a clear benefit in all groups, independent from the PD-L1 staining, a clear advantage for our patients. When we look more careful for these patients for the event-free survival, receiving also adjuvant treatment, yes or no, we always have a selection bias in these patients who did not receive adjuvant immunotherapy, but those patients who receive it also without, they always perform better when they received immunotherapy. So it has to be standard, even in these patients who could be operable. When we look at the overall survival, and I think when I showed you initially the curves, how good is the overall survival? We see here already now, even the follow-up is not finished, we see 10%, more than 10% difference in the overall survival for our patients, and I'm sure the curves will get separated more and more. So this, and why did I say the king of the studies? Because this is the only study that showed in this perioperative setting an overall survival benefit. I will show you also the checkmate X16 afterwards. Here, after longer follow-up, clearly longer follow-up, the overall survival benefit was released 2 days ago for this group. Here is also the overall survival, adjuvant, non-adjuvant, I will skip it. Here is the major pathological remission with immunotherapy and chemo and pathological complete remission. You see 20% of the patients have a pathological complete remission. But when we select our patients more carefully, and I will show you with our publication in lung cancer recently, that our rate of pathological complete remission, when you include NGS, is above 40. And this is important that we test patients more carefully. Also, when we do when we did the chemo IO and look at the pathological report, we have to look up how much tumor is left. When patients have nearly nothing anymore, they're 0 or less than 5% viable tumor cells, the outcome is clearly better. When you still have viable tumor cells, the outcome is clearly worse. And I think these patients who have still viable tumor cells need more. And this is the reason why we planned this study, adding Pembro against Pembro plus ADC in this adjuvant setting for these patients. Another quite similar planned study is the Checkmate 770, Nivo plus chemo against chemotherapy. And I have to say, till now, quite similar data, MPR, PCR are shown here, quite comparable data to the Keynote 671. Also, event-free survival, quite nice, with a good hazard ratio, like I showed you, also with Pembro comparable. What is important? Should we go for perioperative or should we go for only neoadjuvant? And this study, 770 against Checkmate 816, here just a neoadjuvant Nivo trial, and here perioperative neoadjuvant and adjuvant Nivo trial was compared. Here you can, the data are quite comparable, and at ASCO these data were collected, or WLCLC were collected and compared if there is a better outcome if you go for the perioperative strategy. And we see that the perioperative Nivo is performing better against only neoadjuvant Nivo in terms of event-free survival. So this not directly head-to-head, but when you put the studies not directly together, you can see that there is a better outcome for the perioperative strategies. Which study do we have? On the other hand, we also have Aegean, and all this with durvalumab, nivolumab, perioperative only neoadjuvant, and Keynote 671, different follow-ups, different types of studies, and you can clearly say that the event-free survival is clearly in favor. The only study that showed us an overall survival benefit was till now the Keynote 671, and the study with the longest follow-up with the Checkmate 816 with the only neoadjuvant strategy. 2 days ago, they showed us also an overall survival in a press release, but the data were not available till now. So those two studies show a clear overall survival, and this is, I think, the most important endpoint. But I have to say, Keynote 671 already relatively early. This was released at ESMO 1.5 years ago, and with a longer follow-up, shorter follow-up, and here now in the moment. So nobody knows at the end what is the right strategy, and I'm in favor of, like you heard, of the perioperative strategies. What you have to know and what are pitfalls in this situation. With chemo IO, we can have a pseudo progression. The remission is not always clear that you see immediately always a response. You can have a pseudo progression. And not always like that. You have the tumor here. Sorry for the German sentence here. You see here the tumor on the left side, and you have a complete remission. Here, a pathological complete remission is probably extremely possible. But we cannot say it on the CT scan that it will be for sure a pathological complete remission. So the surgeons will still, and I'm clear in favor that we still should do chemotherapy after chemo IO, here surgery. The problem is when we do PET-CT, like in this patient, tumor here, tumor here, tumor here, we do after chemo IO PET-CT, you still see activity, and you think there's still some tumor left. At the end, we had in this situation with the cavitation a T0 N0 situation. So the PET-CT can be sometimes misleading. Here, this patient was for sure not operable. Then we had the cavitation, and then we did surgery, and at the T0 N0. Nobody would think that we should not do surgery in this situation. And in CT scans, we can flip a coin. Here, patient after chemo IO, 60% viable tumor cells. Here, a CT scan with complete pathological remission. When really everything is away, it seems to be relatively easy to say complete pathological remission, but not for sure in this setting. What is the problem? How can we evaluate remission? You see here the tumor. After chemo IO, you can have more immune cells infiltrating in the tumor. And then you can have an inflammation, and this looks in this situation like you have a progression. But it can be only immune cells there, but it can be also the progression. And this makes the evaluation extremely difficult. Two cases that were extremely where we hesitated and we didn't know initially what can we see here, baseline tumor here on the left side, a T3 and 0 situation after chemo IO in PET-CT and 2 lymph nodes also here. And then we said, oh shit, this is now the worst thing you can have. You have a operable situation, resectable, and then you have an N2 disease. Normally a clear no for a resection. But then we said we do EBUS, find a lot of inflammation there, and then we went for surgery and at a T1A, N0, R0, and a nodal immune flare based on sarcoidosis in this situation. So normally now we learned that out of studies we do not perform PET-CTs because they could mislead us. Also here, one patient example, left-sided tumor decreased clearly, but in PET-CT you see a pleural involvement here. In the PET-CT was written M1A situation. The patient performed the PET-CT out of our hospital, was reading the results and said, "Ui, I have now M1 disease and now I'm not able to do surgery anymore." And then we said, this can be a pseudo flaring, a paradoxis remission. The main tumor clearly decreased, the new lesion were not here, and we went for surgery and had a good outcome. This is the real world data that I promised you initially, neoadjuvant therapy in early stage. We published recently in lung cancer 2 months ago, where we collected patients who received neoadjuvant chemo IO. And you see 72 patients were included and only 2 had a PD or death. 1 did not receive local treatment. The rest, everybody received a local treatment. And this is, I think, the most important point. And we have to say, this is a time that we have to check, that we have to think, what is the outcome for the patient? The patient is scared that he could not get surgery in the setting. And when we look at these patients, some patients were 3C or 3B, actually not classical patients who should receive surgery here in N3 disease with metastatic lymph nodes. But you see the pathological complete response rate is 47.8 because we excluded EGFR, ALK, ROS1, BRAF, ROS1 patients where we know that we should go for a targeted therapy. Overall survival data for our 71 patients starting 3 or 4 years ago in real world setting are really telling us a clear outcome. What can we do when the patient is inoperable? But this is something we have to discuss always with our surgeons. We can go for durvalumab in the Pacific trial, just to be correct that this is also a chance in this setting. At the end, only the next 2 or 3 minutes when that is left, targeted therapy touching. Generally, I said, let's treat patients in stage 4 and early stage similarly. The sooner, the better. We know the heterogeneity gets more, the tumor load is getting worse. So the sooner you use the better drugs is better instead of using it in a later situation. Do we have in NGS differences when we do NGS in early stage or advanced stage? From our data, we don't see any difference. One drug that is already approved in the early setting is osimertinib. Patients after surgery receiving EGFR in EGFR mutated patients, OSI or placebo. We have a clear overall survival benefit, for our patients. Even there was a crossover to OSI, we saw a clear overall survival benefit. And when you remember the adjuvant data I showed you initially, this is really a clear advantage for our patients. Also for alectinib, for Alina, I was also co-author in this study where we can say patients with ALK translocation, alectinib receiving disease-free survival and avoidance of brain mets clearly better, so alectinib is approved. My last two slides. We will see new event data for EGFR TKIs at ASCO, where patients received osimertinib or osimertinib plus chemotherapy against chemotherapy in the new event setting. And I'm really interested what is coming out here. Do we see only NPR? Till now, we didn't see any PCRs in this setting. Is targeted therapy different to patients with immunotherapy? It seems to be, at least in EGFR mutated patient, that the PCR rate is not there where we expected, and the NeoDaura trial will be presented at ASCO, and I'm really interested what's coming out here. I can skip that because my time is over, and I want to summarize. Please test, treat patients similarly, early stage, similar like to later stage chemo IO in these patients, mainly in patients without driver mutations. Thank you very much. Dankeschön from Clinic Floridsdorf, not Florida, Floridsdorf. It's not close to the Danube. Thank you very much.
Thank you, Dr. Hochmeier. I think for the sake of time, we have one question. If anyone wants to ask, if no one, let me ask you this question. Yeah, we know that the perioperative pembrolizumab had the overall survival, edge over the rest of the perioperative regimens, but we have now an overall survival for, I think, the new adjuvant Nivo. How do you put this in the context of clinical practice and financial toxicity?
This is what I highlighted. We saw 2 days ago in the press release that nivolumab is positive in the only new event setting. The follow-up is 2 or 3 years longer already, and the keynote study showed it already 2 years ago already. So I think the strength of the overall survival benefit is with the keynote study clearly stronger, but it's also possible with CheckMate 816. I'm not the financial officer in my hospital. I want to treat the patients in the best way. And we saw that perioperative is better against new event when we just look at Nivo. Pembrolizumab is used in stage 4 regularly. Why should it be different in early stage? But I would say we have no head-to-head comparison. All possibilities are possible. And when somebody is thinking he does it different, I think it's not wrong and also acceptable. But for me, the keynote 671, like I said, is not the queen or the king, let's say queen and king of the studies.
Thank you, Dr. Hochmeier. Hope to see you in Jordan soon.
Thank you. You're very kind. Thank you. Ciao.
السبيكر معنا مدحت معنا moving to our next session with us is Dr. Ankir Bal. He is a highly experienced and skilled cancer specialist with over 15 years of expertise. He earned his oncology degree from the All India Institute of Medical Science, New Delhi, and he is also a prominent founder and leader of various innovative oncology educational platforms and networks. He will be presenting to us recent advances and the utility of liquid biopsy in non-small cell lung cancer. Are you with us, Dr. Ankur? Dr. Bal.
Am I audible to the organizers? Am I audible?
The floor is yours.
Yes, yes. So just a minute. I'm just doing it. So my slides are visible to you?
Yes, visible. You
Yeah,
can go
thank you
ahead.
so much. Thank you so much, organizers, for giving me an opportunity to speak from India. And I'm Dr. Ankur Behel. I'm a director of oncology at Fortis Cancer Institute, India. And greetings from my country. And I was in Jordan last year, and it was a pleasure being among with you. And special thanks to Jordan Hematology Society for calling me in. So today topic is the utility of comprehensive liquid biopsy in advanced non-small cell lung cancer. As we know that non-small cell lung cancer is the most common cancer in any registry, and those patients in which oral cavity and other cancers are coming. So lung cancer is a prominent cancer in any registry in the world, and because of the smoking and all. But we have seen that in a decade or so, particularly in last 5 years or so, the amount of lung cancer in non-smoker female population is rising year on year. So as my previous speaker said, that this is an era where we should identify the driver mutation. It's not about the driver mutation. We should also identify the resistant mechanism, and our patients with
Can
lung
you move
cancer
your
should get the
slides?
maximum benefit.
Dr. Bal, can you move your slides manually?
Yes, I'm moving it. Can you see the movement?
We are still with the first slide.
Okay, then it's not moving probably. Okay.
قلنا له manually.
Can somebody help me in moving? I'm sharing my screen, but there's a problem. Can the organizers help me in doing that?
Can you move?
Can you share it again, please?
Okay, this is
Without the presentation button, you can use it manual. Select for selecting each slide.
just a second. No, I'm
Just
not able
start
to
the
do
sharing.
that. So in the share, I'm not able to do it. You guys have my slides. If you can help me in that. The entire screen, window.
You will find in the block, you'll find the PowerPoint button. Yeah, share it. Okay.
Nisarg, are you there?
Yes, we're still waiting for you to share your slides.
There's some problem at the end.
Can we share it from our side?
Not able to do it from. Can I? Yeah, please.
Okay,
Yeah, you
hold
please
on.
share. Somebody's writing. You can share the slides on my behalf, please?
Yes, in seconds, please.
Yeah. Yeah, thank you so much. So I'll say next, and somebody can move it on my behalf. So greetings from India. I apologize for this technical hitch, and greetings from India. And I'm here to tell you and share the discussion that how the utility of liquid biopsy in non-small cell lung cancer can actually help in the overall survival of our patients. Next slide. So we know that the cancer is a disease of genome, and the alteration which can be a driver mutation, which can be a fusion, which can be an indeletion, and these alteration in the DNA can the mistakes in the DNA copy causes the multiplication of these cells, and identification of this driver mutation is the key factor where lung cancer survival can be determined. And in our practice we feel that 30 to 40% of our patients, of lung cancer have these driver mutation, and if we check them in a comprehensive way, means that we check in a solid biopsy and complemented by a liquid biopsy, the identification of these mutations can increase, and which can lead to a targetable drug, leading on to a good response and overall survival benefit for these patients. Next slide, please. So conventionally, we were using tissue biopsy for the identification of these driver mutation, but lately the concept of liquid biopsy is coming up in a big way, and there are various advantages and disadvantages of this view. The advantages of the liquid biopsy is that it has a very high concordance rate as high as 80 to 90% if we compare with the conventional one. It is minimally invasive. We have to take a blood sample as we do for our normal routine test, and it can be repeated over time. The estimation of the circulating tumor DNA and various VAFs can be determined repeatedly if we have to identify the burden, and it's better capture the tumor heterogeneity and the clonal evolution. In tissue biopsy, we get a chunk of tissue, but that not be representing or that not be harboring that the mutation or amplification because of the heterogeneity of the solid tissue. The liquids overmine it, and it can overcome the heterogeneity and the clonal evaluation, and we might get a better driver mutation, and the yield can give us a high survival rate. However, there are some disadvantage of liquid biopsy, which includes a non-DNA biomarker, which is not evaluable. However, it carries an increased cost if used concurrently with the tissue testing, and there are theoretically false negative reports as well. So conventional tissue biopsy, the upcoming role of liquid circulating tumor DNA, and if complemented with the tissue biopsy, the yield of this biomarker, the yield of getting this actionable driver mutation can be increased, and which can help our patients in their treatment profile. Next slide, please. So the desirable quantity of a comprehensive circulating tumor DNA in advanced cancer, there are certain factors which should always be considered. The test should have an ability to capture the cell-free DNA, which is called as cfDNA. At times, we should be able to yield result in a low cfDNA output. It should be validated both clinically and analytically. And this test should have a high concordance with the tissue testing, which is our gold standard. And the test should have an ability to find uncommon alteration and co-mutation. Many times in our practice, we see that there are co-mutations which are along the driver mutation, which gives resistance to these tyrosine kinase inhibitor. And however, these tests should also have a pan-tumor biomarker testing like microsatellite instability and tumor mutational burden, which are the biomarkers in which we can give immunotherapy combined with chemotherapy or immunotherapy alone when this tumor harbors MSI and have a high tumor mutation burden, which can be more than 10 mutes per megabase in a solid setting, or in liquid, it could be more than 16 or 20 mute per megabase, and may complement the negative tissue testing results as well. Next slide, please. So how do we detect the DNA detection in our lab? So we take a sample from the blood, which is an easy bedside procedure, and this sample goes for a digital sequencing platform where single nucleotide DNA coding, which can have a conversion efficacy of 80 to 90%, and a hybrid capture of this DNA is followed by a PCR where standardized next generation sequencing test is done, and with various error and distribution corrected, the single nucleotide sequencing is done, and with this method we detect a mutation, deletion, various arrangement and fusions, and finally the report comes which tells us that this non-small cell lung cancer, squamous or adeno, is harboring either EGFR mutation at this exon, ALK fusion, MET amplification, RET, ERBB2 amplification. So report comes like this, and it have a concordance with the tissue one, but many times the yield of this report can be higher than the tissue if done alone. Next slide. So the So the performance of the liquid biopsy has been evaluated across various cancers. So non-small cell lung cancer is the majority, is a prototype or the gold standard in which the liquid biopsy has been tested and validated across various cancer. However, in other cancer like endometrial, bladder, esophagus, various GI cancer, it has been studied. But the prototype is lung cancer, in which the various reports in liquid biopsy have been documented. Next slide. So how do we validate this analysis, and what are the genomic iterations which can happen in these patients? So Garden 360 is one of the platforms in the world which detects various alteration type, which can be single nucleotide variants, which could be insertion, deletion, fusions like ALK, and a copy number amplifications, which have an analytical sensitivity and specificity close to 100%, and with the ability to detect microsatellite instability or an MSI instability, which can detect as high as 95% with sensitivity and 100% with the analytical specificity. So the Guardant 360 liquid biopsy has a good sensitivity and specificity to detect various SNV in deletion, fusions, or amplification number. Next slide. So the most important key question is that this liquid biopsy or this liquid cell circulating tumor DNA or a cell-free DNA should have a concordance with the solid biopsy. And the most important study which has documented is in non-small cell lung cancer treatment naive is the NILE study, in which tissue and the cell-free DNA was estimated, and the concordance rate in this study was 89.2 with the tissue, means that the tumor which is being the actionable mutation or an amplification, the alteration detected in tissue is similar to detected by liquid. And if we combine this liquid and solid biopsies, so our concordance rate is higher, rather than we get some more number of the patient which can be treated in a precision oncology way. Next slide, please. So the genomic profiling via circulating free DNA yields a similar landscape or tissue-based cohorts. This is a cohort of a colorectal cancer, in which we can see that the spectrum and the frequency of the alteration which is identified in liquid is demonstrate a striking similarity in a tumor tissue type. So similar number of TP53, APC, KRAS, NRAS, EGFR, and various other mutation, amplification, deletion are actually striking similar to the tissue biopsy reports. So this confirms that the liquid biopsy has a high concordance rate. If done in a good lab, standardized lab, it can be a substitute for a tissue if we are not able to get tissue many times in our clinical practice. Next slide. So similar is the case in GI cancer, particularly in biliary tract cancer, where tissue can be an issue, and 25% of the time in biliary tract cancer, we are not actually able to take the tissue because of the anatomical site of the tumor. It could be in pancreatic head or a cholangiocarcinoma, extrahepatic, or in cystic duct carcinoma. So in such patients, 84% of the patient samples have a detection, so we can detect this alteration in more than 80% of the patient. And in this study, the number of the patients who have detected alteration, 44% of the patient at least have a level 1 to 3B alteration, where a specific drug against FGFR or IDH mutation can be given. So a liquid biopsy can be a very useful methodology or a test, particularly in this subset of hepatobiliary cancer, where a tissue taking a biopsy is difficult, and we rely on cell blocks and FNAC slides only. Next slide, please. So it can detect amplification and fusion. So liquid biopsies, they are not inferior to solid ones to detect this amplification and fusions across various cancers. So ERBB2 amplification detection can be similar to the tissue when the tissue has a HER2 enriched, which is usually detected conventionally by immunohistochemistry or a FISH method, but this liquid biopsy can also detect amplification to the positive predictive value of as high as 80 to 90% across various studies in colorectal, esophagus, gastric, and biliary tract cancers, and various other solid cancers. Next slide. So it has an ability, so liquid biopsy has an ability to detect focal amplification in a cell-free DNA, which could be either MET amplification or a CDK6 amplification or an EGFR amplification and a BRAF V600E amplification. So it can detect focal amplification at times when a solid tissue misses through because of the heterogeneity and the clonal evaluation. So MET amplification, BRAF fusions can also be detected by this method. Next slide. So, and one of the fusions, which is rare, 1 to 2%, the NTRK fusion, we have two drugs, larotrectinib and alectinib, which can be used in NTRK fusion across any solid cancer. So this is a patient who was having EGFR tyrosine kinase inhibitor. It was an EGFR mutation. We treated this patient with osimertinib, then they had a response, and we did a liquid biopsy in this patient. We got an NTRK fusion, and this patient was added on, larotrectinib was added, and we got a response after osimertinib failure. So this rare mutation, rare fusions, NTRK fusions can also be detected. We have got many patients who have got NTRK fusion and have benefited with the anti-NTRK drugs to these patients. Next slide. So, and apart from the common mutations, which could be EGFR, ALK, ROS, MET amplification, HER2 amplification, we get uncommon and various complex alteration which can define resistant to the conventional osimertinib or conventional crizotinib. So liquid biopsy also detects uncommon and complex alteration. So detection of GFR exon 20 insertion by various platforms can be missed in a solid hotspot testing. However, if a good test in the form of either Foundation, Guardant, or any other CARES test is done, so the identification of this rare EGFR exon 20 insertion can be identified, and these patients can benefit with a specific drugs for this exon 20. Next slide. Next slide, please. So, so that's why so this test is important, because it can detect various other mutation like PIK3CA mutation beyond hotspot. So hotspot, everybody in our institute, we are in a habit of doing a hotspot testing in non-small cell lung cancer. But if we do a comprehensive circulating tumor DNA either in tissue or a liquid, so this comprehensiveness test, we can detect some rare mutation like PIK3CA mutation, which are not picked in hotspot, and these patients can be benefited by a specific PIK3CA targeting agents. Next slide. So as we said that it can identify co-alteration because the tumor heterogeneity and the clonal evaluation is lost, and we can get some other mutation in KRAS G12C mutated non-small cell lung cancer. We can have other mutation like KSE wild type or a KSE mutation. We can have an EGFR mutation by the side. We can have an ALK mutation by the side. So these uncommon co-mutations can give a resistance pathway, and these patients do not responds conventionally to the single TKI. So we might have to do something more, either add a bevacizumab or add another TKI so that this patient can live longer. Otherwise, they carry a resistant pathway in which conventional drugs do not react. Next slide. So the influence of co-mutation on the outcomes can matter if the same patient, because of the heterogeneity, is having co-mutations, 2 mutation, 3 mutation. So at times we target only one driver mutation, but the patient do not show a clinical outcome on the first and subsequent PET scan. So this test can identify, with the help of co-mutations and other similar alteration, we can identify and precisely tell that the patient may not respond to a conventional TKI, and we have to do something more than conventional TKI to treat such patients. Next slide. So this test, this liquids biopsy test, should have ability to detect pan biomarkers like MSI. So Garden 360 liquid biopsy clearly detects microsatellite instability, and we know that those patients who are microsatellite unstable, they respond to checkpoint inhibitor, and the positive predictive value is very high. So this test can actually identify MSI stability in as high as 80 to 95% of the patient. Next slide. So, and the plasma determination of tumor mutation burden, and in tissue, the tumor mutation burden is called as high if the TMB is more than 10 mutes per megabase. So in liquid biopsy, if the patient has a high TMB defined by more than 16 or more than 20 mutes per megabase in various combinations, so these patients can be having a serious beneficial effect with addition of immunotherapy to the chemotherapy regime or immunotherapy alone. So in nutshell, I want to say that the tumor mutation burden, MSI stability, which are pan biomarkers, these tests, liquid biopsy test, the circulating tumor DNA testing, comprehensive NGS can detect these biomarkers as well. Next slide. So the comprehensive circulating tumor in non-small cell lung cancer is beneficial, and across various guidelines, the incorporation of this test is useful. So this is important, which impacts the screening times and the failure rate, because if we get a small tissue on a screening test and a tissue biopsy cannot be performed because of the site of the tumor can be deep and it can be in the middle part of the lung, so the biopsies are difficult. So screening failure happens in 20% of the time. In around 20 to 25% of the patient, the tissue quantity is not sufficient for molecular profiling. It takes a time. The solid NGS takes 21 days, and the appropriate purpose of screening can be lost. So this liquid biopsy can actually detect the circulating tumor DNA, and it can also detect the alteration. So the primary reasoning of screening failure among biomarker eligible patients, so this liquid biopsy can be of help in patients where tissue is difficult to get. Next slide. So the tissue and circulating tumor DNA testing in treatment-naive patients. So it as we have seen in the Nile study, and so if we combine tissue testing and the liquid testing complementary, so our yield can be high, and the concordance rate being very high, and the TAT of liquid being just 7 to 10 days as compared to the TAT, the turnaround time in solid, which can be 22 days to 25 days. And it also depends which part of the world you're sending these samples. So we in our practice see that in 10-12 days we can get a liquid biopsy report, and we can take action on the basis of those report. And then finally the solid also comes if we have given a complementary testing, and we can do the concordance, and these patients do much better if we get an early TAT time, and the response in lung cancer can be achieved with this TKI drugs very fast. Next slide. So this is a PEN2 where they said that the PEN2 study, which says that NSCLC, non-small cell lung cancer mutation detection by plasma and tissue testing, and if we do a tissue testing, it is usually 21% detection rate, and it was in plasma, it was 29. But if we combine the tissue and the plasma, if we do a dual testing, that as high as 30 to 40% of the patient can get this driver mutation. And if we do, next slide please, if we do the treatment of these actionable detection mutation, we can see in this waterfall curve that in first line, second line, and any line, the overall response rate can be as high as 70% and 40%. First line 70%, if we detect a right mutation and the right drug is given, the disease control rate can be as high as 85 to 90%. So PEN2 study clearly said that the clinical response to target therapy increases if we do a dual testing by a liquid and a solid in a first go. Next slide. So the acquired genomic alteration, when we have, so in the second line, when the patient progresses after the first line TKI, whether it can be erlotinib, gefitinib, or osimertinib, so when the patient fails on these drugs, then it's a real challenge. And all the guidelines says that we should do a repeat biopsy and detect alteration, a new driver mutation or a co-mutation or a new clonal evaluation has happened. But at times when a disease has relapsed, so solid biopsy many times the patient refuse, and many times we do not have an adequate tissue. So liquid biopsy at that time, at the time of relapse, is very important. And we have seen in many times that the resistant mechanism to anti-EGFR agent, which it can be osimertinib or erlotinib, we find various pathways like MET amplification, PIK3, BRAF, and many other ALK fusions and all can happen after the first line failure to osimertinib or ALK inhibitors as well. Next slide. So Garden 360 helps in detection of the ALK fusion and various resistant pathway. So if we detect a mutation on the baseline and on relapse, so we see that in 10 to 20% of the patient, there are some new fusions and new alterations have happened, which can detect and which can tell us that the resistant pathway. And many times we are successful in getting a new mutation so that we can treat the patient with a new TKI or new chemotherapy or an immunotherapy combination to treat such patient in a relapse setting. Next slide. So the guidelines which we follow in our practice is NCCN guideline and NCSite guideline clearly depicts that a complete genotyping testing for various driver mutation like EGFR, KRAS, ALK, ROS, BRAF, NTRK, MET, RET, HER2 amplification via biopsy and a plasma testing. The combination of a tissue and a plasma testing either concurrently or in sequence are acceptable. So the guidelines clearly say that, first of all, a comprehensive genomic sequence should be done. These lung cancer patients only give us a chance in a first line setting. And if we rely on our hotspot testing, and if we do not do a comprehensive genomic testing, we might be missing 18 to 20% of these mutations, and these patients are given unnecessary chemotherapy and targeted therapy or immunotherapy, but they want a specific TKI. So if we do a comprehensive genomic sequencing profiling of these patients and we have a tissue and a liquid approach, then the yield can be increased and these patients will survive longer. And this is a reason that the 5-year survival of lung cancer patient of overall all over the world has increased, because by the detection of these driver mutation by a comprehensive genomic profiling. Next slide, please. So this is a very famous study from your part of the world, the genomic landscape of advanced solid tumors in Middle East and North Africa, the MENA area, using circulating tumor DNA in a routine clinical practice. This was published in Oncology in 2024 March edition. Next slide. This says that a very good sample of around 900 patients were analyzed, and the most common, as I said, any cancer registry will say that the lung adenocarcinoma is the most common cancer. And this sample size also had breast cancer patients, colorectal, pancreatic, ovarian, prostate, and other cancer type. The table detects what was the stage and the male to female population. Next slide. You can see that the biomarkers which were detected in these 926 patients were EGFR being most common, KRAS G12C, ERBB2 amplification, ALK fusion, BRAF, MET. So characteristic classical driver mutations were being found in this very simple study of 900 patients by a circulating tumor DNA analysis. Next slide. So this is a deep dive, EGFR deep dive. So they have done further EGFR dissection, like exon 5, 6 were present with the frequency exon 18, 20, 21. So they have clearly determined that what was the kind of the EGFR mutation in such patients. Next slide. So the beauty of this liquid biopsy is that it captures heterogeneity. So co-mutation with EGFR, LAT5R, you can see there are many co-mutation. These patients harbor many other mutations also, and this co-mutation can happen with a classical 858R or a exon 19 deletion. So it has a beauty of capturing many other co-mutation in a simple one sample. Next slide. So as we have seen in literature, so the EGFR mutation was the most common one, then was KRAS G12C, ERBP2. So the in the MENA region, this 926 samples captured classical mutations, which are seen all over the world. Next slide. So I'll just present in next 2-3 minutes a few of my cases. This was a 65-year-old female, and she was an adenocarcinoma, non-small cell lung cancer, asymptomatic brain metastasis. As we all do reflexly, we have sent a tissue NGS in our local lab. Next slide. So in local lab, we did not find any mutation since she was a non-smoker, adenocarcinoma, and a female. I just pressurize them for a better test. We send the sample, both liquid and solid, to a Guardant, and we found a classical EGFR mutation both in solid and liquid. And this, next slide, please. And this patient was given arlotinib, and she responded beautifully, and she's still alive. So this clearly gives a message that a test which a local test missed driver mutation, but a comprehensive genomic sequencing by a better analytical, better validated test was being sent, and we got a simple EGFR mutation, and this patient responded to the simple drug, and she's living happily. Next slide. So this is a case 2. This patient presented with cervical lymph node, SVC syndrome kind of picture, and we did a biopsy. And reflexly on the first visit, I sent her solid and liquid, and within 8 days we found a ALK fusion. Next, you can please proceed. We found an ALK fusion, and we treated this patient with lorlatinib. And hotspot was sent to India. It was negative, but ALK fusion was found, and we gave this patient lorlatinib, and she had the SVC syndrome, and the clinical response, the lymph node disappeared, and the PET scan showed that she's right now on 12th month of lorlatinib 100 mg and doing very well. So we can see the PET scan, all the lymph node disappeared in first 2-3 months of lorlatinib, and we got this testing result within 7 to 8 days. And the fastest ALK report in liquid biopsy was this patient for mine. Next slide. Next slide, please. So this is a patient who got a chemotherapy, many lines of chemotherapy, and then a liquid biopsy was performed, and we've got a red fusion in the liquid Guardant biopsy, and we started the patient on pralasetinib, and we got a near complete response with this anti-red fusion drug. Next slide. This is a patient who presented to us with pneumothorax. He was on oxygen, and we could not take the biopsy. We did a blood biopsy, and we got an EGFR mutation. We gave the drug, and this patient had a beautiful response. The pneumothorax disappeared, and this patient is still living. So the point is that if we combine liquid biopsy with solid in lung cancer, we can have these driver mutation, and these patients will do better. So liquid biopsy with solid is going to be the standard of care, I think, in next 2-3 years, and many mutations will be found, and many millions of patients will be treated by this approach. Thank you so much, organizers, for having a patient listening, and I'm open for any questions or comments from your side.
Thank you, Dr. Bal. Sorry, we are running out of time. Maybe only one question. Do you have any question? I want to ask you a question regarding when you look at the NGS report in Guardant, let's say, and see the tumor fraction percentage, whether 1% or 70%, does it reflect on your conclusions?
Yes, absolutely. So if it reflects to my conclusion, I have to see the quantity of the tumor fraction, but particularly in liquid biopsy, even a miniature 1 to 2% of that tumor fraction is considered important, and we treat such patients with TKI if we get a driver mutation for such patients.
Thank you. Any questions? Thank you, Professor Bal. Thank you.
Thank you.
We move to the next session.
Thank you.
مرحبا دكتور، كيفك؟ عشان التقديم. أنا حضرتك إن شاء الله. مساء الخير. نبلش. I am delighted to introduce Dr. David Binato to our conference tonight. Dr. David Binato is a clinician, scientist, and a consultant medical oncologist working within the Department of Surgery and Cancer at Imperial College of London. He is Director of Developmental Cancer Therapeutics at Imperial College, where he leads a translational research program focusing on the early clinical implementation of novel experimental anti-cancer therapies to the clinic, with particular emphasis on anti-cancer immunotherapy. He has led the inception of portfolio of first-in-class studies of immune checkpoint inhibitors in liver cancer. His extended research and studies supported by international collaboration have led to the qualification of novel prognostic and predictive biomarkers in HCC, which have been published in leading journals in the field of oncology. David lectures internationally in the field of molecular oncology with a specific interest in HCC and liver cancers, and acts as a reviewer for a number of peer-reviewed journals, including The Lancet, Cancer Discovery, and the Journal of Hematology, and many others. His prolific research output includes his high-impact publications in leading medical journals, establishing him as a thought leader in translational oncology. In recognition of his significant achievements, Dr. Binato has honored with the prestigious EESL Emerging Leader Awards in 2023. His clinical insights and visionary leadership continue to drive innovation in HCC care on a global scale. Please join me in welcoming Dr. Binato.
Well, thank you very much for such a kind and comprehensive introduction. I'm actually very glad to be here with you today to discuss about particularly around biliary tract cancer. So what I'll do, I'll try to share my slides. So please let me know if you can see them okay. Can you see them all right?
No.
Let me try again. Screen. PowerPoint maybe? Is it better now?
Can you move the slides, please? Maybe this is the first one.
Can you see the PowerPoint presentation?
You are sharing your background, I think. Can you stop the share and restart it again?
Okay. Let me do this again. Share content. Can you see it now?
Maybe the first one. Can you move the slide?
Yeah.
I think we see just only the background.
Yeah, I can see that as well, but I don't know why, because I am.
Is there any choice of the icons that comes up, like choosing from PowerPoint or choosing from other things?
I'm trying to do that. WebEx.
Other choices. You can see the other choices. It might help.
Unfortunately, I don't think I can. So I'm trying to share something else, but it doesn't come up with what I want. So I'm trying PowerPoint, but I can see you can't see it. It's all gray. Is there a chance I can see my slides and I am sharing PowerPoint?
Nothing comes up. Can you share your entire screen and then switch to the PowerPoint? Can you do that?
Yeah, that's what I was doing before.
Yes, please.
Right, until we solve. You can start.
لا لا شيء نحبته شيء لا نجرب قبل ما.
Unfortunately, I can see a screen that is not even mine, to be honest. This is not my screen, the one that I'm projecting now. It might be someone else.
I think we are waiting for your slides to come up at our end.
Okay.
And we'll share it from our end, I think.
Okay, that's fine. I think it's better. Perfect.
I think it's a matter of minute.
No problem. That's okay. So. Sorry for this. Sorry, you don't have my slides. Do I need to send them by email?
Yes,
Would you start your presentation, Dr. Binato?
I'm
You have
trying
the
to.
slides now.
You have them? Okay, sorry. Sorry, just a second. Let me close my email. Let me come back. Okay, fantastic. Yes, I can see them. So apologies for this. And again, thank you very much for inviting me today to talk a little bit about the role of anti-cancer immunotherapy in the management of patients with unresectable or advanced biliary tract cancer. Next slide. So first of all, I would like to thank AstraZeneca that has supported my participation to this meeting. And I will be talking a little bit about Imfinzi or durvalumab in the combination with gemcitabine and cisplatin, which is indicated for the first-line treatment of patients with locally advanced or unresectable BTC. Next slide. You can see that we've got, a long agenda looking at a number of aspects relating to this particular therapeutic indication. So let's move on to a background on biliary tract cancer. We all know that BTC is a poor prognostic cancer and has been for a number of years. The vast majority of patients, over 80% across different centers, are diagnosed in a stage where no cure is possible. And irrespective of the anatomical distribution of the disease, whether you've got intrahepatic, perihilar, or gallbladder cancer, which is a relatively different disease entity, the survival at 1 year is only 50%, and at 5 years becomes less than 5%. So we are all familiar with these figures. They have been haunting us for years, and there has literally been very little progress in the way we manage these patients for decades. Next slide. As you can see, the last positive trial in this setting was published in 2010, and I'm actually quite proud because the ABCO2 study is part of an academic collaboration in the UK, where a number of investigators led by Juan Valle were actually able to prove that the combination of gemcitabine plus cisplatin is actually able to improve the overall survival of patients compared to gemcitabine alone. And so that is really what established the platinum doublet in these patients. And there have been absolutely no phase 3 studies to improve on that standard, which, as we recognize, is really not fully satisfactory to bridge the gap between the need of extended overall survival of these patients and novel therapies. This is until 2022, when the addition of a PD-L1 inhibitor, durvalumab, in the TOPAZ-1 study was actually able to improve the overall survival of these patients. We'll look at the data, and as of 2023, the ESMO guidelines have adopted durvalumab as the only IO combination recommended with a level of benefit that is defined as substantial with a score of 4. Next slide. We'll talk a little bit about the TOPAZ-1 study. Next slide. So TOPAZ-1 was a fairly pragmatic study that actually enrolled a number of patients that we would give gemcitabine and cisplatin to. So anyone adult with, irrespective of the site of origin, intra-extrahepatic or gallbladder cancer, provided they were previously untreated with good performance status and had at least measurable disease. And as you can see, the study was a randomized control study investigating either gemcis for up to 8 cycles, or gemcis-durva with, again, a similar regimen. Now, one of the aspects that is important to remember is that at the end of treatment with the chemotherapy plus immunotherapy backbone, patients were allowed to continue on durvalumab maintenance, which is a novelty in this disease area, until disease progression or unacceptable toxicity. And one of the other things to remember is that durvalumab was given together with chemotherapy once every 3 weeks in the chemotherapy backbone induction phase, and then once every month at exactly the same dose in the maintenance phase to optimize patients' attendance. Primary endpoint, overall survival, with a number of secondary endpoints, including PFS, response rate, duration of response, and also, very importantly, safety and quality of life. Next slide. These are the patient characteristics. As you can see, as you would expect in a global trial of this kind, the baseline clinical characteristics were actually fairly comparable across the treatment arms. Particularly, I must say, the proportion of people with intrahepatic versus extrahepatic cancer, so about 50% of the patients were intrahepatic. In terms of biomarker status, so MSI high status, which is, as we know, a predictive marker of response to immunotherapy alone, was essentially very rarely present in these patients, as we would expect. So we can't really focus on the efficacy as exclusively marked by MSI high status in this disease. And another thing to say is that despite 50% of the patients being PD-L1 high, PD-L1 positive with at least the 1% mark, the patients were actually eligible to this treatment irrespective of PD-L1 status. Next slide. So let's move on to efficacy. Next slide. This is, yeah, perfect. So this is the median overall survival. And I wanted to present here 3 levels of analysis, just to give you the sense of one particular aspect. So the primary analysis, which is what enabled the registration of this trial, was completed in August 2021. And as you can see, the median overall survival in this particular patient group was extended significantly, with an increase to 12.8 months versus 11.5 months in the chemotherapy-only arm, with an hazard ratio of 0.8 and a p-value of 0.02. However, as it always and often happens in immunotherapy, some of the benefit of immunotherapy is really lying in the extended flat line of the curve. And as you can see, the subsequent analysis, the updated one, as well as the exploratory 3 years analysis, confers the same median overall survival essentially for the patients, but actually a higher hazard ratio, getting to up to 0.74. Of course, not formally tested because it was an exploratory analysis, but you can see that the benefit is extended in the long-term landmark survival endpoint of 23% at 24 months and 15% of that at 36 months. So these are figures that really mean doubling of the overall survival at those landmark time points in time. Next slide. So this was obviously followed by a subgroup analysis. One of the subgroup analyses that I was particularly interested in was the location of the disease. And as you can see, this led to essentially an equal representation of the group. So across all the pre-specified group, including PD-L1 expression, including site of disease, including geographical origin, the improvement in OS from the combination was observed across every single predefined subgroup. Next slide. So another aspect to keep into consideration is the progression-free survival. So we know that this is a chemotherapy backbone, and as you can see, the progression-free survival really is improved across the board with essentially an improvement that I think is particularly significant also in the maintenance phase. So as particularly at 1 year, the progression-free survival rates were again doubled compared to the GemCis alone, where patients were essentially observed without any active intervention. Next slide. And of course, another important secondary endpoint is the response rate. And as you can see here, the confirmed overall response rate by RECIST 1.1 criteria were significantly higher, 27% compared to 19% for standard of care. And the duration of response, the median time to response, was actually shorter in the combination with immunotherapy. So again, going to suggest that the combination of all these agents leads to a faster response, to a deeper response, and to a progression-free survival advantage, meaning that the patients would remain in response for a longer period of time compared to chemotherapy alone. Next slide. Another aspect that is interesting to say is the duration of response. So as you can see here, the duration of response was higher in the combination arm with durvalumab, with at least patients that remain in response at 12 months being 26% as opposed to 15% with placebo. Next slide. Another important aspect, especially when we combine novel agents to an established backbone, is patient-reported outcomes. And so one of the concerns in adopting new medicines is that, is the new drug going to be more toxic or leading to a deterioration in the quality of life? Well, I think the secondary endpoint is actually quite important. This particular Kaplan-Meier curve doesn't show you survival, but shows the time to a significant deterioration of the quality of life based on validated questionnaire, with a cutoff of 10 points to define when the patients would meet that particular event of deterioration. And as you can see, the median time to deterioration was actually not significantly different compared to the standard of care, with a trend towards improvement, suggesting again that these patients would not be worse off from the perception of quality of life compared to the standard chemotherapy arm. Next slide. And these are, again, it is another way of looking at patient-reported outcomes, the individual scores across each individual domain. And you can see what is it that we've actually measured on the PRO: emotional functioning, cognitive functioning, physical functioning, as well as also significant symptoms such as jaundice, abdominal pain. Next slide. So let's move on to safety. This is an important aspect. Next slide of the combination. So again, the rate of adverse events in the study, whether we consider all grades or grade 3 or 4, are essentially the same. A lot of them are attributable to the chemotherapy component. So particularly the rates of neutropenia, which are essentially the same, anemia, fatigue, decreased appetite. So some of these particular adverse events are essentially due to the chemotherapy backbone. And, one of the things that we are actively looking at sometimes on immunotherapy are things like colitis, pneumonitis, hepatotoxicity. You can see that the addition of PD-L1 monotherapy really adds very little, especially in the grade 3 and 4 toxicities. And perhaps not unsurprisingly, the percentage of people that discontinue as a result of an AE are essentially comparable across the arms, 9 versus 11%, not statistically significant. Next slide. So this is particularly the immune-mediated AI component. So I can say very safely that the adverse events that really worry us which are the 3 and 4, are actually less than 5% across the board. So, 2.4% is not a toxic regimen from the perspective of immunotherapy response and immunotherapy type of regimen. So this is an extremely safe combination to add. Next slide. So moving on to the dosing and administration, move on. There we go. So we have the induction phase, as we said before. So we need to start chemotherapy as we normally do with 3 weekly regimens together with Imfinzi, with durvalumab. And then we move on after the patients have completed the up to 8 cycles. Again, to the discretion of the investigator, a patient could receive up to 8. They then move on to a monthly infusion of monotherapy as a 60 minutes IV infusion. Next slide. There we go. Summary. So I think I managed to give you the sense, hopefully, that the addition of immunotherapy to an established chemotherapy backbone leads to a significant improvement for the very first time in over a decade to the overall survival, the key endpoint that we're measuring to define success from systemic therapy in biliary tract cancer, with 15% of the patients being alive at 3 years. I think with immunotherapy, particularly the long-term survivorship component of the success is very, very important. The other aspect to say is that the quality of life of the patients is not compromised, and the grade 3-4 adverse events, and I personally think particularly around the immunotherapy-related adverse events, are not necessarily happening at a rate that would concern us as physicians, as oncologists. So in a way, patients can safely start Imfinzi, durvalumab together with GemCis without any need for biomarker testing. This is a combination that is approved irrespective of PD-L1 testing. Next slide. With that, before I move on to a clinical case, happy to accept any questions.
Thank you, Dr. Benato, for this nice presentation. Any question from the audience? Yes, Dr. Hussam.
Thank you so much, Dr. Benato, for this sensational presentation. Given that you are interested in molecular oncology, this trial has demonstrated that PD-L1 positivity is around 55. Thanks, Dr. Benato, for the sensational presentation. My question is, we know that from this trial, we know that PD-L1 positivity is around like 55%, and the MSI high are like around 5%, and we do know from other case series that tumor mutational burden high is around 20%. Is there, and you have shed some light on the location of the disease, that patients with gallbladder cancer are being less responsive. Do you believe on molecular level or on any other level, there is a better way to identify patients who may benefit more from this combination in light of its financial toxicity? And thank you.
Well, thank you very much for the question. This is really an area of unmet need. There are absolutely no biomarkers that we can utilize to stratify for the benefit from this combination. And actually, in general terms, if you think about the chemo-IO landscape in general, there is very little, even in lung cancer or in other disease areas, that really qualifies very strongly for benefit from the combination of all this treatment, because obviously part of the benefit is driven by the cytotoxic component of the combination and part is driven by the PD-1, PD-L1 inhibitor. I think one of the aspects that I was always quite interested in is whether or not the oncogenic addicted component of the cholangiocellular carcinoma patients, in particular the intrahepatic, might be the patients that will derive more or less benefit. And I think the subgroup analysis that we have seen really do not demonstrate a differential effect on those biomarkers that we can routinely and we should routinely obtain in these patients. The gallbladder cancer question is also a very important and interesting one. I personally feel, and I'm not sure what is the practice in Jordan, but in my own patients with gallbladder cancer, very often the prognosis is poorer. And so you can say that the overall disease subcomponent, the intrahepatic ones, is significantly worse. A lot of these patients, get infection from an abnormal gallbladder. They require more difficult instrumentation to maintain the biliary tract patent. And so, anything that we say about this subcomponent of the population really needs to be put in the context of the fact that it is a slightly more disadvantaged population compared to the others. And so I don't think we can say that it's a molecular subtype, although we know that in gallbladder, the molecular markers are slightly less enriched, and it's, again, another reason for the poorer prognosis. But, we can't really make up a solid conclusion. And I think the subgroup analysis really demonstrate that the level of benefit comparing to the prognosis is still preserved.
Thank you. Dr. Marwan, please.
Thank you, Dr. Binato. If the patient has HER2 positive, would you prefer to start with anti-HER2 or durvalumab?
Definitely with Gemcis durvalumab, for sure. I think there is no evidence that HER2 targeted therapies in the first-line setting or any other molecularly targeted therapy in the first-line setting is necessarily better. And so my approach would be to potentially reserve any targeted combination to the second-line setting in these patients.
Yes, Dr. Arij.
Thank you. We know that targeted therapies work better in the intrahepatic cholangiocarcinoma rather than extrahepatic. Any data on durvalumab on this context?
Yeah, so there have been sub-analyses looking at the molecular phenotype of these patients. And as I said before, this is something that I was really, really interested in looking at when the data came about. And I think irrespective of the molecular phenotype of the patients, unfortunately, I don't have slides on that, the benefit is preserved, especially if you think about the the FGFR2 amplifications, which are obviously, one of the key actionable drivers, or the BRAF V600E mutations. I think it's important to note this because very often, there is a perception that molecularly targeted, molecularly driven tumors are perhaps a little bit more resistant to immunotherapy. But again, as I said before, this is not an immunotherapy only study. It's chemotherapy plus immuno. So it makes sense for these molecular markers perhaps not to play a role necessarily in the resistance to immunotherapy alone.
Yes, Dr.
Oh, thank you, Dr. Pinata, for your presentation. I just have a comment and a question at the same time. So going back to the statistics in the Topaz trial, it seems that at least more than 50% of the patients were Asians in the ethnicity, probably less than 40% of the patient had PD-L1 negative disease. We don't know the exact proportion of patients who harbored the aforementioned and relevant genetic mutations, such as the IDH1, FGFR, NTRK, or HER2. To me, I believe that if you look at the Kaplan-Meier curves, when you see that step look, it feels like there is a subgroup effect. So I would believe that some of these benefits are derived from the population of patients who had a PD-L1 positive disease and from the proportion of patients who are Asians, because historically Asian people respond better to immune checkpoint inhibitors than non-Asian population, as you can see also in the first plot. So I believe in precision medicine, personalized medicine. The cost of integrating durvalumab in the frontline therapy of BTC is not a little. So what I believe that even though AstraZeneca did not choose to use or to integrate the group of patients who are likely responding to pembrolizumab, or I'm sorry, durvalumab better than other patients, but to me, I still feel that subgroup effect. And we may encourage AstraZeneca to probably incorporate that subgroup of patients who might benefit more from the durvalumab other than the other subgroups. Thank you.
So in answer to your comment, I think it's true that in a global study, you have to be mindful of ensuring that recruitment for a study like this respects the characteristics of the individual patient populations. And so inevitably, you know, with Asian centers having been involved, particularly Korea, you know, it's inevitable that there will be a mismatch in terms of you know, the type of patients. And I think we have seen that 50% of the patients were intrahepatic. The counter argument to this comment is the fact that, well, you know, we've been using GemCis anyway, irrespective of the location of the tumor. And the hypothesis of the trial was to look at an improvement in overall survival by the addition irrespective of the origin, so in an all-comers trial. I would support the idea of a subgroup effect if the proportional hazards were not met. But I think if you look at the rates of events across the two groups, you can see that there is a separation of the curve and the rate of events is preserved across every single segment of the population. There are a lot of things, and I agree with you on this, that we don't know about this tumor. And I do believe that there might be perhaps some more immunogenic tumors. The challenge in clinical practice is how do we identify those? The second brief comment is that we now have real-world data on the utilization of this combination. Data particularly organized by Italian centers, so Andrea Casadei-Gardini, who published a report very recently, where again, the survival figures are essentially in keeping. So even in Western patients, you know, we don't get much more than that median overall survival, but I think the expectation is that the uptake of this will produce results that are consistent with the trials. The fight is not over yet because we are not curing these patients. And I think we need to really be thinking about what the next steps are. So in that, I completely agree with your comment.
Yes, Dr. Majdi.
Thank you for the nice presentation. You know, a few percentage of those patients have hepatocellular carcinoma combined with cholangiocarcinoma. Is there any notification about regimen?
That's a really good question. These patients were not included in TOPAZ and were not included in any of the other clinical trials for HCC. I must say that very often it has happened to me that if a patient really has a dual pathology, we would potentially think about using this regimen, GemCis and Durva, rather than any HCC-specific regimen, because you will leave the cholangio in the hope that, you know, you will leave the cholangio component treated, as well as have some effect on the HCC component with durvalumab, which we know is also effective in HCC. This is completely, you know, my personal opinion. It's not supported by any data, and it's just my own clinical practice.
Okay.
Last question. Do you think that you have any evidence, for combining, for benefit of combining immunotherapy, chemoimmunotherapy with targeted therapy in the era of, in the presence of actionable mutations and tumor-driven mutations in the future, in the first-line setting?
That is a really good question. I think there might be scope, but the problem that I see with this is that bringing molecularly targeted therapy to the first-line setting has been really, really difficult, even in highly prevalent mutational profiles such as FGFR2 amplification. So the first-line pemigatinib study, for instance, has been extremely, extremely difficult to recruit to on a global basis because you need to wait for the molecular report to be back. A lot of the patients do not really have adequate histology. The benefit of using an approach like the TOPAZ regimen is that you can request, and you should request, all the molecular markers. You start with a broad approach that treats the patient irrespective of the molecular marker status, and you use that time to investigate the patient and try and make decisions in terms of what to do next. Not all the patients respond to this regimen. Some patients, unfortunately, primarily progress or have a short benefit, and so those are the patients that should be prioritized for a good second-line therapy.
Okay, one last question, please. In patients who did not receive Durva in the first line, can we give it in the second line?
Unfortunately, it's not something that we have approved. I've never had the opportunity of giving immunotherapy in second line, for instance, for FOLFOX. And unfortunately, I have had patients that, let's say, had a great response to GemCis before the treatment was approved, I think I tend to refer these patients for clinical trials, knowing that immunotherapy can potentially benefit some. But there is unfortunately very little data of immunotherapy post-chemo. The responses for monotherapy are actually very, very low, in the region of 5%. You can look at the Pembro data. It's really dismal, the prognosis, unless you are very lucky and you've got one of those tumors with TMB high, as we were saying, or MSI high, but these are extremely rare in my practice. I've not seen very many.
Last question. Do you think we are talking still about modest improvement in survival in biliary tract cancer for adding durvalumab compared to HCC?
That's a really good question. I think the two diseases are completely different. And when I saw the initial median overall survival results from TOPAZ, I was happy that finally we had a novel treatment option and that the cost to the patients was actually fairly minimal, and the practicality of delivering this treatment, doesn't really change what we normally do, apart from maybe thinking about the maintenance phase. I think BTC is not like HCC. They're two completely different diseases, and even a small but significant improvement should be accepted as one, because otherwise we wouldn't be doing clinical trials and we wouldn't be advancing the field further. I wouldn't say modest. I think it's clinically significant. Numerically, it's lower compared to other disease areas like lung, HCC, but this is the disease that we are treating. It's an aggressive disease, and it puts us in the spot to try and make these standards even better for the future. So design more clinical trials now that this is a novel standard of care.
Okay. By this, is clinical case?
I'm not sure if you have the time.
Yes, please. You can proceed with the case. Yes.
Yeah, is that still okay despite the time? I'm just checking that I'm not running over with your schedule. Yeah, perfect. Okay. So if we can move on, I just wanted to give you an example of a clinical case of a patient that we have treated. I will just go very briefly. I prepared some questions, but perhaps I can ask them at the end. So if we can move the slides, please. So yeah, these are my disclosures. So move again. Next. Okay, so 49-year-old male that presented, software programmer presented to emergency. So previously fit and well, no history of chronic liver disease, and presents like many patients with cholangiocarcinoma with nausea, weight loss, and painless jaundice. No unwell contacts, no significant family history. At the age of 49, no other significant drug history. So he gets admitted for this painless jaundice, and we can have a look at the slide with the initial investigations. So immediately what is done is an ultrasound scan to investigate what you can see is a highly abnormal liver function picture. So with the bilirubin as high as 162, fairly low albumin, increased ALT and AST, and a CA 19.9 that is actually quite worrisome, 1,600 in a 49-year-old. So the liver echo texture is normal. There is extensive intrahepatic biliary dilatation, as you can see from the ultrasound, and a 53.43 focal liver lesion. Next slide. So I will skip the questions perhaps. So let's move on to the next slide in the interest of time. So we did a CT, cross-sectional imaging, as well as an MRI. You can see how ugly that picture is, especially the CT picture with a very indistinct lesion right in the middle of the liver. Perhaps a little bit better demarcated on the MRI. You can see that the characteristics are not typical for HCC, but already hypodense, so suggesting either a metastasis or a primary adenocarcinoma. You can go to the next slide. Workup was, of course, to get histology. So you can see the ultrasound-guided biopsy that we performed, very typical for an adenocarcinoma. You can see the biliary ductals, the hepatocellular markers, GPC3 and HEPA1 negative, CK7, CK19 positive. So we are convinced about the diagnosis of a primary biliary adenocarcinoma. Move on to the next. So we did NGS. As you can see, this is a profile that is basically unhelpful from the perspective of treatment. There is an ER2 mutation, there is a CMET amplification, but nothing that we could actionably target. So we make the decision, next slide, to proceed with treatment. The problem was the very high bilirubin. So bilirubin keeps rising on treatment. You can see the figures up to 240 millimoles per liter, and the liver function also becomes a little bit more deranged. Next slide. This is when the patient was an inpatient. So these are the things that we were considering. What do we do? ERCP, PTC, steroids, or we could start chemotherapy or even local therapy for this patient that doesn't seem to have any evidence of metastatic disease. I'll give you the answer straight away in the interest of time. So we tried, next slide, we tried to obtain adequate biliary drainage. This is something that we always have to aim for in these patients. The problem is that bilirubin less than 1.5 is always an exclusion criterion in any chemotherapy study. And there are, as we know, lots of multicausal etiology, luminal, neoplastic. It's a poor prognostic subgroup, the patients like this kind. And so we can see in the next slide what we did. So we gave some high-dose steroids. We did a PTC. I normally tend to cover with some antibiotics and ursodeoxycholic acid, and then we immediately commenced on chemotherapy. Next slide. So these are the slides. We can skip this and move on to the follow-up of the patient. So very luckily, the patient's bilirubin comes down with all these interventions. And actually, quite interestingly, this is the CA19.9 levels that we can see are nicely drifting down on the chemoimmunotherapy. Next slide. So these are the images. You can see that there is a very significant reduction in the size of the tumor from the original scan when the patient presented to the follow-up scan. Next slide. We saw actually an increased response also in the maintenance part, which I think might go and explain why in TOPAZ 1 we've actually seen a continued benefit in some of these patients. Next slide. So once we reached this level of response, we started thinking, what are we going to do next? And so I was thinking we could either continue on durvalumab, we could stop there, we could think about other options such as resection or even SERT, which is something that we do in our center, despite not being a lot of trial evidence for it. Next slide. And so at the end of the day, these are the things that I was thinking about. If you could click on the next slide again. And again. So really, you have a lot of different features in this patient. It's a well-differentiated tumor, young patient, no mets, no comorbidities, low biomarkers. So, some of us in the MDT were like, we need to push. Others, we still are anchored to the bad prognosis of this patient. So 7-centimeter tumor, central lesion, someone that cannot be primarily resectable and no molecular alteration. So, which subgroup features are we picking, the good ones or the bad ones? We can move to the next slide. I'll tell you, we debated quite a lot, and our surgeons were actually happy to try and offer radical therapy to this patient. So it was resected. We did show actually a poorer differentiation on resection with extensive microvascular and perineural invasion and also serosal invasion. So very extended tumor. It was not an easy decision for us to proceed with surgery, but we counseled the patient, and the patient preferred this way. Next slide. So, we were looking at what to do next. So do we observe? Do we resume durvalumab? Do we give adjuvant therapy, either chemo or radiotherapy? We can move on to the next slide, and I'll tell you how I personally manage this case. So, the only evidence to support what we do after resection is the BILCUP study. The BILCUP was run when there was no durvalumab available, and in a patient that was not going to be treated in a inverted commas neoadjuvant or conversion therapy way, just like this patient. So we can move on. But, in absence of any more evidence, next slide, we decided to continue and treat with potentially consenting with capecitabine. Unfortunately, what happened is that the postoperative recovery was quite tough for this patient. There was evidence of a collection, as you can see here, and there was that particular area of cystic collection with enhancement that seemed to be quite suspicious. Next slide. So I started adjuvant capecitabine, sorry, previous slide. But unfortunately, the area that initially was thought to be just a simple collection manifested itself as being, unfortunately, an area of early disease progression. And so we had to be thinking about second line, and we can move on to the next slide. Again, evidence-deprived area, especially after TOPAZ 1. In a patient like this, the decision would be to give oxaliplatin-based chemo with, unfortunately, a very low median overall survival benefit of about a month. We can move on to the next slide. And so this is on second-line chemotherapy. Unfortunately, fairly poor response at this stage with this extensive collection plus, unfortunately, neoplastic invasion. Next. So this is unfortunately the history of the patient with worsening bilirubin levels despite second-line chemotherapy. So, really, this is a bit of a dilemma for us. We can move on to the following slide, which will conclude my case, I think. Next. What are the learning points? So, in a case like this, we've had an excellent response to first-line treatment, something that we hardly ever see. I think this is where the benefit lies in patients. You can see that there was literally no benefit from adjuvant and not even from second-line therapy. We should have probably discussed, what to do with the development maintenance. Was it safe or wise to stop and go for surgery? We will never know. Radical therapy, in a young fit patients, very often we want to push, but what are the risks in terms of continuing on treatment? Could we have done differently? Should we have done CERT instead of surgery? I mean, these are really open questions on a case of this kind. The only aspect of certainty is the really good response to first line and the fact that this patient really had an excellent first-line outcome, which is probably where the survival was and the natural course of the disease were most likely changed. And with that, I thank you very much for your attention.
Thank you, Dr. Pinato. The floor is allowed for 1 or 2 questions, please.
If I may ask, the resection was R1, not an R0 resection. Have you considered like local radiotherapy or for this patient? Thank you.
That's a really good question. The UK practice is not really in favor for local radiotherapy. I can tell you because I've got 2 passports. I've got an Italian passport and a British one. So if I were to use my Italian passport, I would have probably used radiotherapy as an adjuvant because it's very much practiced in R1 resections. In this case, we didn't. There was also the problem of the patient becoming septic again quite quickly and then literally within a month manifesting with recurrence disease. So, yeah.
Dr. Abdullah. Okay, thank you, Dr. Pinato, for your presentation, and we hope to meet you in Jordan.
Would be fantastic. Thank you ever so much. Bye-bye.
Thank you. Thank you.
لا أنا على الواقف. بختم بآخر دعوانا الحمد لله رب العالمين. أشكر الحضور، أشكر الشركات الداعمة، أشكر رؤساء الجلسات، أشكر المتكلمين على هذا الإنجاز. مؤتمر رائع، توبكس رائعة، متحدثين رائعين، وحضور أونلاين كمان فوق المتصور، زائد الحضور الآن. بتشكركم اللي جاوبتوا مع دعوة الدكتورة غدير، وأنا دعمت دعوتها إنه بحضوركم آخر الجلسة لأنه تتونس بوجودكم معنا، وأسترازينيكا بتتونس بوجودكم معنا. أسترازينيكا كانت دائما سبورتيف إنا لجمعيتنا ونشاطاتنا، وإحنا بنشكرها على هذا الدعم المتواصل. نشكر بقية الشركات، نشكر روش، نشكر الحكمة، نشكر جانسون، نشكر نوفارتس، مين كمان آخرين، ونوفو، نشكر كمان نوفو. حكمة حكيت فيها وحقيقة يعني الاكتيفيتي هاي سهير قديش هاي حسبوا لنا اياها؟ كم ساعة؟ 6 ساعات وسبيكرز 8. فالشهادات موجودة مع سهير مع هيفا، والشيكات موجودة مع سهير، والعشاء موجود خارج القاعة إذا ما وداخل القاعة. إذا ما كفى كمان حجزنا بمرج الحمام ولا برج الحمام. فبراحتكم، وين ما بدكم تعشوا انتوا تدللوا، والله يعطيكم الف عافيه. شكرا لكم.